Good morning and welcome.
Actually during the meeting.
Sorry. Good morning and welcome to the 12th hearing of Portfolio Committee 2's inquiry into health outcomes and access to health and hospital services in rural, regional and remote New South Wales. The inquiry is examining health outcomes, access to services, patient experience, planning and capital expenditure in rural, regional and remote New South Wales. Before I commence, I'd like to acknowledge the Gadigal people who are the traditional custodians of the land on which this Parliament sits, and I'd also like to pay respect to Elders past, present and emerging of the Eora Nation and extend that respect to Aboriginals viewing the broadcast today, wherever they may be. Today's hearing is being conducted virtually. I would ask for everyone's patience through any technical difficulties that we may encounter. If participants lose their internet connection and are disconnected from the virtual hearing, they are asked to rejoin the hearing by using the same link as provided by the committee secretariat. Today, we'll be hearing from a number of important stakeholders based in and around Walgett, Broken Hill, and surrounding areas, including local councils, private organisations, nurses, private individuals, Aboriginal health services, and the Far West Local Health District. I'd thank everyone, or I do thank everyone, for making the time to give evidence to this important inquiry. Yes. I just might go off script here for a moment and just acknowledge that our plan had always been in these last few hearings to actually visit these important places around New South Wales, like in the northwest and Broken Hill. But because of the COVID emergency and the need to adjust to the requirements around that, we had to make a judgment now some weeks ago that we would have to either participate in a remote fashion and collect our evidence that way, or potentially run the risk of running into the end of the year and early into the new year and potentially even miss that opportunity of getting to our important witnesses in these remoter parts of the state. So in terms of Walgett, Broken Hill, particularly our important evidence from the Indigenous Health Services, I'd just like to acknowledge that it was not our first preference at all to be doing these last couple of hearings in this way, but nevertheless, with what's been before us, we've had to be considered in our judgment about how we go about collecting the evidence, and as I said, whilst this is not our first preference, it's quite adequate and suitable, and indeed we've been collecting evidence over the course of the year in some instances remotely, so all the evidence will come in uninterfered and be used by us in conjunction with obviously submissions that will contribute to the development of the report and the recommendations, but I just want to acknowledge that. Before I commence, I'd like to make some brief comments about the procedures today. Today's hearing is being broadcast live via the Parliament's website. A transcript of today's hearing will be placed on the committee's website when it becomes available. In accordance with the broadcasting guidelines, media representatives are reminded that they must take responsibility for what they publish about the committee's proceedings. While parliamentary privilege applies to witnesses giving evidence today, it does not apply to what witnesses say outside of their evidence at the virtual hearing. I therefore urge witnesses to be careful about comments you may make to the media or to others about after you complete your evidence. Committee hearings are not intended to provide a forum for people to make adverse reflections about others under the protection of parliamentary privilege. In that regard, it's important that witnesses focus on the issues raised by the inquiry's terms of reference and avoid naming individuals unnecessarily. All witnesses have a right, of course, to procedural fairness, according to the Procedural Fairness Resolution adopted by the Legislative Council in 2018. And finally, there may be some questions that a witness could only answer if they had more time or with certain documents to hand. In these circumstances, witnesses are advised that they can take a question on notice and provide an answer within 21 days. Finally, a few notes on the hearing etiquette to minimise disruptions and assist others, particularly including the Hansard reporters involved in organising today. Can I ask committee members to clearly identify who questions are directed to And could I ask everyone to please state their name when they begin speaking? Could everyone please mute their microphones when they're not speaking? Could you please remember to turn your microphones back on when you're getting ready to speak? If you start speaking whilst muted, please start your question or answer again so it can be recorded for the purpose of transcript. That's important for Hansard. Members and witnesses should avoid speaking over each other so we can all be heard clearly. And also to assist Hansard, may I remind members and witnesses to speak directly into your microphones and avoid making comments when your head may be turned away from them. So we welcome our first witnesses this morning, and I'll go through them and just provide a bit of information, and then we'll have you as witnesses either sworn or affirmed to give evidence. So can we start? And perhaps we'll just, if we do it in this order, so Councillor Woodcock first, the Mayor, I'll get you to identify, obviously, your name, your title that you're appearing before this inquiry today, and swear either an oath or an affirmation, whichever you prefer, Mayor, and the words of which you've chosen should be before you. If you don't have them for some reason, please yell out. We'll provide them to you. So, Councillor Woodcock.
Yes, I'm Ian Woodcock. I'm the Mayor of the Walgett Shire Council, and I will take the oath. Thank you.
Thank you.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you very much, Mayor. Mr. Urquhart, same. Name, position, title, either the oath or affirmation, whichever you prefer. Please proceed.
Michael Urquhart, General Manager, Walgett Shire Council, and I take the oath.
Thank you.
I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you, Mr. Urquhart. And to Councillor Turley, Mayor, Broken Hill, good morning. Name, position, title, and oath or affirmation. Thank you.
Dari Turley, Mayor of Broken Hill, and I'll take the affirmation. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much, Mayor Turley. So what we'll do, we'll provide an opportunity for opening statements. Can I acknowledge that with respect to the Walgett Shire Council, we have received, thank you, your submission to this inquiry. That's noted as submission number 341. It's been processed and stands as evidence to the inquiry and has been uploaded onto the inquiry's webpage. And equally, Mayor Turley, thank you very much for the Broken Hill submission. It stands as submission number 398 to the inquiry. Likewise, it's been processed and stands as submission to the inquiry and has been uploaded to the webpage. So perhaps we'll start just in order then, as I've got it in front of me, with Mayor Woodcock. Would you be making the opening statement, Mayor?
I would ask our General Manager to do that. Thank you.
Thank you very much, Mayor. Mr. Urquhart.
Thank you, Mr. Mayor. Firstly, I'd like to thank the New South Wales Government for affording Walgett Shire Council this opportunity to provide further information in the inquiry into health outcomes and services in regional, rural and remote New South Wales. Walgett Shire has a population of 6,100 people dispersed across 22,000 square kilometres in far northwest New South Wales, with an Aboriginal population in the order of 2,500. Council's primary concern with the health services to the region is the replacement of face-to-face primary care with a telehealth platform. Councillors and community believe telehealth has its place in the health system as a tool to assist general practitioners delivery of specialist services or assessment of minor illnesses by nurse practitioners, but it should not be seen as a replacement for face-to-face primary care by a general practitioner. It's a known fact that people living in remote New South Wales do not enjoy the same health care as their city cousins living in more densely populated and serviced metropolitan areas of New South Wales. Our remote shire experiences poorer health, higher chronic disease ageing population and a lower life expectancy. Quality medical services in rural remote towns are an essential element for every individual's quality of life and the ongoing economic sustainability of our communities. A reduction in the basic face-to-face medical services is a retrograde step, one that increases isolation, remoteness for residents, and a widening of the gap between the haves and the have-nots. For residents living in the Shire, it's a terrifying situation when one becomes seriously ill, knowing that face-to-face primary care is limited and emergency specialist services are 3 hours away in Dummer. In summary, the community asks they be properly consulted with any future changes to health services in Walgett Shire. The New South Wales Government, A, design and implement a new GP recruitment and training program for rural and remote communities, and B, increase the funding for rural and remote health services, C, increase primary health care general practitioners in rural remote areas. Once again, I thank you for this opportunity.
Thank you, Mr. Urquhart. That's a very good opening statement, which lays out a lot of important groundwork that I'm sure is going to lead to questions of obviously both yourself and Mayor Woodcock. Could I move now to Mayor Turley? Can I invite you, please, to make your opening statement?
Thank you for the opportunity. I'd like to acknowledge that I am on the land of the Willakali people of the Barkindji Nation, and I pay my respects to elders and acknowledge the ancient wisdom that they share. I'd also like to acknowledge all the doctors, nurses, allied health workers, cleaners, administrators, gardeners who all support the delivery of health in the Far West. The Far West, Broken Hill City Council welcomes this opportunity to be able to be part of this inquiry. We see Broken Hill as a key centre for residents in the Far West, the whole Far West, and it provides services that cover over 196 square kilometres. I'm going to go straight to the point and say that, you know, the issues for us is always around recruitment and retention for our workers and how we care and look after those workers when they do come and work in the outback towns. The other part that really concerns us at the moment is the cross-border referrals. We are so challenged under COVID about accessing health services that I cannot predict what the impact of health will be for our community. The stories that have been told to me about delayed services is beyond my capability at the moment. Every day, someone gives me examples of melanomas not being removed, about to see a cardiologist but no service and can't go to Adelaide because of the cross-border community issue. What we're recommending is an MOU with South Australia so nobody disadvantaged. And I have to repeat this, we will not know the impact of COVID until about 3 or 4 years down the track or more. And I am beyond thinking about what's been delayed. Particularly, I want to acknowledge that a young mum who's trying to get assessment for their child for autism. For people sitting in Sydney, you can't get an assessment. You will go to your next key stakeholder and or NGO in the next suburb. This person has been waiting over 12 months. This is 12 months delay. Even the Royal Flying, the Far West Health Service cannot help them. We need immediate review of what is happening for the delivery of health in the Far West. I also want to acknowledge the delay in specialist care. I was told about one incident where a person had a referral. They've been instructed, and I think it was 2019, their referral was, they were told by the specialist clinic that they will be moved down the list because priorities come in. So it may not be to 2023 that this person is seen. And I want to say, is this acceptable under our health service? I keep hearing that the further you are, the more challenges you have in the delivery of health. And I want to acknowledge Walgett and all they are undertaking, because telehealth is supposed to supplement. But for us, we want to make sure that we start to look at seriously look at the delivery. Can I also add that we believe we should be recommending a drug rehab centre for Broken Hill. To access drug rehab services is, and it's in our submission, is challenging beyond compare. Again, if you're in the city, it would be easier to access a health service, access a drug and alcohol health service. The other part that we would like to share, and I'll say in the opening statement, is that our community deserve to know the data that reflects our service delivery. We deserve to know what is actually being delivered, how it's being delivered, and what health improvements there are. I would have to say that the annual report delivered, recommended by New South Wales Government, that the local health districts would present an annual report. The way it's presented during the day, you can't attend if you're working. The data is not easily accessible to the everyday citizen, and I can tell you there are many people that would like to know the good things that we deliver and the challenging things. And I particularly want to acknowledge Mrs. Coles, who is probably watching this today, and the fact that we need to deliver care for all. Thank you for the opportunity.
Thank you, Mayor Turley. And just before I open up to questions, just on behalf of the committee, can I express my thanks and gratitude to our local government representatives, particularly our mayors and councillors, general managers and other staff who've been involved in providing material as submissions to this inquiry, and particularly for the oral evidence they've given at our public hearings, because some of the most clearly articulated and detailed evidence we've received through both submissions and oral testimony has been from local government, which I think in some sense more than anyone as an or any group as an organisation have provided such clarity into what are so many of the challenging issues regarding the provision of delivery and the health outcomes of health with respect to regional rural New South Wales. So I just wanted to put that on the record, because our inquiry would be much impoverished but for the provision of all that most valuable evidence from our local government representatives, particularly, as I said, the mayors, the general managers and their staff. So we'll open up for questioning now, and it'll be roughly 8 to 9 minutes for each of the groupings around the table, which is opposition, crossbench and government. So we'll commence with opposition. The Honourable Walt Secord.
Thank you. I'd like to start with Councillor Turley. Thank you for making a submission and making yourself available today. Councillor Turley, what's the current status of preparedness for COVID in Broken Hill? With Sydney is now grappling with the South African strain. What's happening in Broken Hill at the moment?
I haven't been briefed by the Chief Executive about their preparedness, but can I just acknowledge Dr. David Lau and our Public Health Unit have been doing an incredible job during COVID. But, you know, I'm very concerned about anybody understanding the data around vaccinations for the Delta strain. I was very concerned that there wasn't a lot of planning and very concerned that there wasn't resources put in to the area healths across the whole district, but particularly the far west. Back in when we've seen the strain develop in Sydney, I've been very vocal about that. We've certainly got on top of when I was asking what's the vaccination rates, nobody knew, you know, and everybody was willing to pass the buck onto someone else. My thing is data is gold. You should understand data. It took a while to people to get that. I should acknowledge that I worked in health for 41 years and I have a little bit of understanding about delivery of health services for the area. I covered at times over onto Broken Hill, but I was shocked and angry to understand at that time for Delta that there was no understanding of vaccination rates. So I'm challenged at the moment. I have not been contacted by the Chief Executive to date. I hope that that will happen to tell us their preparedness around this new strain. And certainly the Public Health Unit, we've got some absolutely stars there that are working 24/7 But I think at times the communication needs to improve.
Well, what are the vaccination rates in Broken Hill at the moment, and are people getting boosters?
Yeah, no, boosters are just starting. Our vaccination rates, once people got the understanding it's the priority, our vaccination rates are incredibly high. My challenge would be is the, we were targeted by Clyde Palmer, by his groups to try and get people to stop vaccinations. And, the misinformation that he was leading, he actually sent flyers to our communities, I think 3 times, maybe 4. And so we still have some hesitancy in some elements of our community.
Sorry, Ms. Turley.
And that's a concern.
Sorry, Ms. Turley. So Clive Palmer's group targeted Broken Hill with an anti-vaccination message.
Yes, and misinformation. And he changed the image of the flyer. So at first it was yellow and black in their party colours, and then he changed it to looking like a medical flyer. So it was white, blue and red. And I was just outraged. I just thought, this is just unacceptable.
How did you feel as a health professional when you saw that?
I was shocked, and I found that do they understand the consequences? What is the intent of sending a flyer to the most vulnerable community? This is a community that has 12% Aboriginal people living in the whole district. What is the intent of sending that flyer? I was just outraged, and my thoughts were not only for those community people that would read it and think it's a medical flyer, but for our staff in the ICUs and the emergency department, there is potential such a risk.
Thank you. Ms. Turley, if time permits, I'll come back to you. I'd just like to speak to the gentleman from Walgett. Now, gentlemen, you talked about, just correct me if I'm wrong, your health facility in Walgett, is it an MPS?
I know what that might mean.
Oh. Are you?
It is.
Oh, yeah, it is. So you talked about, and you used the word in your opening statement, I think the general manager, Mr. Arkert, mentioned that it was terrifying. So your MPS, if there's a problem and you can't receive medical care at the MPS, where's the nearest major health facility? Dubbo?
Dubbo.
Yes, that's right.
So now we've heard evidence to this inquiry that there have been other MPSs, district hospitals in Western New South Wales and Southern New South Wales, where there was a lack of a medical doctor at facilities. Do you have a medical doctor at your MPS 24/7?
No, not 24/7.
When do you?
They're on call.
Sorry, gentlemen.
They're on call if they're available.
What do you mean? Can you explore this a little bit for us? When you say if they're available, what do you mean?
Well, there may be times when there is no doctor here.
When you say here, you mean in the town or in the hospital or in the region?
In the hospital.
In the hospital. So what happens when there's no doctor? And now you're quite a big. You have 6,100 people in your area. So no doctor for an area like that. What kind of presentations would occur at the Walgett MPS?
The MPS, we have it at the hospital. We also have the Walgett Aboriginal Medical Service, which is a very good service that supply medical services to the town itself. And quite oftentimes they may have a doctor available, which they somehow or other they borrow to go to the MPS if there's no one up there. It happens there. It happens in Lightning Ridge, exactly the same thing. Oka now have the contract to look after the MPS, and they have fly-in, fly-out doctors all the time. Like they're here for a week or a fortnight at a time, and they're gone. WAMS did have, or RAMS had the service in Lightning Ridge, and they lost the contract for the VMO rights because Oka took that over. So I think we're down to only one doctor there at the moment who services the town, so they're available, but they don't go to the hospital.
So what do patients do? They have to rely on a nurse in telehealth?
They do there, which a lot of people don't seem to like that idea because they don't feel as if they're getting a proper consultation, because sometimes the the line might drop out. Our signals are not real bright at times, and there's a lot of confusion about it.
2 minutes.
And I know one of our councillors had to go, actually was down to Canamble, I think it was Canamble last week. I'm not sure it was Canamble. I think it was Canamble. He had to go and have, no, it was here in Lightning Ridge. He had to go and have a telehealth thing done, but he said it was disgusting, and he's a medical man himself, so he said it doesn't work. And people don't feel if you're getting the proper treatment. If the doctor's there and it's there to have a look at you and say, have a look at this, or take, whatever they need to do. Sometimes it doesn't work if you're looking at it on the screen.
So do you find that people in the community, because they have to resort to telehealth, simply don't get medical treatment?
Well, it appears that way, yes. They don't like it. They don't want to have anything to do with it.
Now, gentleman from Walgett, you mentioned the general manager, Mr. Arkert, mentioned in his opening statement there was a desire from Walgett Shire Council to be consulted. Can we explore that a little bit? What were you talking about? What were you referring to? I would assume that the local council would be consulted by New South Wales Government and Health. What were you referring to?
When the tender for the health services at the MPS went out, we weren't consulted as to what was going to happen. And at Collarenebri, which is another small town in the LGA, it was being cut back to, I think, 1 day per week to have medical services available. Lightning Ridge was being cut back to 3 days a week. And I'm not sure, I can't remember what it was for Walgett, but I think it may have been 5 days a week instead of 7. So we weren't consulted with any of this, but it was just by chance that we found, or one of our counterparts was able to get hold of the tender and to find out actually what was being promoted by the Western Area Health and the reduction in face-to-face primary care services.
So this was just dropped on you guys, no communication, you just found out that health services were being cut?
Mm-hmm.
We found out by accident.
By accident. Okay.
We'll need to move on.
Thank you, gentlemen. Hopefully I can return if time permits.
The Deputy Editor, Honourable Emma Hurst.
Thank you, Chair. Just following on from the Honourable Walt Seccord's questions about the services being cut, and I know that in your submission you mentioned that you were concerned there was going to be a 53% reduction in primary care services in the area, but I also note that submission was written almost a year ago now. Can you give us an update on what's happened in the past year? Has there been any changes or has anything happened since you sort of wrote that submission about the 53% reduction?
Well, RAMS, we've been very fortunate that RAMS, Rural Remote Medical Services, have stayed in all 3 centres. They've left, or they had no doctor here for a while in Walgett, and in Lightning Ridge, I believe, Mr Mayor, they're down to only 1 doctor from RAMS. Oka also have their doctors there. So we're probably about the same as what we were before, but it certainly wasn't a drop of 53% in the, that was the final outcome.
Okay, and are there concerns going forward that there might be more drops or more reduction?
Well, the concerns going forward are that we'd like to be consulted if there's to be a change in the health services for Walgett Shire. And in fact, those 3 statements that I made there with, the designing and implementing a new GP recruitment for rural and remote and increasing the primary health care.
So you're concerned that there might just be a sudden reduction in primary healthcare services to the area and that it will just sort of be announced after it's been done? Yeah.
That's what we're frightened of.
Yeah.
And it does happen because you might have 2 doctors this week and next week you'll have none.
Yeah, yeah. In your submission, you also note that there are 6 children in the Shire with serious heart conditions. Do you know how they're able to manage these conditions despite the lack of specialists and access to care generally?
Is that right? Yeah.
I know one child here from Melbourne. That little girl had to go to Sydney here a while back. So there's no services, I don't believe,
Rick wants to follow up on that
locally for them, but they actually travel away to Sydney for specialist care.
So most of them are having to travel to Sydney for any kind of attention.
Yeah, and then in the interim, they would, if needed, they would have to be flown to Dubbo.
Yeah, and
that's the biggest concern, that if anything happens to anybody out here, and, you know, they don't like to touch people, they just put them, you know, assess them, and then they fly them out to Dubbo, you know, and that's quite frequent.
And is that causing a lot of stress for these families, obviously with having young children that have heart issues?
It certainly is.
Thank you. I've got a question just for Mayor Turley. Mayor, you mentioned in your opening statement that you were wanting to have a memorandum of understanding with South Australia, and I was wondering if that's progressing in any way, or if that's something that you're looking for assistance with.
That's something we're looking for assistance with. It is, you know, in the last 2 years under COVID is beyond our challenge, but it's something that New South Wales government will have to be the lead for that. But it is every day our access to South Australia changes. We've had people turn back at the border at 5, 6 o'clock at night, which means the border crossing isn't actually on the border. It's actually 3 hours from Broken Hill. And so you travel into South Australia, you know, you're travelling there and you arrive around 6 o'clock to go through the border check, and all of a sudden the border's closed. You're travelling back in the dark to Broken Hill, but also you've lost all your motel accommodation, your doctor's appointments, which is what the critical part of it is. We really need the New South Wales government to have a great understanding. At this stage, my understanding is that the Cross-Border Commissioner is not even informed by the South Australia government when they close the border to Broken Hill. They also, the New South Wales government is not informed, let alone the Mayor of Broken Hill. And, you know, it is creating risk, it is reducing access to health services, and for all of us, the stress for our community is unmeasurable.
Thank you.
Thanks. Kate Femin. Kate, you might be on mute. Kate?
Yeah, sorry, it kept remuting. That's very strange. So, hi everybody. Thanks for joining us. I wanted to echo the Chair's comments about councils, how much during this inquiry you have really stood up for your communities and just really shed a light on what is happening in terms of the lack of health resources, particularly in remote New South Wales. I just wanted to thank you for your advocacy there. I'll go straight to you, Mayor Turley. You mentioned in your submission and in your opening statement about the need for a drug rehabilitation centre in Broken Hill. Could you speak to, firstly, what's been the impact of not having drug rehab services in Broken Hill for so long, despite I know there has been advocacy for this kind of the impact to individuals, families and the broader community?
Can I just acknowledge that the great counsellors we have at our mental health unit, but when you're looking at referrals for drug and alcohol rehab, you know, people have to travel a long way. What often happens, one story I heard is putting your young teenager on a bus to get to a drug rehab centre, don't even know if they'll arrive. But, you know, it is the fact that it actually delays care. It, you know, can actually interfere with, you know, the holistic approach to caring for that person and their family. Because drug rehab is not just about the person, it's the family dynamics. And for all of that, what really happens simply is people don't have that access. They don't have the intervention. They certainly don't have an early intervention. So they're crippled by the impact of their addiction. And an addiction is a medical condition that New South Wales Health needs to understand doesn't just happen in Sydney. It happens in these rural communities. And, you know, I'm reminded of talking about this at the ICE inquiry when someone asked me, would a drug and alcohol rehab centre help if there's one in Dubbo? And I thought, well, it'll help you in Sydney because you live closer to Dubbo than I do. We are a long way away, yet we're an important part of the population and our community deserves to access care and services.
Thank you. Can I ask then, what has been the response from government? Where is that up to? I know it has been several years of advocacy to get that treatment centre in Dubbo, actually. So what's the response been? Is there any hope that something is going to happen sooner rather than later, or at all?
Yeah. So we're about 800 and something kilometres from Dubbo. So our care factor really is about Broken Hill. And, you know, I don't know what's happening in Dubbo. We don't get Dubbo news. So what we want, and we've got a great team that are leading this, Joni Sanderson, you know, community members that understand partnerships are important. They're working with the primary health unit, Western PHN, and so they're working with them to try and get funding now. I hope they do. I think it's an important issue. I can't imagine someone in Sydney sending their family members over 1,000 kilometres away for treatment. I just think that when you're looking at addiction, that it needs a holistic approach and it certainly needs support, not isolation.
What is the level of demand, Councillor Turley, do you know?
I don't know. I do know that we have a low socioeconomic community.
But I know Walt wants some extra time, so...
Oh, sorry.
Sorry, my fault.
Sorry about that interruption.
Do you want me to continue?
Yeah, I apologise.
No, it's fine. So I do know that I don't have the data in front of me. Again, we'd have to find from health, but anecdotally, we are an outback community. We're isolated, and we don't have that early intervention. If you're waiting potentially 3 years for a referral to a specialist, then imagine what you'd be waiting to get early intervention for addictions. And I think that we have a great team, a great job, but with very limited resources.
Thank you very much. All right, Second.
Yes, thank you. Ms. Turley, I'd like to go back to the Clive Palmer anti-vaccination stuff. So did it in fact impact on the community? Did it in fact increase people who were vaccine hesitant in Broken Hill?
I think what my understanding is that there are still people that have vaccine hesitancy. We're very lucky. We have a high rate overall. But if you broke down and looked at the target groups, I would imagine there are specifically target groups there that have hesitancy and that, you know, I haven't got any data to say that this flyer influenced it. But if you received a flyer that looked like a medical information, you would be thinking that this is real, to keep it simple. And so, you know, and thinking these messages of, you know, that were in the flyer were recommended by health professionals rather than, for whatever reason, they targeted our community.
Councillor Turley, but what do you think the purpose was? So from memory, it looked like a bit of medical advice, and it was put in with LD material, I think, from memory. Is that correct?
Absolutely. I wonder if we were being targeted and to trial one of their treatments. Like, first, let's get some low vaccination rates, and then let's trial this, didn't mean to say crazy treatment, but this untested, proven not to work treatment. I just don't understand why you would target a community of the most vulnerable with such misinformation. It is a shame that they were able to circulate that information. It's a shame that nobody's ever legally taken them to task. I have to wonder why that hasn't happened.
Thank you, Councillor Turley. My colleague,
Honourable Trevor Khan.
Councillor Turley, can I return to the issue of the drug and alcohol facility or the lack thereof? Do you know what programs exist under the merit scheme from the, say, in the local court in Broken Hill?
Yes, very good question, because I actually developed the merit scheme for Broken Hill.
Well, there we go.
So merit does exist. It's been in place, I think, since 2004. But it's pretty hard to refer people to drug and alcohol services. But also there's a difference between, rehab services in a lot of ways and detoxing. So, again, I don't have the data, but it does exist. Certainly it's a good intervention program. But when you're trying to get, and I know that one of the stories that was told to me was about, and I've used this story before, about 14, 15-year-old started to use drug, parent very wanting to get early intervention, couldn't even get a paediatrician to see the child. And so, it's very hard in the outback, but it shouldn't be. We should have those services. We can't keep saying it's too hard. You're a great opportunity to progress it.
Well, Councillor Turley, just before I go on the next question, you've got me absolutely on side. I have to say, with clients of mine out of Tamworth where we were having to send them to facilities on the coast, regrettably, sometimes we would lose our clients somewhere on the way to the facility and then we were back at square one. So I absolutely understand the point that you're making, that you need a facility close by in order to do it. Do you know, in terms of such a facility, as to what sort of manpower footprint would be required to operate it and the like?
Well, look, I don't. I haven't seen. I don't think the group that locally that is developing a case study at the moment, and I think that is one of the issues about, what will the services be? It has to be reflective of our whole community. We have a very important Aboriginal community within Broken Hill as well,
yep,
and the Far West. And so, but at the moment, the case study is being developed.
Now, if we can just go to this issue of the cross-border problem that you've got. The Cross-Border Commissioner and I suppose you could say health generally were fairly successful. I'll put the caveat of fairly successful at setting up models on the Victorian border and also the Queensland border to allow movement of patients and the like across the border. And again, how successful that's been has varied over time. Are you telling us that in terms of Broken Hill, that level of both communication and cooperation that existed just hasn't taken place for you?
It took some time, and we finally got what was a buffer. I wrote to the Premier and everybody on a Friday, my love letters to South Australia, I called them. We finally got a buffer, but they pull this so-called buffer constantly. So people travelling, I'm just trying to work out the day, people travelling beginning of this week, we thought that the borders were open, we could cross over. All of a sudden, I got a call on the weekend from a mum who was taking her child for a cardiac paediatric assessment. And now imagine this, if you're in Sydney, you could probably go to a suburb, but you have to travel over 550 k's for a paediatric cardiac assessment. I got a call from this mother saying, I don't know what's happening with the border at the moment. And so I found out, thank you to the Public Health Unit, a great champion there, Kathy Seawood, that she, even though it is clear as mud when South Australia changes their public health order, it was very hard to understand. It may not be you need to have a COVID test. You still have to apply for a border pass. But what we had to resolve is everybody just get a COVID test to go over for an assessment and look like the child as well. It is just terrible that we don't get up-to-date information about the borders and how quickly it could change within a week, within a day, but nothing is ever sent to to Broken Hill, to the Far West Local Health District that I'm aware of, but particularly even to our media, so we could say, don't drive to Adelaide unless you get a COVID test. Don't drive to Adelaide, the border's closed. You're going to be caught on the road for 6 hours if you do this. But more importantly, the delay in accessing healthcare. One lady was flown out to Adelaide so she could go to Adelaide. She had to have a stent put in for a stone. Came back to Broken Hill, was supposed to go back to Adelaide to have the stent removed. That is an emergency, so she can't go back. This was in the first outbreak of COVID. Couldn't go back. Now, what this means now, because she couldn't have the stent removed, the operation is bigger, much bigger. She was delayed, and it just has such impact. I have 1,000 stories. One that heartbreak me is around children and accessing care.
So I think will be my final question, Councillor, but in terms of the Broken Hill community, do I take it from your evidence that the primary source of specialist consultation is Adelaide as opposed to Sydney? And the second part of that question is, in terms of the source of specialists coming into Broken Hill, is the source or the home location, if I can describe it, for those specialists Adelaide or Sydney?
Primarily they're from Adelaide, and because again of COVID, once COVID hits, they can't travel because we had cases where the border closed. If they did come to Broken Hill and went back to Adelaide, they would have to go into 2 weeks isolation. And so they weren't prepared. And everybody understands this. But what that meant is their caseload, all those appointments were pushed back, and they didn't have, again, our community did not have that intervention of care. And this is a constant story, and I would say if you're looking at anything, reviewing the specialist clinic in Broken Hill, they need our support, but certainly, you know, as I said, delays of appointments could be up to 3 years.
Thank you. I'd like to ask more, but I've run out of time.
Thank you very much. Listen, I've just got a couple before we close off this session. And directed, these can be taken on notice, but I'll just explain the thrust of my two questions. The first question is, and this will be to both councils, is that with respect to your annual budgets for your councils, do you contain within them a line item for expenditure on what I'll describe as health and medical services? In other words, because this has become such an issue over the years that the council specifically now is including within its budget consideration expenditure for health and medical services. And I'm saying this is beyond what historically may have been done as considered normal for councils and shires. And secondly, with respect to that, I'd be keen to find out, I'm sure the committee would be as well, that if we look at the 2019 and 2020 financial years and the 2020 and 2021 financial years, what has been those health and medical costs? And I'm thinking in line with ideas like what could be subsidies that are paid for perhaps housing for doctors and nurses. It could include also matters like the advertising or advertising costs that the councils go to advertise themselves for nurses and doctors and allied health workers. It can provide also incentives in money or kind, those types of items which can be aggregated as expenditure essentially now being devoted by the councils on health and medical matters. So I'll let you take that on notice to be able to prepare for that, but that information will be very valuable to inform our deliberations. Thank you very much. Well, on that basis, I just, on behalf of the committee, thank both Mayor and General Manager. It's been great to see you once again it would have been our first preference to come out and spend some time with you and perhaps even meet some of the citizens in your area, in your towns, locales, to talk with you explicitly about these matters, but that's been denied us. But once again, I can assure you your evidence has been quality evidence and will be most usefully used by the inquiry. So thank you very much and all the best for this afternoon. Thank you. Okay, we'll have a short break now.
Thank you.
Short break now, and then we'll move into the next. Okay, thank you. Thank you all again.
We could have used more time with him.
Yeah, that was cool.
Could have used a lot more time with him.
Good morning. It's Andrew here from the Secretariat. Mr. Burdak, can you hear me? Sorry, I think you may be on mute.
Yes, I can.
Thank you. We can hear you. Mr. Anisic, can you hear us?
Yes, I can.
Thank you.
Thanks, Andrew. Good morning, gentlemen, and welcome to our public hearing this morning, or a hearing this morning. It's appreciated you've made your time available to be able to participate, to provide helpful oral evidence in addition to the valuable evidence that's been provided in your submission. So my name's Greg Donnelly and I'm the chair of the committee. May I get through the formalities first, gentlemen, of having you be formally sworn or affirmed before the hearing. So I'll ask each of you, commencing with Mr. Burdak, to first of all state your full name, your position title, and swear either an oath or affirmation, whichever you prefer, the words of which should have been provided to you, but if for some reason they've not made it, let us know and we can provide them to you. So, Mr. Burdak, welcome.
Thank you, Mr. Chair. My name is Mark Burdak. I'm the Chief Executive Officer of Rural and Remote Medical Services, and I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you, Mr. Burdak. Mr. Anisic, the same for you, please. Your name, position, title, and either the oath or the affirmation.
Yeah, thank you, Chair. My name is Richard Anisic, Chair of the Board of Rural and Remote Medical Services, and I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thank you very much. Well, once again, welcome. As I've said, with respect to your submission, and thank you for that, it's been received, processed, and stands as submission number 705 to this inquiry and has been uploaded onto the inquiry's web page. Can I invite an opening statement? I'm not sure whether one of you or both of you will participate in that respect. Is there someone been delegated to or decision made about who will do the opening statement, or would you both like to make an opening statement?
Well, Chair, thank you for that opportunity, and I've been delegated at least to work through the opening statement which we have submitted to the inquiry in the last day or so as well.
Thank you.
And can I say, initially, thank you for the opportunity to address what we see as a very critical, important inquiry on rural and remote health. Can I open firstly, though, by paying our respects to the Gadigal people on whose lands you are sitting in Parliament today, and also to the Gamilaroi, the Wiradjuri, the Waiawan and Yuin people on whose lands our company works every day to address the gaps in rural health and healthcare in New South Wales. Thank you. The part of Mr. Burdak and I today, giving you evidence virtually from the lands of the Wawakal and the Wiradjuri peoples, respectively. We'd like to acknowledge the more than 20,000 people who entrust us with their daily lives, with daily care, 25% of whom are Aboriginal and Torres Strait Islander people, and upon whose wisdom and knowledge we rely every day to understand how to better deliver healthcare, sustainability in rural and remote communities. RAMS has worked as a charity for about 20 years now, delivering better access to healthcare in New South Wales, rural and remote towns. The organisation was established in 2001 by a group of dedicated rural general practitioners with the support from the Rural Doctor Network in New South Wales, initially to address the lack of GPs in towns like Potter-Renabray and Lightning Ridge. Our service locations and operations have evolved and adapted over that period of time to meet community demands and expectations. In doing so, we have proven that it is possible to deliver sustainable healthcare that reflects the priorities of individual rural and remote towns if we have the will to do so, supported by the right policy settings and well-directed public funding. You have received over 700 submissions to this inquiry and taken evidence from a large number of witnesses over 11 days of hearings so far, with more to come before the inquiry is concluded in the new year. There have been some distressing stories related to the inquiry, but it's not our intention today to comment on specific examples, but rather to speak on what we see are some systemic issues and our thoughts on how they might be addressed. Across rural and remote New South Wales, we have community and clinical consultative committees working diligently to address the health needs of local communities. The question, therefore, is not whether we have consultation mechanisms, but are they working? In 2019, the New South Wales Auditor General observed, and I quote, "Despite the importance of community and consumer engagement, it is difficult for LHD boards or the ministry to know with confidence that community and consumer engagement is being done effectively. If devolution was intended to bring the management of health services closer to local communities, then there is little way to know whether this is being achieved." The 700 plus submissions you received in this inquiry paint a clear picture that rural and remote people do not feel that their needs are being met or that their voices are being heard in decisions about their local health services. The problem was illustrated in this inquiry when it was advised by New South Wales Health is, quote, moving away from the GP VMO model, on which rural and remote towns rely to sustain their primary health and hospital systems. As far as we are aware, this was the first time people in our communities were told that the government is making or planning to make a radical change to the way healthcare has been delivered in our communities for over 50 years. And this was at an inquiry in Sydney to find out what is wrong with our rural health system, not at community meetings involving rural and remote people in the bush. We will only get to solutions that work if there is a genuine collaboration with rural and remote communities in the design of local health systems to address their specific needs and opportunities which are very different from metropolitan and larger regional locations. In October this year, the Commonwealth Department of Health released a consultation draft document, Primary Healthcare 10-Year Plan, 2022-2032. And that notes, quote, people living in rural and remote areas have limited access to healthcare services and poorer health outcomes than those living in metropolitan areas. We cannot go on imposing a one-size-fits-all solution on the diverse needs of rural and remote communities. This inquiry has also heard from New South Wales Health that, quote, primary healthcare and GPs are the absolute backbone in keeping people healthy and avoiding unnecessary hospitalisations and the care and support they provide to improve health communities. To ask this begs the question, if primary healthcare is so important to the future of rural and remote health in New South Wales, why do we not have a New South Wales primary healthcare strategy, a rural health plan that sets out measurable health outcomes against which governments will be held accountable, or a clear and accessible framework that tells rural and remote people exactly what services they can expect in their local hospital and the minimum workforce it will receive? Sustainable primary healthcare is to the future of rural health, and this can only be delivered if there is a clear strategic and accountability framework and the resourcing to support primary healthcare-led service delivery in rural and remote communities. This requires some frank and honest discussion about culture, development and structures that support rural and remote health. In its evidence before this inquiry, New South Wales Health seems to be saying that the problem of rural and remote health comes down to a simple workforce problem, the lack of GPs willing to live and work in these towns. Workforce shortages, however, don't explain why in some rural and remote towns there are GPs who simply refuse to work at the local hospital, and why in other places there are local rural GPs who are qualified but not accredited to work at the local hospital. In November this year, the Daily Telegraph published a report on a study of junior doctor perceptions of our hospital system. It wasn't very pleasant reading. It used words like, to describe the system, like toxic, poisonous, dangerous. Trying credibly to suggest that the sort of cultural problems that affect our hospitals in Sydney and the larger metro areas do not also exist in the bush. We need to acknowledge the impact of culture and working conditions in rural hospitals as a factor in the willingness of GPs to live and work in rural and remote towns. Every year, we, as a community and government, we spend a lot of time and money training enthusiastic young doctors to work in rural and remote towns, to communities that lack adequate services, where hospitals and healthcare services are overstretched to operate in primary healthcare facilities that would not be out of place in some towns from the 1960s. We spend millions of dollars building new rural hospitals in the hope of attracting doctors, without recognising, though, that GPs spend about 90% of their time in general practice, not at the hospital. And then we wonder why GPs don't want to work in rural and remote towns. One of the most important reasons we have failed to solve these problems is because we have treated the problem as exclusively a health workforce problem, rather than a community development issue. We need a broader development approach that involves a bottom-up, joined-up, whole-of-government effort that is co-designed with local communities, not for them. This is also not inconsistent with a comment in the Commonwealth's draft 10-year primary healthcare plan, which I referred to earlier, which notes, quote, PHNs and LHDs are best placed to understand the needs of regional and local populations, to drive bottom-up planning and to collaboratively commission services to integrate the health system locally and regionally. Whilst this plan supports the need for bottom-up planning, we say, though, that the PHNs and the LHDs are not best placed to do this unless that planning includes genuine consultation with and input from local communities in that planning. Hospitals treat disease and emergencies, and they do that very well. To achieve this, they deploy a model of care which requires centralisation of staffing and services and heavily reliant on ever-increasing levels of specialisation. Primary health care, on the other hand, is about keeping people healthy and out of hospital. It is built around continuity of care by clinicians who live in the community for which they care and who are trained to understand the social determinants that drive health outcomes. GPs work to build a continuous and trusting therapeutic relationship with the patient and the community. For 75% of Australians, primary health and hospital care are two completely separate systems, as they should be. They do very different things and their models of care are not interchangeable. This is not the case in rural and remote areas. Rural and remote practices have historically relied on state VMO funding to be sustainable. In the past, New South Wales understood that supporting primary health care in rural and remote communities not only helped to reduce preventable illness and avoidable hospitalisation, but also meant there were always a GP available to treat patients who turn up in a rural emergency department. This shared care approach made it more financially attractive for GPs to work in rural and remote towns and recognise GPs as clinical leaders in community care. This collaborative approach has given way over the last few years to a more managerial approach as health budgets tighten and demand increases. Rural GPs are no longer, in some cases, treated with respect as clinical leaders, and VMO funding is too often viewed as the New South Wales Government paying for a Commonwealth responsibility. This has eroded a once collaborative and positive approach to leveraging available resources to achieve better health outcomes for rural and remote communities. In this context, we also note the evidence from New South Wales Health, where it was said, quote, our compounding challenge for healthcare delivery is the split responsibilities between Commonwealth and the states, with Commonwealth having responsibility for primary care, diagnostic services and specialist private practice, where the state governments typically build and manage public hospitals and community health centres and employ staff to manage these facilities. It is the Commonwealth task. It is the Commonwealth tasked with ensuring access to other services. Quote. And I can come back to that in the Q&A session if you want. But in my other health board roles, I see that problem every day as well.
Mr. Anistich, sorry to cut you off. Listen, we actually have got your statement here with us, and that's, I think, what you're reading from, if I understand correctly.
I am.
If we have that fully incorporated into Hansard, that will enable us to move to the questioning straight away without actually having you to spend... Is that okay with you? It'll just open up more time for the questioning?
Yeah, absolutely. If all the committee, assuming all the committee members now have that statement and have the opportunity to read it, that's fine. Yep.
Yeah. It'll just enable more questioning, and it will be reflected in the Hansard. So, not meant to cut you off, but just so we can open up the question time, and your statement will be will stand as evidence to the commencement of this session. So we've got now 10 minutes each with respect to the groups around the table. So we'll start with the opposition, Honourable Secord.
Thank you. I'd actually like to go to Mr. Burdak. Mr. Burdak, you're on the record saying that there's too much focusing on attracting GPs and doctors to country areas, and you believe the shift should be to retaining them. What do you mean by that, and what are you proposing? And what do you think we should recommend in that area?
Thank you, Mr. Secord. The issue in rural towns, whether it's doctors, teachers, police officers, social workers or accountants, is not how you get people to the towns, but how you sustain them within those communities. The challenge we see is one where we're putting a lot of money in training doctors to come to rural towns, but very little investment in actually making those towns places that people want to set up life and a family. So we've got a disconnection. We've literally spent billions of dollars over the last 20 years. We have rural graduates coming out to these towns, but they're confronted with a situation where services have been withdrawn, there aren't jobs for spouses, there isn't appropriate infrastructure, and so they leave very quickly thereafter. If we want to create effective solutions, we've got to simultaneously build the workforce, but also look at what are the dynamics of those communities and how to invest in those communities to make them more attractive places to remain as well.
So when you have prominent GPs or community leaders who decide to leave communities, do you do, so in the corporate sector they'd be called exit interviews. Do you ask them or research and find out, and what is sort of the number one reason for leaving those communities?
Look, I think it is because there's not a career pathway in those communities. There isn't opportunities for their children, for example, to attend the sorts of schools necessarily that they would like to be attending. We've got fantastic schools in rural towns, but often the children of doctors or doctors' children's parents are looking for a type of education that isn't necessarily accessible locally. That's a major reason. We often see doctors leave around about that year 7 mark, where their kids are moving into high school. Spousal employment is another really significant issue. So if you have a doctor, you may well have the husband or wife who is an accountant or a doctor themselves, and so what you need to be able to do is have a sustainable career for that person within that community. Now, for a lot of these things, it's not actually a big challenge to address many of those problems. And part of what we see is, we know that 80% of our health is determined by where we are born, live and grow. So we know things like high employment is very strongly related to poor health. We know that low educational attendance is associated with high unemployment and poor health. But we also know those factors make it more difficult to attract doctors into the town because of economic decline. So as we're doing regional development in these towns, we need to think more holistically about how we create environments that people want to remain in by creating active economies. And so that requires us to link up planning in a much more effective way than we're doing. We can't treat health as though it's in a silo from everything else. It needs to be part of an overall strategy. I was meeting with a fantastic group of people yesterday, the Warren Health Action Group, who've really taken this bull by the horns. And they've got some really serious trouble. And they're saying to me, well, what do we need to do? I said, look, it's about 100 things we need to do, and it's getting all those ducks lined up and making sure we can make our towns as attractive as possible to keeping doctors here for the longer term.
Mr. Anchich, I'd like to turn to something you raised in your opening statement, and you talked about concern about the communicating of the New South Wales Health changing the VMO model. Can you take us to that and what occurred there and what were the deficiencies and how did it unfold?
Well, I was referring to some evidence given, I think, at the first day of the hearing of this inquiry, and that's the evidence from some of the senior health ministry officials, I think, before this inquiry. That's what I was referring to. Whether that statement is a reflection of current government policy or not, I'm not sure, but the point that I think we're making is that for the 20 years that RAMS has been operating in those towns, it's the VMO GP model which has been underpinning the sustainability of the practices, and it provides the resources for GP, whether it be someone who's permanently residing in the town or on a locum basis, on a regular locum basis. But they're not just working in the hospital setting, they're working also in our practices and providing that community-led healthcare to the patients and dealing with the chronic disease management plans, dealing with issues of diabetes and things like that. It's not just the acute care, which might lead to a presentation in the local emergency department. And from the management of the health budget point of view, surely we should be trying to keep people out of the hospitals and being dealt with by GP and allied health-led care in the community.
Either one of you can answer this. Now, in the opening statement, there was reference to doctors refusing to work in local hospitals. What would be a blockage, or what would make a doctor refuse to work in a local hospital if there are very few doctors in that town? What's the blockage, or what's the reason? Why would you be reluctant to work in the hospital? Is it long hours? Is it insurance? Is it pressure? What is the reason? Why would you refuse to work in a local hospital?
I'm happy to answer that question.
Please, thank you.
If you'd like. Look, there's various factors, I think. There are, we have very good, dedicated staff working in our rural hospitals across the board. But there are examples of hospitals where the culture is not supportive of having general practitioners in those communities, in the hospital itself. And we see in some towns where you might have 6 or 7 doctors and none of them work in the hospital because they do not feel that they are well supported or their clinical skills are properly recognised or the culture of the hospital is such that it is not a pleasant place to work. And, we've seen that across the board in hospitals in Sydney and in the bush. It's not something that is unique, but it is a real challenge. So if 95% of the job of a doctor is general practice in a rural town, 5% is out of the hospital. But if that's a really unpleasant environment, it causes problems. And we certainly have experiences of hospitals that are not conducive to supporting doctors working in that environment. And so we don't want to work there.
Well, I want to stop you there. So you have sort of a toxic atmosphere in a hospital where a doctor doesn't want to work there. And you in fact, you said you had a town of up to 7 doctors, but none of them working in the hospital. So wouldn't alarm bells go off in New South Wales Health? We have 7 doctors in the community. None of them want to work in the hospital. So okay, sorry, I'm sorry to cut you off. Go ahead, sir.
No, please. I'm sorry.
I just can't get my mind around. I can't get my mind around that. You have no doctors in the hospital, but you have 7 in the town, and they won't work at the hospital.
Yeah.
Can you educate me on this? Yeah.
Yeah, look, I think it's a complex beast. So in rural towns, one of the challenges is you don't necessarily have a full suite of skills available in, health services management, in, practice management. So there's a very strong reliance when you get to these towns on those capabilities to run a hospital, which is a very complex job. It's about managing budgets, managing facilities, managing clinical governance standards, recruiting doctors and recruiting nurses. So there's a trade-off that occurs between having those skills in the town and the culture that is created within that town. So you have situations where you have leadership in some of the hospitals, and this is a very small number. I don't want to give the impression that this is across the board. I think in our submission we talked a little bit about that it's not. We have to have hospitals operating at the top of their game in a way that, in the same way that the community embraces the local GP and makes them feel welcome in the town, that can all be undone in 2 seconds flat if they're not getting that level of support in the local hospital. So the solution, I think, sits around having clear performance indicators on the hospital management that says if you have 7 doctors in a town and none of them want to work in the hospital, that's actually your performance indicator. That you're obviously not creating an environment, a remunerative structure, working conditions, or making these doctors feel as though they are welcome and clinically respected in the role they perform in that hospital, and you'll be performance managed on that. We don't have any such structure in place in New South Wales to put accountability expectations. So I would say 80% of hospitals, you've got fantastic health services managers who do a wonderful job and really work for their community, and then in other towns you don't, and it shows. If you ran a list through those towns where the local GPs don't want to work, you'll find the hospitals where there are cultural challenges potentially.
One tiny indulgence question here. So what community were you referring to where there were 7 doctors who didn't want to work in the hospital?
Look, I think the challenge for me is I don't want to, rural communities have it tough enough as it is. But what I prefer to see is a focus on what the systemic problems are. If I go around naming towns, then that creates a problem for recruiting to those towns, if you understand what I mean.
Okay.
Mr. Burdak, you could take that question on notice and perhaps come back with a sort of considered broader response as opposed to feeling that you've got to name the town if that's what you prefer. So,
thank you, Mr. Chair. I'm very happy with that. Thank you for your time, and sorry, Emma.
No, thank you. Deputy Chair, Honourable Emma Hurst.
Thank you, Chair, and thank you both for coming here today. Just following on from some of the questions from the Honourable Walt Secord in regards to attracting doctors to rural and remote areas. We've heard a lot in this inquiry about how difficult it can be to attract doctors into rural areas, but in your submission you point out that a lot of other states and territories are actually doing a better job than New South Wales, and I just wanted to get a feel for what you felt that those states were doing and that they were getting right, that we should really be implementing in New South Wales.
So I think there's a range of things. I should start out by saying I don't think anyone does it perfectly. But there are good practices and less good practices, and New South Wales perhaps falls into the category of less good across most of the indicators. Remuneration is certainly one of those things, but I don't want to focus too much on that because it's not, I think, the overall determining factor. We have doctors working and have worked with us for many years because they're committed to the local community, because we support them really well in general practice. I mean, we put a lot of work into that. And I think where you see those differences in different states is it's around the culture of respect for general practitioners and primary health care in those states. And I'd say that's the defining issue. In reality, we don't run hospitals in rural and remote communities. It's a sort of misnomer. At best, if you're in Lightning Ridge or at Walgett, a patient will be brought into emergency, and if they are a serious, triage category 1, 2, or high 3, they will be transported to a referral hospital, where the traditional functions of a hospital are actually performed. So in the states that are effective, I think, they have a respect for the fact that they are supporting good primary care and excellent emergency interventions for transport. They are not trying to run hospitals. In New South Wales, I think there is a very hospitalist culture and an attempt to impose what's a very different form of medical care and an operational framework onto rural hospitals that are essentially primary care facilities and aged care facilities. So I think that's the biggest issue, is just we're running a hospitalist model in rural areas which is based on fragmented episodic care for acute patients, when what our hospitals need in those communities is exceptionally advanced primary care that actually requires respect for GPs, for primary care nurses, for primary care allied health. And I don't think that is really built into the way we operate hospitals in our rural and remote towns.
Thank you. One of your recommendations is that the New South Wales Government establish a community service obligation payment to recognise the broader community service role played by rural and remote GPs. I was wondering if you could expand a bit on this and what some of the community service work is, and if that kind of payment does exist in any other states.
Yeah, look, there's various models for this, and I think we're flexible. But if you look at the average day of a GP in a rural town, you might have somebody come in for, typical aches and pains, but you'll have other people coming in because in most of these towns, the doctor is the most trusted person in the town. Right? They build up a therapeutic relationship. You're telling them all sorts of personal, private issues. So that trust relationship is so critical. So what you find is, people will come in and talk about their legal problem, and how it's causing them stress. And so the doctor becomes a facilitator of access to legal services, either directly or they get the practice staff to do that. Somebody comes in and they've got, a chronic asthma condition, and it doesn't seem to be, a biological cause. And the doctor starts talking about the house, and it's apparently the roof's leaking, there's fungal growth in bedrooms and producing fungal spores. And so, we get on to talking to the Department of Housing and saying, we've got to get that leak fixed. So the healthcare solution isn't always about health. And that function that rural doctors play, because remember, most of those services don't exist in our towns anymore. They're delivered remotely from Dubbo or Orange or even from Sydney. So the doctor ends up having to play this facilitation role and coordination role to get people to the services that they may not know exist. Or if they don't feel confident being able to, demand, that the hole in the roof is fixed with the Department of Housing, we can provide support there. None of that's funded, and it's not something that metropolitan practices are required to do. On the question of is it done elsewhere, it is, in different ways. So in Queensland, you have the nurse navigator model, where you have nursing staff work in practices to help people to navigate the various social services that might be available. It's called, in some sense, social prescribing, and it comes from work in the UK. The UK has a very extensive network of social prescribers who recognise that medication is not the solution to every problem. In Victoria, you have care coordinators that work with primary care to link people to the appropriate services. So there's a couple of models out there, and there's really good emerging evidence to say that because 80% of our health is determined by things that are not medical in nature, that having that role supported in rural and remote communities not only makes general practice more financially sustainable, but gets patients to the services that they need and helps government agencies to make sure that they're getting the services to where they need to get them as well.
Thank you.
Thank you very much. Kay Femin.
Thank you, Chair, and thank you both for appearing today, and can I say for your extensive submission. It's an excellent submission, and it's really hard to know where to start in terms of asking you some questions on it because it just contains so much excellent information, which I'm sure will be very useful in the final report. I might go straight to waiting lists, waiting times actually. You have said in your submission that waiting times are one example of how we use process measures rather than community health outcome measures that are designed to drive health system efficiency and performance. And you give the example of telehealth. If telehealth was measured on, in terms of that performance, can you just expand for the committee why that has led to, I suppose, poorer health outcomes, that focus on waiting times? And I'm not too sure who to direct my question to.
Richard, would you like me to address that?
It's okay.
Look, I think we're very good at measuring the wrong things in health. I come from outside health, so it's been a bit of a baptism of fire for me, looking at the way. So for me, you need to have clarity about your strategy. You need to know what you're doing, and for us, that's about improving health in rural and remote communities. We don't seem to measure that. So if you look in the rural health plan in New South Wales, it's largely about the hospitals. It's not about health. It's about how hospitals will be organised, not about how we're going to reduce pre-diabetes in Aboriginal communities in rural remote areas. It's not about how we're going to intervene in early years to build up an understanding of health literacy around respiratory diseases so that kids don't end up smoking and end up with chronic obstructive pulmonary disorder. So none of those things really sort of jump out. We work on waiting times, we work on triage categories, but they don't tell us anything about the health of communities. It only tells us about how our hospital systems run. And that's the problem, I think, that we've identified in New South Wales is we have no primary health care plan. We don't have a rural health plan that's actually about rural health. It's about the rural health system. We don't have measures, for example, to say, we are going to close the gap in diabetes outcomes between rural communities and cities in the next 20 years. Those sorts of things, if we start driving into those directions, means we have to make different types of decisions. But if the outcome indicator is we have built a new hospital, then when you build a new hospital, you've met the outcome without necessarily actually achieving any improvement in health. And so therein lies the problem, if you like. In terms of telehealth, it's a complex issue. So I think we noted that, and look, I'm not going to sort of, we just noted the anomaly rather than being able to testify as to what caused the anomaly. But we've had better wait times in terms of wait times in hospitals that had no doctors than we had in towns with doctors. And so we get this sort of distorted picture that hospitals with doctors are less efficient than a hospital that perhaps is operating on a telehealth service. So there are data issues and data integrity issues there that can give us the wrong answer about what's working and what's not. Because if we don't define what good health is and what the system's going to do, then we're going to end up with some rather sort of distorted answers.
Thank you. I did want to try and jump in with another question before my time runs out. I was fascinated by the easy entry, gracious exit model, where you really talk about the different kind of recruitment. It differs from previous recruitment models, emphasising this continuity of practice as opposed to continuity of the doctor. A couple of elements to this question. Firstly, why hasn't that seen, if it is so successful, which it sounds like it, why is it kind of limited to just the RAMS model? How come the New South Wales government hasn't adopted this more broadly, if you like? Because it does sound extremely successful, and why, in some ways, isn't your organisation kind of rolling out more of this across New South Wales? What are the blockages there? Because it just does sound fantastic.
Look, it's a model that's been researched quite extensively, and there's a number of published papers that look at its sustainability and its effectiveness. And it's if you put it in the combination with the Aboriginal Medical Service model, that's a community-controlled model in a slightly different way, but the methodology of how we work is very similar. So why hasn't it been adopted? Well, two reasons. I think, partly we had a bit of a tendency to stick to our knitting and we stuck to the places we knew, and we weren't running around looking for new opportunities in the way in which you might otherwise expect. So there was a bit of an internal issue, and we were take that on the chin. But I think also that there has been a growing sense in New South Wales in particular, and I've certainly heard this amongst senior officers of the Department of Health, that our model is seen as New South Wales Health paying for federal government funding responsibility, because we drive things through a primary healthcare lens. And I think this has become increasingly a more acute blockage for models like this to be rolled out into other communities, because if it's seen as VMO funding is necessary to make this work, And if that is seen as a cross-subsidisation of primary care, you end up with a situation where New South Wales says, well, that's not our funding responsibility. We're getting out of that game. And that's very much what's happened over the last 3 years, is a very strong message that VMO money is no longer going to be used to cross-fund care. Now, the reality is, I don't care whether you call it VMO money or, whatever, give it whatever name. The state has always supported primary care because it's actually designed to keep people out of hospitals and reduces the total cost of the state whilst keeping people healthy. Now, I think it was the Mayor of Leeton yesterday said, no one in rural Australia gives a damn whose responsibility it is. Fix it. Bang some heads together and say, fix it. In effect, that's what we did. The old Greater Western Area Health Service. So it was much more community-based. The board was community. They knew what these communities were about. The Rural Flying Doctor Service, the Walgett Aboriginal Medical Service, the Rural Doctors Network all got together and said, we can't get doctors into these towns. What are we going to do? Came up with this model, put it in place, made it work. Everyone put some money on the table to make it happen. And we came up with a solution that we were very successful with for 20 years. Now we're being told that as you're moving away from the VMO model, we don't know what replaces that. I mean, we've certainly seen telehealth replace that, but we're not sure what we think that retreat away from VMO, because it's a cross-subsidisation of Commonwealth responsibilities, simply makes rural people a sort of pawn. Their lives are going to be damaged because a couple of people can't get their heads together and work out how to pool those resources across state, federal and local government to make it work for our communities. If they did, we would have medical services in most of these towns.
Thank you very much. We move now to government questioning. The Honourable Natasha McCurran-Jones.
Thank you very much, and thank you for your submission. I'm looking at the recommendations, particularly recommendation 15 and point 3, where you have suggested establishing a trial of social prescribing. Could you outline what you mean by social prescribing and how that would operate in an Australian or a New South Wales environment?
Yeah, look. Once again, Richard, sorry, I'll jump in there if you don't mind. Look, what I think, so social prescribing is, as I think we talked about, it's recognising that 80% of people's health is determined by factors that sit outside. You can't get it out of a bottle of medicine. So it's about addressing, why asthma is being caused because of the housing conditions. It's addressing people's employment and how that impacts upon their ability to access health care that they need. So there's a whole range of stuff that our human services departments in New South Wales address, but there isn't a connector between the hospital system and those services in rural and remote communities. So what we end up with is lots and lots of resources coming into those communities, often from very far away. So they're delivered from Dubbo, or they're delivered sometimes from Melbourne into Lightning Ridge, but we don't connect up those services. So I was talking to some community transport folk the other day and said, well, can we train up your bus drivers to take oximeter readings on elderly patients, Aboriginal patients, as they go on transport, and then you let us know if their oximeter readings are off and might indicate, some indication of, respiratory problems. There are all these resources out there, but we're not actually pulling them together in those communities. We have police providing domestic violence support services. We have social family and community services doing communities and justice. And they all come in different directions. And then we try and coordinate that through a stakeholder sort of coordination group. We don't do that with the community. So a lot of the work I do is when people come to me and say, as they often do, can you get us a doctor? I say, is that what we need? Let's have a look at the problems. A lot of the stuff can be addressed by just better coordination of those services. So what we mean by social prescribing is having somebody in these towns, one, which creates jobs in rural areas and actually creates capacity, whose job it is to essentially navigate with the client. So the doctor says, I'm going to give you some analgesics to prescribe you a consultation with our social prescriber who's going to sort out your housing needs. And so rather than government services sort of hovering around towns, where you actually have somebody in the town going, can you help with this problem? We need to have the roof patched. This person really needs to get a Cert 3. How can we make that happen to get them a job because there's a vacancy at the local butcher? You know, we can do a lot more because we have this infrastructure in the town. What we don't have is the connecting resources to make that infrastructure as effective as it could be.
Could I just briefly add to that through Mr. Burrow-Jones and Chair? And there's been a fair bit of, I think, evidence before in our submission and in some other submissions around the concept of the social determinants of health. And so we need to be thinking far more broadly than just prescribing pills and potions, whatever, from the GP. And I refer you, particularly to the submission and inquiry from the member for Barwon, which goes into that in some detail. But Mark, it might also be worth just briefly mentioning to the inquiry what we're doing in Colorenderai at the moment. So that's one of it's a small town, less than 1,000 people population, a large proportion of Aboriginal and Torres Strait Islanders. It's one of the towns that we stayed in after we were unsuccessful in the VMO contract with the Western LHD because the community wanted us to stay there. We've been successful in obtaining funding from the Commonwealth in the Murray-Darling grants round to enable us to acquire a property in the town to rebuild not just our GP practice, but build it in connection with a community centre where we will house, for example, the local library, where we will have facilities for young kids to come after school and have access to the Wi-Fi so they can do their homework there that wouldn't be doing it in their own home environment. So we're providing that, far more than just the local GP, but providing a community service, if you like, where to try and foster some encouragement to the community to improve their life, improve their lifestyle, improve their dietary habits and all those sorts of things, which it's all part of the social prescribing, all part of the social determinants of health to improve their health and well-being, keep them out of the hospital, save the state health budget money by keeping people out of hospital, but improving the lives of these people in the community. So that's one very live example which we currently are getting off the ground right at the moment.
Thank you.
Thank you very much.
Mr. Chair. Oh, sorry. I'm sorry, Wes.
I was just noting the time. Do we have any time left, Chair?
We are. There's 4 minutes. So do you want what's it called?
I think Wes.
Wes, I'll be really quick. I just want to make in response. Earlier, we had the mayor of Broken Hill give evidence about Clive Palmer's movement distributing anti-vaccination material. Now, I believe that was irresponsible, reckless, and a downright act of bastardry. How do you guys feel about the anti-vaccination movement targeting rural and regional areas, especially the Clive Palmer movement targeting Broken Hill?
Well, we perhaps don't have a comment specifically on that particular matter, but certainly we were doing a lot of work to communicate with our communities about the safety of vaccination. I was on radio in Queensland this week to talk to Aboriginal communities about why it's safe to take vaccines and why it's really, really important to do it. So we're focusing in, I suppose, on the evidence. In our practice towns, and this I wanted to use this good opportunity to use this as an example. Almost 100% of our patients are single or double vaccinated. That's in Aboriginal, where we have populations 50, 60% Aboriginal people. That's because we have a trusting relationship with our communities, and because we're there, and we've been there for a long time. It's not just the doctors, it's the practice managers and the practice reception and the nurses. You build up that relationship, and whoever's saying you shouldn't take a vaccine, no one's going to listen to them. They're going to listen to their local GP because they trust them. That's why we desperately need to continue to maintain and support the growth of primary care in our communities, because we're going to face other pandemics, we're going to face other challenges as we go along. And we need those trusted people in the community and help communities to understand. And that's certainly what we've seen across our patch.
Gentlemen, on behalf of the committee, can I thank you very much. As Kay Fairman said, your contribution via the submission was most substantial. And I have to say, your oral evidence today from both of you has been to a particularly high standard in terms of what you've been able to communicate to us. It's not just thoughts and ideas about dealing with the matters before this inquiry, but I think most significantly for me anyway, particular suggestions and proposals about dealing with the matters before us. So much of the evidence before this committee has been the articulation of, I sort of used the phrase, the problems, unquote, and probably a lot less than I would have liked in terms of thoughtful ideas for initiatives and programs and solutions of looking at things differently than hitherto we've done in the past, which I think is going to be necessary to confront and deal with these issues which are before us because of the size and the magnitude of them. So that contribution by yourselves and the organisation is most appreciated. So thank you both very much. Thank you.
Whilst Mark and I haven't been with the organisation for 20 years of its history, I mean, the organisation has been on the ground in these communities for that period of time. And I think we do have a good understanding, as you say, of the problems, but our focus is how to solve them. What is the future and what is the future for the benefit of the communities we serve? So that is, we have put a fair bit of into our submission.
It's much appreciated, and I can assure it's very much front of mind for us when we're looking at what we're going to be looking at in terms of what we're developing with our report and recommendations. Thank you. Okay, well, thank you both. So we'll now move on to the next set of witnesses, which will join us now. So call them forward.
Mr. Sam, this is Sharon from the Secretariat.
To rush out.
Just checking you can hear us, Mr. Sam?
I can, thank you.
Great, we can hear you too. And Ms. Beach, just checking you can hear us?
Yes, I can hear.
Yep, great. You're coming through loud and clear as well. Thank you both. We'll start momentarily.
Well, welcome to our next pair of witnesses. Thank you very much for joining us this morning. We appreciate that you're very, very busy and appreciate carving out some time for us today. So on behalf of the committee, thank you very much. So joining us now are representatives from the Royal Flying Doctor Service of Australia, the South Eastern section of that organisation. An organisation that's obviously very well known to the people of New South Wales and beyond. And of course, we are particularly grateful for the outstanding work that the RFDS does for and on behalf of our citizens outside of the major metropolitan areas. Joining us today is Mr. Greg Sam and Ms. Jenny Beach. What I'll do first, if I could please, is have you formally introduced to the inquiry by getting you to provide your name first, your position title, and then swear either an oath or an affirmation, whichever you prefer, the words of which should have been provided to you. If for some reason you haven't got them before you, let us know, we can provide them to you. So we'll start just list in front of me. We'll start with Mr. Sam.
Good morning, my name is Greg Sam. I'm the Chief Executive Officer of the Royal Flying Doctor Service South Eastern Section. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you, Mr. Sam. To Ms. Beach.
I'm Jenny Beach. I am the General Manager of the Health Service at the Royal Flying Doctor Service South East Section. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you, Ms. Beach. Well, we'll proceed with inviting an opening statement. I'm wondering whether there is one that you'll both do, or there'll be one in sharing that, or one that perhaps one of you will do. So how would you like to proceed? What's...
Thank you. I'll provide the opening statement.
Thank you, Mr. Sam. Please proceed.
Thank you. Health and wellness continues to be disparate for those living in rural and remote communities in New South Wales. And the associated poor health outcomes and access to healthcare is both well evidenced and well documented. Despite these challenges to improving a disparity, it remains unacceptable to our service that geographic location continues to determine the quality of life and health outcomes. The impact of care delivery within existing health systems declines with increasing rurality and remoteness as the underlying components of effective health systems become more variable, fragmented and less available. Reduced access is further compounded by underlying socio-economic and demographic differences. In short, the provision of rural health is not on a level playing field with urban, metropolitan or super-regional populations. There is a place and a need to continue to increase investment in secondary and tertiary healthcare systems so as to assure service quality and outcomes, as the vast majority of care received, once accessed, is at a desired standard. The more challenging problem, however, relates to the significant geographic and temporal gap between wellness and the need for managed care, arising due to factors that limit or complicate access to the right care, importantly at the right time. Poor access is composite of extensive distance, lack of transport availability, low income, low affordability, lower health literacy, fewer choices, and attitudinal barriers to the priorities of rural health delivery. The continuing decline in permanent small-town general practice presents two fundamental problems: the direct loss of community-based primary care medical services and the loss of the primary access relationship between communities and the broader health service and system. We assert the value of this relationship is essential in improving access. The RPS operates comprehensive 24-hour emergency, pre-hospital and extensive preventive and primary health care in communities with limited or no service access. In response to the widening access gap and to the limits of our resourcing, we have sustained our emergency and aeromedical services whilst expanding general and specialist primary care, including mental health, dental health, child health and chronic disease management. We hold and have held for a long time a unique health relationship between communities, our services and the broader health system. We understand and work within a complex state and national health system. However, we consider that improvements to health and wellness disparity for rural communities are achievable and sustainable through supporting locally designed and managed care models by organisations funded for that specific purpose. We therefore recommend a sustained investment in primary and community-based care models administered by community-connected and engaged non-government organisations that can establish a formal service relationship, can offer services within communities, governed locally and established by co-design for minimal thresholds of care which recognise the dislocation from established health and social infrastructure. That this be supported by a broad-based fixed and variable funding model to enable required service, workforce and technology planning over time and to respond to local need. And finally, that these models support multidisciplinary models of care to optimise limited and available workforce. We believe this approach fills the important gap of declining GP and community-based services and provides direct healthcare outcomes. Importantly, it also assures a local health service relationship and improved engagement with the broader health system, connecting people into appropriate primary, secondary and tertiary care as quickly as possible. Thank you.
Thank you very much. Well, if it's agreeable to you both, I will move to questioning now from committee members. Can I, before doing so, acknowledge and thank you for the submission made by the organisation. It stands, been received and processed and stands as submission number 677 to this inquiry. And it's been uploaded onto the inquiry's webpage, so that will obviously help inform us in our deliberations with the preparation of the report and its recommendations. So we'll move to question now. The Honourable Walt Secord.
Thank you, Mr. Chair. Now, I guess I'd like to take you to the emergency retrieval team and the work that they do. So that would be the clearest illustration, and that would be where that would be the most graphic illustration of the lack of rural and regional health services. That would be at the very front end, wouldn't it?
I think any emergency service, particularly from our perspective, serves two fundamental responses. One is that we provide the direct emergency response in areas where there is poor or little proximity to acute services. In other words, we become the emergency provider, and our retrieval service is the retrieval service for those communities. Yep. In addition, we work with the ambulance service in New South Wales and the LHDs to be part of the retrieval system across New South Wales. So we provide both those functions. And yes, the nature of that is that it responds to both acute emergencies arising from trauma or injury, accident, as well as the need to move critically ill patients or severely ill patients between community and facility or between facilities.
How much of that activity would be the result of what you would describe as avoidable situations or preventable situations if, in fact, medical care had been provided earlier?
It's difficult to be accurate in quantifying that. It is fair to say, though, that increasingly the long-term impact of chronic disease and the poorer access to ongoing management of chronic disease is featuring more in the nature of the patients we need to move around. And I think, again, that reflects both a lack of access to service, but this compounding problem of fundamentally a sicker population.
Now, how do you respond to incidents or mental health needs through the Royal Flying Doctor Service? What are the challenges that you have in that area, and how do you respond to them?
I might defer to my colleague. Thank you.
Certainly, we have. Certainly we have in more recent years expanded our mental health and alcohol and other drug services quite significantly. We respond to those across the spectrum really of care. So there are times when we will have an emergency retrieval service where we go out when somebody is in a crisis. Then we have a team that works with them at the lower end of the spectrum throughout life. So in the areas that we're working with at that end of the spectrum, we aim to work with people and manage their mental health issues so that we either stop them exacerbating or we recognise them very early in that exacerbation and we can improve the outcomes.
Now, can I take you to dental treatment, dental patients? What kind of service and medical services is being conducted or carried out in regard to your service? Is it simply extraction and things like that, or I guess how do you provide dental services through the Royal Flying Doctor Service?
So I will start to answer that question. We provide it in a number of ways. Our focus is again very much around rural and remote people. We have services that we provide through a number of different avenues and sometimes partnerships and contracts. We go into remote communities and there is a range of services that are provided. It's not just extractions. There's a lot of, we have dental assistants, we have dentists, we have a range of staff that work out there. So they're working again on prevention and on treatment. We have people that go into some of those communities. They work sometimes out of the Aboriginal medical services or the local health districts. In addition to that, they will go to remote clinics where they take everything they need, including the chair, and people will come into those remote places. Then they go into clinics that are RFDS operated, such as Tilpa, Louth, Inaminka, places like that. And then again, we have a dental van that visits various remote locations around the state.
Now, well, can I ask a question about doctors, medical doctors and dentists that work for this service? Is there a high turnover? Do they go through the service quickly, or do they stay for a while? What's the average stay in the Royal Flying Doctor Service in southeastern New South Wales?
So I can answer that one. We did some stats on that not very long ago. The average, I would say, is 2 years, but it's a very big mix. We have some people that have been with the service for a long time. Then we also have a large locum workforce as well, and that is one of the things in rural and remote areas that most of us are facing.
Now, I asked a question earlier about exit interviews and that. Someone staying for 2 years is quite a short period of time. What's the reason? Is it because they find themselves only doing emergency work and that reduces their skill set, or what's the reason for such a short period of time?
I might.
Oh, okay. Yes, Mr. Sam.
Specific.
Yeah.
Thank you. Our service really is impacted by the same market forces that most rural health services are currently, and we have traditionally relied on a mix of both Australian trained graduates and Australian training pathways to provide our workforce, as well as overseas trained graduates. That has started to change, obviously, through the impact of COVID more recently. We know that the shifting dynamic of rural careers is almost universal, certainly nationally and certainly across the state. And so what we've moved to do more is about offering professional experience throughout your training and development and your career, rather than an endpoint that said, we want you to come work with us for 20 years and buy a house in Broken Hill and stay. That model is very much now, becoming the minority of our workforce. It's about trying to find a model of care that works for community, so that there is consistency in both the provision of the care and the care providers, as well as the opportunity for us to be able to accommodate this rather shorter turnover. The other expansion for us is that traditionally we only really employed staff who were in effect able to work at the top of their accreditation or qualification, in other words, shovel-ready staff. We are now very much participating in different pathways of training and development so that we can take on registrars, internships, etc., that still provide some level of service but also support the broader rural health workforce. And it's fair to say the other trend particularly is that increasingly we have to meet rising compliance and accreditation needs. In other words, that the concept of a generalist flying doctor from 20 years ago is very different now. We are required to have accredited, vocationally registered staff, whether that's emergency physicians or general practitioners, and you will be aware of the emergence of sort of rural generalist pathways that aim to give quality procedural skills and enable more workforce to be able to practice a broader scope. So they are the same challenges that most health services have. I think it's fair to say our brand in terms of our remote work, our fly-in, fly-out services and our relationships with remote communities is a point of attraction. Keeping people more than 2 years now is a challenge.
So, can I take you back to your comments about the Royal Flying Doctor Service brand? So, in fact, does it make it easier, even though you have a turnover of doctors, as you said, average of 2 years. Does it make it easier for you to recruit doctors and get doctors because of your brand?
I think it's easier to, attract amongst a pool of staff that want to go and work rural and remotely. So we do have a point of difference. I think for us, given where we sit in New South Wales predominantly, we're seeing the impact of that decentralised regionalisation, where it does provide us greater access to sort of specialist workforce. And to some degree that has two dynamics. One is it still allows people to come in for us without being a remote-based clinician. So it enables us to sort of share across the service, if you will. But equally, we do have staff who only specifically want to work remotely under a more traditional model.
Can I add?
The other phenomenon...
Sorry. I'm just mindful of my time. I'd just like to ask one last question. Is the demand on your services increasing or decreasing over time? Do you find that you're actually called upon to do more now or less activity now? What's been the trend?
The trend in our emergency service is that it is reasonably stable in terms of the overall activity of emergency work, and that reflects the broader impact of health services. Where there has been a rapid increase and greater demand is in the primary care pre-hospital and step-down type care, and that's been associated with largely the decline of small-town general practice and that traditional model of local GP, permanent GP, and the relationship between those roles and small hospitals. So that traditional view that small clinics had a GP and a small hospital that could do some procedures. So that has changed and continues to change, and that's adding to the demand on our service.
Thank you, Mr. Sam.
Thank you. Deputy Chair, Honourable Emma Hurst.
Thank you, Chair, and thank you again both for coming here today. The Honourable Walt Secord asked you some questions about the dental services, and I just had a couple further questions about that because we've had other submissions actually raise concern about the lack of dental services in remote areas, and many people are relying on the Royal Flying Doctor Service to actually deliver these services. And I just wanted to ask if you're seeing an increased demand specifically for dental services. And so I might ask that to Ms. Beach. Thanks.
Yes, thank you. So that's quite a difficult one to answer over the last 2 years. It's been a particularly challenging part of the business due to many of the restrictions for the last 2 years. I think that the demand for the service is probably growing, but we also have to put it into the context of the way we've been operating for the last 2 years. The preventative dental care is particularly important, and I think there is a great need for that for young people, particularly in schools. In terms of treatment, there are waiting lists. Basically, I would suggest that the demand is there. There is increasing numbers of people that are needing treatment as well as preventative care.
You mentioned waiting lists. Do you have any idea on how long some of those waiting lists might be? How long people on that waiting list would be waiting for, sorry?
Look, it's quite I'm not trained in dental services, but it is, there is a triage system, so people that need to be seen urgently are seen within days. Obviously, people that are considered less urgent, there is a longer time period, and I don't have the specifics on that, but sometimes it can stretch into weeks.
Okay, thank you. In your submission, you say that the focus of local health districts is often at reducing transport costs to the detriment of the patient journey. I would throw this to either one of you, but I'm just wondering if there are any examples of this, and what some of the decisions that have been made to save costs.
I might respond. I think in terms of the decisions to save cost, we can't comment about that. What we see is that a large part of our business and service outside of providing direct care is providing transport for patients, largely who require flying around the state, and particularly between facilities. And we've also seen that has broadened in terms of the demand for moving lower levels of emergency or acuity. So there is quite a distinct structured patient flow system in New South Wales that relies on different scales of acuity of moving patients around. The comments around the price signals and the use of that largely relate to the lower acuity of non-emergency patients. So there is no restriction or indeed limitation if we're tasked to move someone who requires urgent care or emergency care or are classified at a certain level. There is another category of non-emergent patient that basically can run more on a schedule or requires managing in terms of when and how those patients may be moved around. Clearly, using airplanes is expensive, and at times there are marginal decisions on whether somebody living within a particular distance could be moved safely with a vehicle or could be moved safely with an aircraft. And those decisions at times can be subject to financial pressures just in terms of how the system can cope with it.
Thank you. You also raised concern in your submission that a lot of the funding for rural and remote health is short-term, making it quite difficult to plan long-term services and recruitment. And one of your recommendations was that a service planning and funding is extended to a 5 to 10 year time frame. Just wondering if you could kind of expand on what some of the benefits that you think that would bring.
I think there are several, but the key ones are back to the concept of in communities, if there is not sufficient resident medical care, that community basically has to respond episodically. In other words, when there is a care need or when there is a service provided, that is the focus for how that care is managed and provided. In other words, it's very reactive and responsive. A lot of funding is on episodic care, so it I guess, addresses the issue of occasions of service. But from our perspective, what we would like to see is that the benefit of longer-term funding enables us and other organisations to establish a relationship with the community to be able to both plan and prioritise across a continuum of care needs rather than episodic care based on I really am sick and I need care now, or which particular service is available in the community at any particular time. And that is part of the challenge currently. So longer term planning that then we can align our service delivery to, so it makes it more efficient in how we use resources, even down to how we schedule and roster and rotate our fly-in, drive-in or in-community services, for example. To support that, increasingly we have access to technologies that support either remote or supplement remote care. So we can provide more care provided that infrastructure is there. And that infrastructure requires investment, and that investment is better justified with a return that can look at it over a 5 to 10 year period. So it makes the ability for us as an organisation and indeed other funders to invest in communities if there's some assurance that that service will be continued for a length of time. And finally, we do know that part of the issue with workforce attraction is that there is some ongoing relationship that rather than looking at that episodic occasion of care model and locum model, that we're able to actually bring workforce in, establish them in a relationship that enables them to be part of that planning process, part of that multidisciplinary team, and ultimately get a sense that they're contributing longer term to the health of that community rather than simply providing episodic care.
Thank you.
Thank you. Kate Fairman.
Thank you, Chair. I just wanted to go to your submission and your statement just now have talked about the changing nature of the services provided by the Royal Flying Doctors Service, particularly over the last decade into primary health care. This decision, was it made, I suppose it's a little bit of a political question, but was it a deliberate decision that was made at the time, say a decade ago, in conversation with governments, that this is where they would like to see the Royal Flying Doctor Service move to fill these gaps because they were, if you like, potentially withdrawing some services and funding themselves? Or did you see the need and choose as an organisation to fill those gaps?
I think both is the answer. Over time, we certainly have shifted from the idea that we were fundamentally an emergency service, and whilst we weren't providing emergency services into remote locations, we could optimise our resources by providing other forms of care. So I think we initiated broadening our capacity and capability. That led to us being able to work with other services around planning services into those communities. And I think we do have a relationship with other parts of the health sector, particularly the LHDs and primary care sector, around a role for the RFDS into communities. But we are also reading and responding to the broader change to the way that health services are structured across the state, and where we're seeing gaps emerge that we will, again, under self-direction, determine that that is a need, and we will make a commitment to service provision there. If I may, sorry, just quickly also, has been a traditional, view around the non-government sector and how organisations like the RFDS actually develop and evolve. And I think, in my experience, historically it was always relying on funders, governments and other donors to basically carry a lot of that financial commitment ahead of the decision to move a service in, for fear that that funding may not be sustained. We've adopted a very different approach, which fundamentally says if we're able to identify a need, we're able to provide a quality service. Ultimately, that somebody will want to fund it. And it's against a background of increased demand, but importantly against the background of the difficulty of being able to supply services, that the role for an NGO like RFDS actually has evolved to the issues you've outlined.
Yeah, thank you. I was going to ask about funding very quickly as well, so you kind of just touched on that. But what is the percentage of your funding that is through the private sector versus government?
We receive, of our total budget, approximately 30% from the Commonwealth Government, approximately 30% from the state government, and then the rest is through either donor and fundraising, which would be about another 30%, and 10% we undertake other forms of commercial or social enterprise activity to supplement it.
So it's a little bit, Sorry, was that? I think that was my echo actually. So it seems to be is it a bit of a shift then from government responsibility for primary healthcare to having to the kind of raffles and fundraising. I know you do much more than raffles, but it certainly sounds like that from speaking to a few witnesses.
I think the issue of primary care is a combination of the difficulty of the population you've got to serve and the difficulty in the provision of care, and hence many players have a finger in that pie. The clear delineation of who has sole or singular responsibility for that, I guess, can be argued and debated. But we see our role fundamentally trying to represent the interest of the communities, and to that end being able to both provide a service where we can attract funding, making the case to government at state and Commonwealth level for the value of that, as well as making direct appeals to donors who see the value in us being able to move quickly to actually respond to emerging needs. And to give you some quick examples of that, all levels of government and funders wanted to respond historically to drought. They certainly wanted to respond to COVID. They will want to respond to a number of other impacts in rural communities that lead to health outcomes or health challenges. The value of organisations like ours is that we can move very quickly with and ahead of those responses. And I think back to the earlier question on the long-term funding, maintaining that relationship with community that has the service thinking longer term of the community need, in addition to the longer term planning and mapping of the way that the health systems are evolving, is probably where the gap is currently.
Thank you. The Honourable Wes Fang.
Thank you very much, Chair, and thank you both for appearing today. It's really great to have your experience and thoughts presented to the committee today. I just wanted to actually start where almost Ms. Fairman finished off, and that was just around the issue of funding. I used to actually work for a retrieval service myself, which was a NGO, and I know that fundamentally, our service would have been different had we been, say, a corporate entity as opposed to an NGO. The culture would have been different. The provision of service and that sort of dedication to community would have been different as well. Mr. Sam, do you think you could provide some insights as to how being an NGO operator in partnership with New South Wales Health and, like you said, the federal government, but also being that NGO operator, provides you that link to community?
Thank you. It has a direct link in that we see the community fundamentally as our shareholder, and so we are in effect governed through a structure that puts our governance back into community membership. So to that end, we are accountable to the community for our purpose and our mission fundamentally. That gives us sort of three levels of advantage. Firstly, we are, very quickly attuned to what communities need, but importantly expect from an organisation like ours. So that accountability is far more clear and present. Secondly, I think governments of all levels, local, state and federal, see the value of the third sector in that role. In other words, holding a responsibility to represent the interest of communities, equally holding a responsibility to be able to respond and be part of the response to that community. So to be complementary to the overall provision of service, or at least the plan to provide services. Finally, from an employer's perspective, we see that there are a number of professionals, and particularly in emergency care, healthcare generally, who have an underlying sense of value and values to our mission and see that that is a point of difference. In other words, that working with the RFDS, you sign on to the fact that we have a firm view of what our priorities are in terms of the shape of the business and how we manage our services, but also how we behave as an organisation.
And it's also, I guess, that rich history that you've got with serving Australia and the rural regional communities that comes with that as well. I just wanted to touch on, with regard to the, the retrieval component that you do for New South Wales government. That's certainly contracted and funded, isn't it, through that contract?
That's correct. We are contracted by the New South Wales Government through the ambulance service for the provision of inter-hospital transfers, as well as other forms of retrieval as part of the broader statewide retrieval system. And that's a partnership in as much as we are a subcontractor for the provision of fixed wing care, but also we provide that mantle of safety in very remote areas. Secondly, we are also contracted to the New South Wales Government through Health Share to provide those non-emergency transport and patient flow services that I referred to earlier. And finally, we also have direct relationships with the local health districts in terms of where we might provide particular services into particular communities.
Excellent, thank you. I just wanted to touch now on, I don't know if you've been following this inquiry closely, but during the inquiry, we've been presented, some disparate views around telehealth. And I know certainly in my time it was emerging, but the ability to be in transit, say over, a regional part of New South Wales and actually have, the tertiary consultant online providing feedback to the team was available in my time, albeit probably not as advanced as it is now. Are you able to provide some insights as to the positive benefits that the telehealth initiatives that we've had from the New South Wales Government have been be able to advance patient care?
I think that perhaps I'll comment on the broader acute systems, and then I'll defer to Jenny to speak about primary care. In terms of the use of remote-based technologies, it has enhanced the quality of service. To your point, the ability for us now to have both audio and visual contact through a retrieval, through our aircraft or through our vehicles or through place-based technologies does improve the quality of care. It also improves, the clinician experience as well. And in that context, it is very much complementary and increasingly it's supplementary, given from our experience we have limited numbers of aircraft and limited numbers of staff, and if those assets are being engaged, having access to telehealth and remote technologies actually adds another dimension to the provision of our services. I might ask Jenny to comment on the primary care. Thank you.
Certainly. So we have seen an increase in the use of telehealth over the last couple of years. Our philosophy has been, ever since we started to use it, that it will augment our on-the-ground services, so it's in addition to. We have not removed services in place of telehealth. I think that what it has really helped significantly with is our ability for continuity of care, to look after that person throughout life, to make sure that we have very regular catch-ups with those people. So if we, in primary health, if we have the doctor out there one day and then they're not back for a month, we're actually able to have those appointments in between, and that's been a big advantage to us. It's helped a lot. throughout the last considerable amounts of time, through the last 2 years, we've done a great deal in terms of mental health, and the teams both on the ground and the communities that they're dealing with have spoken about the success of that. The uptake has been very positive, and they have continued with their treatment sort of programs via telehealth. So that's where I can see great success in terms of primary health.
Thank you for that. So would it be fair to say then that given that you've both presented, I guess, a positive view of some of the services within telehealth, any attempt to demonise the service would be detrimental to the confidence that patients might have in the ability of telehealth services to be able to make a difference in their lives?
I think we just need to explain what demonise means.
I would have thought it'd be self-explanatory, but I can rephrase the question and say, do you think that it's potentially going to create confidence issues with those in rural and remote communities when we continually see attacks on the name telehealth when it actually is quite a wide-ranging and very beneficial service for the community?
I think perhaps the way I'll respond to that is our experience, and certainly reflecting our introduction of telehealth and our view of seeing the introduction of telehealth across our service footprint, is that there is a lot of concern expressed by community and by clinician that the introduction of these models of care is replacing or displacing other forms of face-to-face or personal-based care. And from our experience, we've had to spend a significant amount of time engaging with community and explaining the rationale behind it, both in terms of the benefits that it affords, but it's more so addressing the underlying concern that says the majority of people would prefer to see, or at least have a relationship with a clinician or a provider or a service. And that transition, I think, has been challenging for us, but we've been able to have those conversations. At scale, it's seen as the only, focus for the provision of health service, and in the absence of any other discussion about the inability for particularly rural-based services to find a workforce or a service model, at times it's the only service that is at hand. Now, communities rightly say, but we still want an organisation like the RFDS or any other health service to do absolutely everything they can to improve proximity to access to clinicians and to clinical services. So in summary, I would say that often what gets lost is the broader discussion on why traditional models of health services are declining and why it's very difficult to sustain them. And that, as with many other structural issues of where health services are available and how patients access them, telemedicine at times can be absolutely complementary and, as I said, supplementary. The debate seems to be heading more around it in and of itself as the only available care model.
Thank you so much. I'm noting the time, and we've run out of time now, have we, Chair? Yes. There's the buzzer. Look, I wanted to say thank you very much to both of you for providing those insights today. It was really valued, and thank you very much for those today.
Thank you. Just before we leave, I just got a question about the matter of, to the extent you can deal with it now or take it on notice, funding that the Rural Flying Doctor Service may receive, and specifically, I mean broadly the organisation, but specifically the southeastern section, from shires and councils in New South Wales. In other words, whether or not reflected in your accounts through form of donations or other forms, support given to the Royal Flying Doctor Service by shires and councils in New South Wales. On that note, can I once again, on behalf of the whole committee, once again I want to acknowledge and thank the Royal Flying Doctor Service for what it does for and on behalf of the citizens who reside in rural, regional and remote New South Wales, and indeed right across Australia. Your service is quite literally world leading and cutting edge, and has been for a long period of time, and that's something you can be most soundly proud of, and we are, of the work you do. We are all very grateful for the Royal Flying Doctor Service for its outstanding work and service, for in the past, the present and the future, and once again we thank you very much for all the wonderful work you do. Thank you.
Thank you.
Well, that brings us to the end of this particular session, and we now break for lunch for approximately 55 minutes. So we'll be back at 20 minutes to 12:40. Yeah, at 12:40. So once again, thank you very much, and we'll see everyone back at 12:40.
Yeah.
can I thank you both for joining us this afternoon. Now, with respect to the formality this afternoon, getting through that before we commence your evidence, we'll need to have. I think will be just you, Betty. Betty will be speaking. Yes. So we'll need you. Yeah. Thank you. To just provide your full name, the capacity in which you're giving your evidence to the inquiry. So your title, your capacity for coming and giving your evidence, and then Betty swearing either an oath or an affirmation. Whichever you prefer, that's your choice, the words of which should be provided to you, but if for some reason they haven't arrived, just let us know and we'll get them to you. So can we commence then, Betty, by just going through that formal part?
Yep, we sure can. My name is Elizabeth Kennedy Williams. I am an enrolled nurse at Walgett Hospital. I'm a local branch member of the Nurses Union.
Yep.
And I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thanks, Betty. Probably I was a bit informal by saying Betty. I should have said Miss Kennedy. Just my mother's name was Betty, and it rolls off my tongue very easily. So
yeah, and I'm known as Betty.
So sorry, I shouldn't have been so. I shouldn't have been so informal, so I apologise. Right. Betty, I'm wondering then if you'd like to make an opening statement. Can I just say, for the record, your submission with its subsequent follow-up parts have all been received and processed by the committee secretariat. And just to confirm, that they stand as submission 258, and then followed by 250A, 250B and 250C. So they're all consolidated as what is essentially your submission, although it's in 4 parts. So it's been received, processed and stands as evidence to this inquiry and been uploaded to the inquiry's website. So that evidence is there. And of course this afternoon is the opportunity to provide some what we call oral testimony or oral evidence to the inquiry. And what we always do is invite the person to make, if they wish to do so, an opening statement. And that's up to them. And then we follow that with, if you're agreeable, questions from the various committee members. So are you okay with that?
Yep, I'm okay with that.
Okay, well, let's proceed then with your opening statement. Thank you.
Hi, my name is Elizabeth Kennedy Williams of Walgett. I am a member of the local branch in my workplace. I've been a member for over 30 years. I trained through the hospital system. I grew up in the tin shack on the banks of the Nemoy River, whereas it was hard as an Aboriginal nurse starting out, and I had to endure discrimination and travelling away from family to do the training in Dubbo. As an Aboriginal nurse, knowing how hard it is to be in Dubbo, no family, no support, it was a lonely experience, but I stood strong and knowing I did it for my community. As a member of our local branch, I experienced a lot of changes in regards to nursing staff. When I was first trained, we had just the right amount of staff for each patient. But these days, the staffing is critical for patient care. As the years went on, there is a decrease in nursing staff. There is not enough staff to assist with mental health, which is a high number of cases in our town. This is due to the number of drug and alcohol-related issues and the COVID pandemic. Staff not able or not available to give them one-on-one care. There is violence around mental health clients, but not enough staffing, including nursing and security. Due to our past history, we need to move on, but not go backwards. Following our staff review and the staff meeting with a representative from our local health district, the nursing staff was promised that we will have security 24 hours a day. To achieve this, the nursing staff was reduced to allow for more security staff. These positions have not been filled to capacity And this has never been more evident than ever the recent months, when at times this hospital was not had any security on evening shift and night duty shift. This impact on our staff to be able to provide quality nursing care. The shortage of staff, nursing staff. We haven't got community health nurses, palliative care nurses, or mental health staff. We need to have more health workers for our community. These positions are important to our community due to the high volume of deaths within our community. We need a solution for our hospital, for more staff, for the community. Everybody deserves to be nursed and treated as an individual, and not having enough staff will impact on that. We need to give our community opportunity to do training in nursing on country at our local TAFE centre, supporting them through each pathways. This will allow interested people to kickstart a career in nursing that are having to leave country. Indigenous people will communicate and relate more efficiently with training on country in their communities where all the support is. Never has it been more vital to look at local solutions to our health issues. During the COVID pandemic period, when we had COVID-19 outbreak, there was additional support to both trace, test, vaccinate and help educate our communities, but this quickly disappeared once the outbreak was over. Thank you.
Thank you very much. Well thank you.
Thank you.
And once again, that contributes very nicely. The other submissions are under the umbrella of the New South Wales Nurses and Midwives Association, of which you're a proud member, and obviously we're now filling that out with specific evidence from nurses to provide some, dare I say, flesh on the bone with some real life examples of what's been going on. So once again, thanks very much, and thank you, Katrina, for joining us this afternoon with Betty. It's really appreciated. It's great. Now, what we do is we move over now to questioning from committee members. There's members around the table here from the opposition, the Labor Party, the crossbench, the animal shooters.
They're in coalition. They're not together.
Never put those two together. The Animal Justice Party, and I offer a sincere apology to the Deputy Chair, don't remember first. The Animal Justice Party. I was just going to say Shooters, Farmers and Fishers Party, another party. The National Party. The Honourable Trevor Khan and the Honourable Wes Fang are joining us as well. So we'll share the questions around. So except for that faux pas, and I apologise for, it's over to the Honourable Secord.
Thank you, Ms. Kennedy, for your time.
Thank you.
I'm Walt Secord and I represent the Labor Party. How long have you been a nurse? How many years have you been a nurse?
I started my training in 1978 and finished in 1979. So I've been nursing since then.
Since then. And how long have you been at Walgett District Hospital?
I've been here all the way through.
All the time?
On and off. I've left and had babies, but I always return back to Walgett Hospital.
Fair enough. Now, has nursing at Walgett District Hospital, which I understand is now an MPS,
yes,
has it gotten tougher?
It has got tougher. Mainly because there's hardly any staff.
Now,
They're all doing double shifts and everything here.
I was going to say, what's a typical work week like for you?
A work week. Well, most of us are doing 12-hour shifts here at the moment.
And that's 5 days a week.
And yeah, maybe every day when everybody's doing doubles to catch up, to try and do our workload here.
Now, so that would be on average a 60-hour work week.
Yep.
60-hour work week. Now, we've heard stories and we've had evidence of hospitals that are unable to have or unable to locate doctors or have no doctors on duty in their hospital. Do you have a situation like that at Walgett?
No, we're pretty covered with doctors.
Yeah.
With the Oka Medical Centre. Yeah.
Oh, this is, yeah.
It's new, they've taken over from Rams.
Oh, Okra, is that the Indigenous service?
No, this is, they took over the lease for the area. For the,
oh, okay. Okay, I see.
Area. Yeah.
Just before you go on, just in terms of consistency for the Hansard to record your testimony, Betty, you said they took over from RAS. That stands for what? Oh, that's okay. What are the initials? RA. What? RA?
It's Rural and Remote Medical Services.
Okay. Thank you very much, Alderman Trevor. Thank you. Yep. Just for the record. Yep.
Sorry. Yep.
So can I take you back to what he said? It's gotten tougher with fewer staff, fewer resources, and that. What about maternity services at your hospital? If someone goes into labour, can they give birth at your hospital?
No, they usually go to Dubbo, but the girls, because of the isolation out this way, the mothers tend to stay until the last minute to birth on country, because there's no accommodation over in Dubbo or finance for them, and being away, if they've got a big family, they think about the other family that's left behind, who's going to look after them, so they tend to stay here and try and birth here before they go over.
Now, does that make for complicated births having to occur at Walgett?
Yes.
Okay, so how does that impact on the community, and how does that impact on the babies and the mums?
The impacts, because we haven't got a midwife here. We haven't got any staff for the midwife.
Okay, so what happens then?
What happens then? Well, the normal RNs, they deliver the babies, and then the flying dogs, the air ambulance come and pick them up.
And how often does this occur?
It occurs regularly.
Regularly. Now, now you're a person with more than 40 years experience.
Yes.
Have you seen preventable mistakes or preventable deaths occur?
No, not in my time, no.
Not in your time, right. But have you seen complicated, I guess, close calls with complicated births and things like that?
Yes.
Mm-hmm.
Yes. But I think the girls that do deliver here, they are pretty experienced, even though they're not a midwife, but they get, because we get an influx of deliveries here, they tend to escalate it up, yeah. They escalate it. So they bring up and to Dubbo and get some information from them.
Oh, I see. Now, now you've heard a bit about telehealth and do you have telehealth? Telehealth at Walt? Yeah. Do you deliver babies by telehealth?
I think they do. They do if one comes in, but the staff they find it really hard. Sometimes it doesn't link up very good out this way because of the remote, and also just trying to explain things to the guy on the other end of the video link up about the patient.
So does telehealth baby deliveries happen very often?
Not really, no. They tend to deliver really quick when they do come, so they haven't got time to link up.
Now, do you find that you talk about nurses, RNs delivering the babies, and that where are the doctors while this is occurring?
Yeah, no, they come over. They come over and they on call 24/7. So they as soon as they're on their phone call away, so they come over.
Now, what about other things like mental health treatment services and things like that at Walgett? What are the services like there?
It's very poor because our mental health is at the Ridge, and they only service us once a week, maybe every fortnight, and so all our clients are missing out on all that service.
When you say
we used to have, sorry.
No, I cut you off.
We used to have mental health on site, but they retracted to the Ridge.
Right. When you say the Ridge, you mean Lightning Ridge?
Yeah, sorry, Ridge.
Okay, that's all right. So
they have a full team out there.
So is there a long waiting list for mental health services in Walgett?
Yes.
How long would a person wait for to see?
They wait to see somebody.
Yeah.
Over 2 weeks.
2 weeks. Now part of this.
Sorry.
No, sorry.
Not even that. Sometimes they have to wait at least 3 weeks because mental health worker might be or
now
they haven't got a counsellor there.
Now, as part of this inquiry, we make recommendations to the government. So what would you like to see to improve? What would make your job? How could you better serve the community out there? What could government do to assist you and other nurses?
To have a mental health worker on site will really help our community because we have got heaps of mental health clients in town.
When you say mental health, what without revealing people's identities, but what kind of challenges would they be facing? What would they be worried about? What would they be experiencing?
The clients or us?
The clients.
Clients, mainly counselling, like a lot of them like face-to-face talking to them. They don't like the video link up or phone calls.
Now, as a First Nation person, do you find that you, in fact, have to encourage or sort of prod other people along to get mental health treatment and assistance, medical treatment in the community out there?
Yes. We tend to go out in the community and talk to them because most of the people in Walgett I'm mainly related to anyway. I've got a big family, so I tend to go out and talk to them, and they relate to me, so I bring them in.
Now, I'm just mindful of my time here. I'll ask you one last question. Now, what about drug abuse, ICE, and other problems? Does Walgett have a problem in that area?
Heaps. We've got heaps of sellers in town that they bring in all the time, and we get heaps in the hospital. We had one the other day that, they used heaps of drugs on him and nothing happened. So, and because we've got no security guards, there's nothing there for the nurses, so they lock themselves in the nurses' station.
You have no security guards. What do the nurses do at night who are on night duty?
Well, that's it. We don't have any security on nights. Or evening shift.
So what occurs? You said they lock themselves into the nurses' station. Is that?
Well, there's not much they can do if the person goes off.
And what about local police?
It takes them a while to get up here to call them on a night shift.
So, can I ask you a really direct question? How do you continue to do this, to work, facing all these challenges?
Because I love the job. I love the community. I love my mob. Just to keep them safe.
Thank you.
Thank you.
Thank you.
Deputy Chair, Honourable Mayor Hurst.
Thank you, Chair, and thank you both for coming here today and speaking with us. We know that obviously understaffing of nurses in rural and remote hospitals has been raised as a major issue within this inquiry. I just wanted to hear a bit about what your experience has been and how understaffing has potentially impacted your work.
It impacts mainly on the patient that we look after, because they could be sitting in the beds, and because if we got a trauma somewhere else, that patient is left in that bed because we haven't got enough staff to nurse them.
In one of the other groups we spoke to nurses and the stress about, you know, if someone is sick or if someone had to take time off for something. Is that something that you're experiencing there as well?
Yes, yeah. That means more people do overtime than before, and there's not enough staff to call in on our casual list, so the nursing staff that's here has to pick it up.
And so what could that mean? So just to give us an understanding, I mean, what could that mean? If somebody had to pick up extra shifts, how many hours could they potentially be doing in a week if there was some kind of an emergency with other staff?
Yeah. They could do up to 3 to 4 overtime shifts a week.
And so that would be an extra 8-hour shift, 3 to 4 extra 8-hour shifts beyond the average sort of 5 days a week.
So, yeah. And when we had the pandemic, the girls were doing overtime over the weekend just to do the swabbing and that. So they was working 24/7, you know.
Yeah, many extra hours, and obviously that's going to lead to a lot of burnout for people. Have you sort of seen staff burning out, and what's their experience been?
Their experience, well, I've known one nurse that can't take time off because she needed out to hospital, so she can't take her holidays, which she is due. She's overdue actually, so she's got to stick around.
And what do you think, you know, I know the Honourable Watts-Secord sort of asked, you know, what sort of recommendations would you like to see from this inquiry, but I just want to sort of hone in specifically on this situation. You know, what do you think we need to do to address this situation? Is it a matter of having minimum staffing ratios, or is it much more than that?
I reckon we should start training people, training more staff.
And so do you think that there needs to be more funding generally, or do you think we need to sort of have funding specifically for more staff and training more staff?
Training more staff in rural and remote, like through the TAFE, like we've got a good TAFE here that can run courses to sustain more local people here in the towns that know the community. But yeah, that's what we need funding for, those sort of things. Or if we can do it on country, people don't have to go away to do the training. They got all the support here in Walgett with their families if they have to do the training, and they don't have to worry about finance or anything when they go away.
Yeah.
Yeah, they have to go to Dubbo, to do the course, which is 3 hours away or more, away from, be isolated and away from the family.
Do you find that people are resistant to going to do that training because it's so far away? Is that one of the reasons that it's acting as a disincentive?
Yeah. The isolation, plus the finance staying somewhere while you're over there doing the training.
Yeah.
And plus about your family at home. You know, your small kids that you're doing the training.
Do you think that we need more incentives for nurses to also move into the area? And if so, you know, what do you think that would look like?
Well, I know they did incentives before with nurses.
Do you recall if that worked? Did it help the situation at the time?
It did work for a little while, but I find that if you did do that, you have to have some sort of thing on it where they stay around for so many years.
Right.
Come here for that incentive for that long and then go. You know what I mean? Or up and go.
Yeah. Just in regards to the training, I'm just wondering what sort of, if you have any sort of idea around what sort of additional training, continuing education. I know we talked about training more nurses up, but we've had a lot of evidence given at the inquiry that a lot of the nurses that are already nurses are not provided access, to further training that other Metro colleagues are often given. And I'm wondering if you think that that's something that's also missing and what you would like to see there.
Oh, I'd like to see the training beyond country, really, because most of the Aboriginal people love their country, and going outside their country, it just breaks down. Then they do going off country.
Thank you.
But if you do training in TAFE, or get them into TAFE and do the training that's done in Dubbo, which is 3 hours away, do the training here in Walgett, maybe that'll be a way to train them all up to grow our own local staff.
Thank you.
Thank you.
We'll now move questioning to Kay Fairman.
Thank you, Chair, and thank you both very much for agreeing to appear today and for the very important work you do in Walgett. I just want to, my first question is around the alcohol and other drugs rehabilitation kind of services and support issue. So in Walgett at the moment, what is available to people who need treatment? Like if they go maybe and talk to somebody like a doctor or in the health centre, like is there any services or any alcohol and other drug specialised health workers at all?
We got one at the AMS, but she's only just came. She's fantastic in her job, loves her job, but she's not sticking around, she said. So once she's gone, we've got no one. And the rehabilitation centres are all like Orange, Dubbo. The centres are all down that way. Like we have got two not far away, like Bree and Moree, but I find that as soon as they go there and they come straight back, they're straight into it again. But I find if they go down to Dubbo or Bathurst, they're so much better, where they got the counselling and people that understand it.
Yeah, so getting to Dubbo and Bathurst then, so that's good to know that can be effective for a start, but then they come back, so they need the support. They need the kind of support. You need the support in Walgett. You said there's one woman who has started just recently as specifically trained. Yes. So unfortunately isn't sticking around.
No.
Is that because, without maybe, but do you think it's just because it's just too hard?
No, it's not hard. Not hard for her. It's because her family. She wants to move closer to her family.
Yeah.
And she's fantastic, and she's Indigenous and know the community. So, but we're losing her, so we've got no one after she goes.
And that's sorry.
And it's a big population of drug and alcohol here.
Yes. Yeah. And so the AMS, they recognise that it's a need. Will that be a vacancy then? That is a funded position that will need to be refilled again. Is that your understanding? Do you know?
Yeah, I think they will. I think they will try and fill it, but it's just trying to get the staff out this way.
Can I check as well in terms of beds or anything? So having the counselling, the staff is one thing. So it's great that there has been this woman in that position for a little bit. But are there any, if they need treatment in terms of getting into a rehab bed, there's nothing. Is that right in Walgett? It's just the worker that they see, and then for any other service they need to go elsewhere.
It's the worker they see. And then they go.
Yeah. And then they come back with that. Okay. I wanted the mental health worker as well that you mentioned in response to the question by the Honourable Secord, who you said that they've relocated that. That was a conscious decision, was it, to move a mental, get rid of the position of a mental health worker in Walgett and move it somewhere else?
I'll have to find that out. All of a sudden they were there, next minute they were gone. Mm-hmm. Yeah, we did have a drug and alcohol worker for Walgett Hospital, and that was gone too.
Yeah. Over the last, say, 10 years or so, is it getting worse in Walgett, do you think, in terms of their health services? I mean, it's probably always been pretty shocking. I was trying to think of a word without swearing. Pretty shocking. Is it?
It is getting worse, because I found out the other day we've got no nursing staff for February. So the hospital will have to shut down.
What?
Yeah. That's how bad it is, because we can't get any staffing in to cover those shifts.
Wait, so shutting down, what do you
like the services here?
Yeah.
There's not enough staff to cover shifts.
So you shut down
we shut the beds down. We shut beds down. And they have to relocate, send them on to Dubbo or wherever.
Have you shut down before for a month?
We have shut beds because of the staffing here.
When you say shut down in February, do you mean shut down all the beds? Or just...
No, just partly the beds, yeah.
Yeah, and so when you've shut down before, does that mean that people who need critical health support and services have to... I suppose from experience, have you seen bad outcomes as a result of that? Like, is it people not being able to get the medical services that they need at the time?
They'll get the services, but they'll get the service for a short time, then they have to go out to Dubbo. And once they're in Dubbo, they've got to find their own way back home.
Yes, so that is another
issue.
Big issue, isn't it? The transport. We have heard that issue a lot.
Yeah.
Did you want to maybe tell the committee what that is?
That means when they get to Dubbo, they get transported out of here by air ambulance or road transport. And once they get to Dubbo, they are put out of the hospital once they get well, and then they find their own way back to Walgett. So most people object to going there. They'll sign themselves out.
Thank you. Thank you. I would just move over to government questions. We've got the Honourable Trevor Khan.
Betty, thanks for being here. So can I just get some sort of context in terms of Walgett, because I'm interested in this issue of training on country and whether that's feasible. Am I right that Walgett itself has about 2,500 people in it?
Yep.
I'm not asking for precise numbers, but that's as I recollect the sort of size of the town. And in terms of Walgett Shire itself, that's 6,000 or 7,000 people?
Yeah, the smoke there, the region collie comes into it.
Yeah. Well, you, like me, have been around for a while. What's the population of Walgett been like, say, since the 80s? Has it gone up, gone down, stagnated? What's the position been?
I reckon it's gone down a bit, but most people go away, but they come back. When they get sick, they come back to Walgett.
Sure. So do I take it that, in a sense, what you've got is a young population and an old population, that sort of the middle is hollowed out a bit?
Yeah.
So to that extent, you've got problems with chronic disease in the elderly. Would that be right?
Yeah.
And you've obviously...
Yes, we have.
Sorry, I don't want to talk over the top of you. And you have the paediatric issues, both in terms of births and problems with childhood illnesses and the like. Is that what you're confronting in terms of your work?
Yeah, that in palliative care.
Yeah.
Yeah.
Yeah, we haven't really talked much about palliative care with you, but we might. No, that's not your fault. We just haven't got there yet.
Yeah.
Let me just go to the training exercise. Tell me something about the size of the TAFE that you've got there.
It's fairly big, the TAFE. I don't know how many staff they have on board or whatever.
Sure. And what trades and the like, or what courses are taught there?
I don't know.
Not nursing.
But I'll get back to you.
Not nursing.
Yeah.
Not nursing. I know there's not nursing.
And when you talk about training on country and it being done at the TAFE, are you talking about courses for RNs or enrolled nurses?
Well, if you do training from an AIN, maybe start doing the AIN, then into an EN.
Yeah.
And maybe an RN. Maybe they all go away for the RN.
Yeah.
Right, but get them involved in the first bit, first enrolment.
Yep.
To get them up to that level.
Yeah, I'm not being critical, but it's my guesstimate was you weren't going to be able to train RNs there simply because of the skill levels that are involved.
No, you've got to go away for uni.
Yeah. All right.
But if they do the AIN, then the EN.
Yep. That would be feasible. So how many, and I'll break it down into its component parts, in terms of your place of work, the MPS, how many RNs are employed there?
Don't know. I'll have to get back to you because it changes. Like we've got
She's right.
New ones that's just starting.
Right.
Today, yeah.
And ENs, you got any idea on that front? It's all right. You can get back to us. That's fine.
I'll get back to you.
Yeah. Because to be honest, I'm interested in the MPS model. Having seen them in other areas, I don't think I ever visited it in Walgett. But essentially, do I take it that you've got essentially an ambulance facility there, the hospital facility, and an aged care facility all rolled into one? Is that what you've got there?
And also we've got a renal dialysis unit.
I was going to ask that, yeah. And how many chairs have you got?
We've got 4 chairs and it's run 6 days a week and there's 7 clients.
Right. And who, is it one of the RNs who essentially supervises the dialysis chairs?
Yes.
So if we were being...
And that one... Yeah, sorry.
No, you go on.
No, and that runs by Dubbo.
Right. Now, and samples and the like all go back to Dubbo. That's essentially your centre of... You're essentially a spoke out of Dubbo. That's right, isn't it?
Yeah, that's it. Yeah.
Right. So if somebody's got severe renal failure, they'll be shipped off one way or the other to Dubbo.
Yes, by ambulance, yeah.
Right. And do I take it that even though I think by distance you're closer to, for instance, Narrabri, there's really no communication along that line of...
No.
And similarly, Moree, that's not a line of essential communication or provision of services. Right.
No, that's outside our boundary.
Right. And so we then go back to the issue of training. If you're going to get nurses into your MPS, the likely route is through Dubbo, training in Dubbo and then out to Walgett. Would that be right? Are your RNs First Nations or are they're not? Any?
No.
None?
None.
Right. And those are...
It's only me.
Only you. Right. Fair enough. Well, you're doing a good job. I take it that those RNs that come there are relatively young, are they, when they arrive?
Yes.
and I'm not trying to put words in your mouth, do they stay there, do some additional training and then head out again? Is that a problem that you're confronting in terms of holding staff, or am I wrong in that regard?
Yeah, no, they come and go, yeah.
And are they with family there, or are they single?
They're single, but some of them hook up with some of the locals.
Well, that's good.
Stay.
Yeah.
Yeah, but there's not many of them.
Yeah, well, if they hook up with locals, they're likely to stay. But the problem is being single and in a small country town, you're likely to lose them again after a period of time. Yeah.
That's right.
And in terms of the doctors that service the MPS, are they sort of in a similar category, that they're from Dubbo, stay there for a while and go, or they more long-termers? Or are they locums?
No, they come and go. Like, they stay for a few months, couple of months, or a month, and then they go again and they switch over.
Right. Let me just go back to the MPS model for a while. Before you had how long has the MPS been there?
2016, it was there.
Right. Oh, it's a relatively new one of the model. So before that, how was aged care provided in Walgett?
How was it?
Yeah. Was there a separate aged care facility there?
It was a different building.
Right.
To the nursing and acute ward. So there was two over there at all times. Mm-hmm. Nurses. I'm pretty sure we had three or four over the other side, acute ward, because we had the babies and baby ward and the acute ward and men's ward and female ward. Yeah.
Right. So do I take it that what the consolidation of the services into an MPS has done is it's allowed the available staff to cover essentially all the aspects of care from birth through to, dare I say, death in the one facility?
Yes.
All right. Wes,
yeah, I'll just ask a few questions if you wouldn't mind. And I just wanted to say, firstly, thank you for appearing today. I think it's fantastic to be able to get some insights from you directly with your on-the-ground experience. I'm very keen to hear about your thoughts on training more First Nations people locally in order to be a part of the health process, whether it be ENs or the like. Do you have some thoughts around how we can encourage greater consideration by First Nations people, not only in, let's say, regional centres, but those remote centres as well, to let them know that it is an option for them. How do we get through to the younger generation that it's something that they can aspire to?
Well, most of the ones I've seen have seen me working here at the MPS for all them years, and I think a couple of them went through nursing because of me, because of what I've done. So, they all know that I work here and been here forever. So, to me, to encourage them would be really good. Like, I will encourage a lot of young people.
So can I suggest then a scheme of mentoring would be a good way to actually do that? Well, thank you. I just heard the buzzer go. My time's up, but thank you again so much for appearing today.
Thank you. Just before we go, just a matter of clarification on a matter that's been raised. So just the Honourable Walt Secord.
Yeah. Ms Kennedy, when you talked about the hospital having to close down in February,
yep.
So you will not be taking...
It's the beds. It'll be the beds.
It's the bed, so it means that you won't be taking patients in the hospital in February because you won't have enough staff. So where will the patients go? Where will they go?
The ones that's critical will go to Dubbo.
And the less critical ones, what will happen to them?
The less critical ones, well, they'll manage around who's there with the staffing, like only a shortage of staff, so they'll manage with whatever they got. But if there's anything that comes in major, they'll just ship out.
So what will the hospital be doing? What will be happening in the hospital at the time?
Well, the hospital, there will be staff there, but they'll be looking after the aged care, and they'll be looking after dialysis. Like we can't stop dialysis because...
No, you sure can't.
No, you can't stop dialysis.
No.
Thank you.
No, well, yeah.
Okay. Thank you, Mrs. Kennedy.
Yeah, thank you.
Well, thank you. Thank you very much, and thank you both for being available this afternoon. I did want to mention to both you, Betty and Katrina, our plan had been earlier in the year to come to Walgett and that part of the state to actually be on the ground, so to speak. And I know the Honourable Kate Fairman in particular has an interest in Indigenous health and wanted to sort of be up there and be able to talk to people on the ground. But for the reasons we all know of, that's not been available. So it's our second best option, I have to say, doing it remotely, but it is a way of doing it, and we appreciate this. We know what the telehealth experience is like. We're getting a real feel of what telehealth is like. So once again, on behalf of the committee, all of us, thank you so much, and thank you for the wonderful work you do up there in the community. Thank you.
Thank you.
Okay.
Thank you.
Bye.
Thank you very much. So let's move then to our next pair of witnesses. We'll do a quick changeover. Thanks.
Good afternoon, Mr. Kennedy and Auntie Monica. Have you got your cameras on, or are you calling in via phone? Mr. Kennedy, can you hear me? Hi, Mr. Kennedy. Can you hear me? Fantastic. Thank you so much. Auntie Monica, are you there? Yeah. Will you be using your video today?
We can't see you, Auntie Monica. We can hear you, but we can't see you.
Oh, there we are.
Oh, beauty. We got you.
See me?
Yep. Can you hear us?
Yeah.
And Mr. Kennedy, can you hear us?
Yeah, everyone, yep.
Good on you. Okay, well, thanks. It's great. We've got you both. So let's get underway with our next session. And can I commence by thanking you both very much for making yourself available to provide some evidence to us today in our inquiry, which, as you know, is to do with matters of health provision, the delivery of services and health outcomes in regional, rural and remote New South Wales. We have a formal part to get through first to enable you to give evidence to the inquiry this afternoon. And what I'll need, and I'll start with you, is it all right if I call you Auntie Monica? Is that okay? Yeah. To state your full name. If you're appearing in your own capacity this afternoon, just say that I'm appearing on behalf of myself, and then to swear either an oath or an affirmation. They're two separate ways of providing your evidence, and you should have been given the words to the one you selected. And then we'll do that with you, Auntie Monica, and then we'll move over to Mr. Kennedy and do you. So, Auntie Monica, could you please follow the procedure then?
Yeah, my name's Monica Herwin. I was invited to speak at this.
Right.
So here and
excellent.
I was invited.
Yeah.
I don't know if you know, I'll just swear to tell the truth, I suppose.
Okay, well, we've got some words. No, that's okay. No. There are some particular words. Just to do it, I've got to do it properly because it stands as evidence to the inquiry. So we just need to do the words for the. Will you take the oath? Would that be what you'd like to do, or the affirmation? I'll read the words out and you can repeat. Yeah. So, would you take the oath, Auntie Monica? Shall I read that out to you? You repeat the words? Okay, so...
I think she's having technical issues.
Okay, sure. Can you hear me, Auntie Monica?
Seems to be a delay. There you go.
Okay. If you could just repeat these words. I swear that the evidence now...
I swear that the evidence now...
about to be given by me...
about to be given by me...
shall be the truth...
shall be the truth...
the whole truth...
the whole truth...
and nothing but the truth...
nothing but the truth...
so help me God.
So help me God.
Thank you very much. Now, Mr Kennedy, the same for you. If you could just follow that same procedure, name, title if you're representing an organisation, and then the oath affirmation.
Yeah, my name is Michael Kennedy and I'm the chairperson of the Wilkenya Local Aboriginal Land Council.
Right.
I'll take the oath.
Thank you.
I swear that the evidence now to be given by me shall be the truth and nothing but the truth, so help me God.
Thank you very much, Mr Kennedy, and thank you also once again for making yourself available this afternoon. Now, what we'll do now, and this is what we normally do, is invite both of you to make what we call an opening statement, to say a few words to set things up before we actually ask the questions. So you would have been informed about that. So if we start with Auntie Monica, would you like to make an opening statement, Auntie Monica?
Yeah. No, thanks.
Yeah, I would. How long have I got?
Listen, keep it to about between 3 and 5 minutes. That'd be great because there'll be lots of questions that arise from that. So, yeah, 3 or 5 minutes, that's fine.
I'll do. Can I have 3 minutes? Like I'm in a game show here.
Yeah. Everyone's a winner at our inquiry, Auntie Monica. Everyone's a winner. So you take your time. 3 minutes is fine.
3 minutes, and then for the last minute, can I please have that as a minute silence?
You certainly can. You certainly can.
And you can say, I don't know what to call you, sir. You know, Your Honour, I don't know.
Just Greg will be fine. Greg.
Greg?
Yep.
Cheers, but yeah, I'll have the last minute of my statement be a minute silence.
Most certainly.
That's all right with everyone on here?
Certainly is.
Thank you. Basically, about me, I'm born and raised in Wilkenya. Grew up there, lived there all my life, never moved away. You know, seen our Aboriginal people, you know, their highest time of their lives and then seen them in their lowest times, you know, basically know everybody in my community. I love where I live. You know, standing up for our Aboriginal. I believe it's cast something I woke up one day and decided to do, but to stand up for a lot of Aboriginal issues in our community, and health is one of them. You know, well, basically I love my community, I love my people, and, you know, I want to see them being treated right, fairly, by a government that, you know, we're all vote for. I don't know, just to see better outcomes for our people, our community.
Okay.
That's really what I want to say here. You know, I just recently lost a son to suicide. So today is probably emotional, but still want to do this. Mental health plays hardly plays a role in it. Never did. Something I want to see our men, is mental health. Be more out there, fellas, you know. Sort of just, I wanted to speak today.
We appreciate you very much doing that.
If I can spend the last, my time here, just a minute of silence, just remembering and all the other tragic losses over the past 12 months here, where I am off right now.
Yeah.
It's been 12 months, I'd have to say.
Okay. Shall we? Sorry. Shall we honour your son with that minute's silence, Auntie Monica?
Thank you.
Perhaps I think we'd like to do that by standing up and showing the respect and honour he deserves. So we'll all stand in for a minute's silence. Thank you. Can you hear us, Auntie Monica, still?
Thank you.
May I ask, Auntie Monica, what was your son's name? Mark. So it must be a tragic loss.
Can't believe it, but got to do this, got to talk.
Yeah. Well, may his soul rest in peace, and we are very saddened to hear what's happened to your son, Mark, and of course the loss of all lives to suicide, particularly amongst our Indigenous brothers and sisters in communities all around the state. So appreciate you being very strong, Auntie Monica, and agreeing to come along today and share. It must be a very difficult time for you, and we thank you for that. Can we move now, thanks Auntie Monica, to Mr Kennedy. Would you like to make an opening statement?
Yes, so just to follow on from Monica, I'm the same. I'm born and raised in Kenya almost. And, it is one of the main concerns that we have in our community is suicide, but it's right across the board in health. Like it's not just suicide, it's our health conditions in Kenya. And, what frustrates me the most is we've got 3 different health organisations running our community and we're going backwards. Like, our people die. On average, a male in Kenya only lives to 37 years of age. A female, 41, 42 years of age. Like, it's quite alarming that, we have 3 health organisations in Kenya, and in the year 2021, this is our statistics. We are one of the most disadvantaged communities in the country. And we're in the year 2021. Like, I think with health, there's a lot of concern and a lot of questions need to be raised around health. You know, the more you look into it, the more you'll see and uncover out here for us. But, you know, that's probably is 37 for a male and 41 for a female. We've got 3 health organisations, and that's our life expectancy in Kenya. I'm 39 years of age now, and every day I wake up, I thank God, our God, that I'm still alive. You know, like Monica, she's in another very difficult situation where the nearest dialysis machine from Kenya is 200 kilometres away. Travel three days a week for dialysis. That's, you know, that's a 1,200 kilometre a week trip for them. You know, that's the 5,000 a month that they have to do. And we have another lady in Kenya, an elder that's well into her 80s. She has to do the same thing, travel near 5,000 kilometres a month for dialysis. You know, and we're in the year 2021, like we've got 3 healthers. So it's very fighting around health out here with a lot of issues, with suicide, with you know, the amount of travelling that people have to do, and just all the other underlying health issues that we have in our community.
Well, thank you. That's very helpful, Mr. Kennedy. That adds to the important information that Aunty Monica was able to describe to us in her opening statement. Is there anything else you'd like to say in your opening statement, or can we move to questions? What would you like? Can we move to questions?
Yeah, you could move the questions, mate.
Thank you very much. And that provides approximately 10 minutes each for each of the groups around the table. So we'll start with the opposition, the Honourable Walt Secord.
Thank you, Mr. Chair. Mr. Kennedy, now, people in Sydney, the most recent knowledge or reference that they would have had involving Wilcannia has been the COVID outbreak. What's the situation at the moment, and how is the community responding post the outbreak?
There's still a lot of fear around. There's still a lot of uncertainty because, you know, there's always things change around COVID. It's such a young virus that there's still things being learnt about it. So there's a lot of uncertainty and a lot of fear. You know, everyone in the community, their anxiety levels, their stress levels, depression levels are all pretty high at the moment because we've just been through so much, you know, the COVID outbreak in the community. And then, as Aunty Mon said, she lost her son to suicide, but we've also had another young lady in the community that was lost to suicide. We had another male that was lost a couple of weeks ago through a car accident. So this community at the moment, over the last few months, has been through a real, you know, it's just frustrating, it's heartbreaking, it's stressful, it's depressing, but we try to find a way each day to keep going.
You mentioned, and Aunty Monica mentioned, 3 health organisations. Is there duplication? Is there overlap, or is there simply 3 not enough? What is the situation? You mentioned several times 3 health organisations. Can you bring me up to speed on that?
I think the 3 health organisations is enough, and I think we should, you know, be a lot further ahead with 3 health organisations. But I think one of the main problems is they just simply don't work together. There's the 3 organisations are run by different departments, so they really don't communicate to one another, and they're just not on the same level or not working together. So, you know, all our little communities out here can get the best outcome with 3 health organisations. think that's the main problem, is they're just not working together.
Auntie Monica, on your how does engagement or how do mental health services work in with the Aboriginal community, the Indigenous community out there?
I don't think any of mental health actually, found any of COVID cases. If I'm just going to go from COVID and then right across the board with this, because the thing with it is, when COVID hit our community, like Michael, my nephew, said there, he, their mental state was a lot of fear, like, is this it? Is this the day, I'm going to die? They had help bring them symptoms. No mental health has rang them regarding the mental side of what they were experiencing. And, a lot of the family, they were really scared.
We may have just lost Auntie Monica, the connection.
No, are you there?
Are you back? Good on you. We got you back.
So mental health really didn't step up to the plate here. Not out of any of those organisations, like the three that we said, Greater Western, Murray and Royal Flying Doctor. Now, since losing my son, I had the Royal Flying Doctor come in. Murray didn't come in. I'm a Murray client. They get funding because I'm a statistic. But they have not been doing what they're supposed to do in our community regarding mental health. And not only mental health, but a lot of the other underlying health issues that, chronic disease. We have a lot of things around, a lot of our people have got chronic disease, diabetes, heart troubles and all of this, and then you got hit with a virus and not one of them came to the table to even do a little simple welfare check on people. I understand them from a lot of the families when I spoke to them after all this COVID, came and went, I asked them about did mental health ring them. They said health rang us. They was asking questions, how am I feeling? And it was more so towards the symptoms is what the people were saying, that they were asking questions around, not their mental health side of it. Not the, the shock and, the fear and all of that. It was more so they were concerned about the symptoms. And it scared a lot of people because, nobody actually asked them about their well-being. And they were scared, they were angry and felt like they were alone and nobody really cared. So, just what Michael was saying, they need to be more out there. We see a lot of their assets in our community. Their pools of cars, their houses, but we don't see what they're supposed to be servicing us with. We don't see the clinics, the on the ground, the home visits, even things like, we don't see a lot of that. And like Cass said with the dialysis, they're still trying to, I don't know what they're doing, but we do need a dialysis. I'm not just saying for my husband. Like Michael said, there's an elderly lady, as well as another elderly lady living away because she can't come home. X-ray machines, we need a lot of mental health on the ground. Building relationships with people. People, we like to talk face to face. We need to know that you actually genuinely care. you know, as opposed to somebody who'll die in and we say they're only in the job for the pay packet. So, you know, I'm angry with health. I am. And it's not just with the mental health side, but it's right across the board. Michael said, you know, it's decaying health out in our community. 3 health organisations. People are dying. People are dying, and not from COVID. You know, not from a disease, but from all the other things that, you know, they've been denied.
Michael, maybe you could assist now. You both have referred to kidney dialysis and the great distances that people have to travel. So is there no kidney dialysis chair in Wilcannia at this moment?
No.
No. Has there ever been a kidney dialysis chair in Wilcannia?
You asking me or Michael?
Whoever wants to answer. Monica, you got the microphone.
Yeah, I've never known a dialysis or kidney chair to be in Wilcannia since I've ever lived there. Everybody that suffered from dialysis have had to move to Broken Hill, which is 200 kilometres away, or do what only one and the other old elders doing in town and travel over 3 days a week.
Are there enough people who need kidney dialysis in Wilcannia to have a chair there?
Well, we have 3 here at the moment, and before the speed that we've got in, we had 2 that had to move away. One of our other old uncles, you know, Broken Hill, and then lost his life in Broken Hill. You know, us as Aboriginal people, for us to move off our country where we're originally from, it's one of the biggest heartbreaking things that could ever happen to us. Like, we cannot leave our country. We're too spiritually connected to our country, where we're from, tribe in the country, you know. So for elders like that to move 200 kilometres or 600 kilometres away for dialysis, that's probably killing them just as much as the actual disease, because mentally and spiritually they're disconnected from their country, and it breaks our elders down massively because of that, you know. So yeah, I don't know if anyone's got anything to add to that.
Yeah, no, we desperately do need one. Like Michael said, you know, we never have had one in Wilcannia in all my 50 years. You know, I turned 53 last week, you know, and never. The talk was on the table, but nothing was, you know, nothing. There's no dialysis there whatsoever.
Okay. Thank you. Thank you both. We'll now move our questions to the crossbench. The Honourable Emma Hurst.
Thank you.
Yeah.
Thank you, Chair. And thank you both for coming. And I just want to say sorry to Auntie Monica for your loss, and thank you for your strength for coming today. And I understand, obviously, the reason you're coming here today to talk to us, even though you're going through such a difficult time, is because, you know, you want to make sure that the community has a spokesperson. And so I suppose I just wanted to ask a really open, broad question. You know, being somebody that's speaking on behalf of your community, what do you think that the government needs to really know and understand about the day-to-day experience of your community, and what needs to really change?
The government needs to listen a lot more to, you know, grassroots people on the ground, not an employee of an organisation that is government funded, but actual grassroots people living in the daily conditions that we do live in. You know, and changes. We need changes in our health structure. We, you know, according to, you know, statistics that they have, with chronic disease, statistics with diabetes. All these areas need to be properly addressed by our health services, the health system, with government. The funding need to be spent properly on, according to our community and the people's health issues, like diabetes. We don't know very much about diabetes, but, to a lot of our Aboriginal people, that's been the silent cancer killer. There's not a lot of advertising out there or knowledge as to how you get diabetes. We know that unhealthy living is one of them. We'll start looking at, the housing conditions. Your house is falling down and, you have to pay high rent and, you can't afford, the food and things where you live. Not everybody can travel to Broken Hill. Health plays a vital role, if not the leading role, in our well-being, our survival. And you look at all the social, emotional stuff that comes under health. Just not with, heart disease and things, but a lot of, the mental side and all of that. Health plays, if not the major role, in looking after our people and catering properly for our people. You go to meetings in your community and you're dictated to by health professionals or people employed in service providers. And we don't need dictators. We need the proper health care that the Australian government can possibly give us. Our river system, the way that is, health plays a very big, important role in our community, and it needs to be addressed properly, and it needs to be looked at, and not only that, I'll just go a minute here, but listen to the grassroots people, the people that have ill health, people that are going through what they're going through on a daily basis. They are the ones government need to listen to on the ground. So,
yeah.
I don't know if I answered it right.
No, you have, yeah. Thank you. And just sort of following on from what you said, do you feel that, you use the word dictatorship, that it almost feels like there's a dictatorship within the health system and that the people at the grassroots aren't being listened to? Do you feel that, that's really destroying the trust in some way with the local healthcare system? That lack of proper consultation?
Yes, because with the 3 health providers we do have, all of them have a duty of care to the people. You go in there and they'll palm you off to Murrima. You go into Murrima, they'll palm you off to RFDS. We don't know who is supposed to be actually servicing us or providing a service to our community in health, but more, you you need to see this one. But when you question them, you're spoken down to, and it's like you throw your hands in the air and walk away and say, I don't want to even bother with talking to anyone here. So a lot of our people, feel being mistreated and dictated to or spoken down to or was provided to go to in our little 7-bedroom hospital where all these service providers operate out. They give up on their own health.
Thank you, Annie Monica.
I don't know. Yeah, thank you.
Thank you.
We'll move to Kate Fairman. We've just lost our connection with Mr Kennedy, which we hope to restore. So, Kate, presently we've just got Annie Monica with us.
Thank you, Chair, and hi, Annie Monica. I also want to just say I'm very sorry, so sorry to hear about your son, Mark, and thank you for still coming here today to talk with us. It's so important, and thanks for having the courage to do that. I wanted to if you're able to, I wanted to ask specifically about what is available or should have been available, because I think Michael just spoke, well, not I think, he did spoke earlier about other recent suicides. So what would you have liked to have seen in place to help Mark and others like him in Wilcannia?
We would like a mental health worker living in our community. You know, maybe 2 or 3 of them, you know, but we definitely need one. One that has to build a relationship with the people, because, you know, that's important, that our people trust. We know, you know, there's confidentiality, but it's not about the confidentiality, it's about the trust. You know, I have to really trust somebody now to go and talk to them about anything and everything. You know, and really we need it living community mental health workers. I don't need them. We don't need, they wanted us, we needed a busload in during COVID. I said, no, we need to isolate people. Don't bring us a busload of counsellors in here to wander around door knocking, just randomly want to talk to people for the sake of talking to them. No, build a relationship with people so they trust you enough. Like, you know, Michael said, that young girl, you know, she was in her 30s. My son is only 34. They're a month apart. You know, a month apart that they committed suicide. She's a young mum of 4. Whatever mental issues was going on behind closed doors for both of them, my son included, you know, at least if a counsellor was available, you know, every day in that community, 9 to 5 every day, my son wouldn't have died the way he died. He would have been able to know that, okay, I can go, I know this fella, I can have a talk with him. That young girl, I know this counsellor, I build a relationship. That's what it's about. Building trust, building the trust up. We'll get the people talking, and that's what's needed. You know, millions of dollars got poured into mental health, and Wilcannia never seen one counsellor through COVID that we know of. You know, so I don't know, that's money that was wasted, or I don't know where it went to, but our little community never received a phone call from a mental health worker. You know, want people to, you know, welfare checks on them every day is good enough. You know, that was involved in that car accident, you know, a few weeks ago. The survivors of it. They need mental health. You know, the husband and wife, they're going through hell because they're blaming one another. You know, the trauma of losing, but their son that died in that accident is well in his 50s, 60s, you know. But they need counselling. They're a very private family, you know. We need counsellors, but we need them to live in our community, not come in clinic days, 3 days a week.
Thank you, Auntie Monica. That's very much heard loud and clear, I think. Can I also ask, this is similar, I think, in terms of the services available, what about, so if somebody wants to, so for drug and alcohol and other drug treatment, what is there available in Wilcannia? Are there any services? We've just been speaking to people previously in Walgett, for example, Betty in Walgett, about the lack of services there. Is Wilcannia similar, or are there services there in Wilcannia for alcohol and other drug treatment or support?
We have drug and alcohol counsellors come in, but that's because of the substance abuse.
Yeah.
There's a difference.
Yes.
With substance abuse.
Do you have a further question before you come to us?
The underlying problem that's been grinded down day after day, the mental side, you know, of people's issues. We do have drug and alcohol, but they're ordered through courts a lot of the times. You know, people are ordered to see them through courts and they got no choice. So really, you know, to get out of jail, they got to go and see a drug and alcohol worker. But drug and alcohol is not the issue. You know, there's other issues. That's a Band-Aid. Drugs and alcohol amongst our community and our people is a Band-Aid to numb from whatever it is that's torturing us daily now.
Yes, and to clarify, Auntie Monica, I'm I've been asking all witnesses about mental health, about alcohol and drug rehabilitation support services in regional and remote New South Wales. So, yeah, absolutely. Just wanted to get your perspective on the services, not saying that is the number one driver or key issue at all. So just to clarify, could I last question, Chair, just in terms of another issue, I just wanted to check as well around dental services in the area. Again, is there anything available there? What happens for dental treatment?
Yeah, they do. They do have that. That's once a week. Hello?
Yeah, yes.
Yeah, once a week they come, or fortnight. Yeah.
Thank you.
Thanks, Kate. We'll move now to government.
Yeah, I'll just ask a couple.
The Honourable Trevor Khan.
Once again, Auntie Monica, can I express my regret and sympathy for the loss of your son? It must be very difficult, and I think it's an outstanding tribute to you that you've been prepared to talk to us today in the circumstances. So I hope it gets better for you. I'm not quite certain who I should ask this to, but I think I'll ask it to Michael because Michael raised these three services, health services that are available. I just want to get some clearer picture as to who's doing what. Do I take it that Marimar provides the primary health care? Is that like your first stop? Is it Marimar? Michael? Oh, sorry, Michael. Yeah. Yeah.
Yeah, really like it. It's pretty much a choice of yours that you want to go and see, whether it be RFDS or Marimar itself. Yeah, the choice is basically yours that you want to go and see.
Right.
You feel comfortable to see.
Right. So how does RFDS deliver its services in the town? Does it, I'm not being funny when I say, does it fly in and provide services as required, or does it actually have a footprint, a building in the place that is staffed full time?
No, they don't have full-time staff here. They fly in from Broken Hill, depending on what it is, 3 days or so a week, I think, that their doctors, GPs are in town.
Right.
All the RFDS staff are flown or driven in. None of them actually are based in Wilkenya.
Right. And so Marimar, what's their position? Are they, in a sense, locally based?
Local health workers.
Yep.
But they're what obviously they can do. The GPs and dental and counselling and everything else like that all comes from Broken Hill and other locations.
Right. And then there is the local health district, the Far West Local Health District. They also have a footprint in the town in the same way, do they?
Yeah, so their nurses based in Wilkenya, but anybody outside of that it's pretty much the same. Everyone comes into town.
Right. All right, Michael. In terms of the nurses, are any of those nurses local First Nations people?
Not that I know of.
And Monica's saying no to that as well, I think. Sorry.
Yeah. B1, which was my auntie, but she passed about 6 years ago, and she was the only qualified nurse that I knew of in our community.
All right. So my understanding is that there's about 750 people who live in Wilcannia. Is that right? Is that around about the population?
Yeah, probably a bit less, but yeah, it's around that.
Right. So is there a local hospital there, or is it something else?
Local hospital that we have here, yep.
Right. And is that an MPS?
Was that, mate?
Sorry. Is that an MPS? A multi-purpose facility?
Purpose. Much, yeah.
Right. So you've been asked about dialysis, and the answer is we've got a cross on that one. And we've been asked about dental services. If I just talk about the kids, what services are provided for the young kids in terms of hearing tests and those sort of things for the pretty young ones?
Absolutely none. So I have that was born at 28 weeks old. My partner had to spend 3 months down in Adelaide Hospital with her.
Right.
And when she turned 1, we were meant to take her back down to see a eye and hearing specialist in Adelaide. We haven't been able to do that, obviously because of COVID.
Yep.
But yeah, we pretty much got to go to Adelaide.
All right. Well, that interests me, Michael, because Wilcannia is, I think, as you've said, about 200 kilometres from Broken Hill. Is that right? So do I take it that what happens is because of the seriousness, your wife and probably while she was pregnant was getting seen in Broken Hill? Would that be right?
Down in Adelaide.
Yeah. But was the link Broken Hill, or was it sort of from Wilcannia to Adelaide?
It was from Adelaide, Broken Hill to Wilcannia.
Yeah. Do you know why actually you're not referred to Dubbo or somewhere else that might be a bit closer than Adelaide? That's a heck of a jump.
Yeah. I'm not too sure, mate. The only thing I could probably think of is maybe because Broken Hill is kind of like under South Australia, which is a bit funny because it's New South Wales, but its connection has a with Adelaide in South Australia.
Right. And so have you heard of other people from Wilcannia being referred for medical treatment in Adelaide apart from yourself?
Everyone that either that was in our situation or has more serious illnesses and stuff like that, if they can't deal with them in Broken Hill, it goes down to Adelaide. The only time they'll send them to Dubbo or Sydney is if there's no room or beds and stuff available in Adelaide.
Right. And so when your wife was being sent from, and again, I think this is, as I understand it, being sent from Broken Hill to Adelaide, how did she get there?
Most of the time, either if you can drive down, they'll supply fuel for you. There's a bus that runs down there once or twice a week, and then aircraft, they might put you on the plane to fly down and back.
And that's on a commercial flight, that's not Royal Flying Doctor Service?
Yeah, that's commercial flight. The only way you'll get by RFDS is if you've been at, and they have to take you down there for, medical reasons.
And how long does it take to get by bus from Broken Hill to Adelaide?
Well, it takes us from Wilkenya, when you drive, it's about a 7.5-hour drive.
Sorry, I missed that.
When you drop from Wilkenya, it's about a 7.5-hour drive. On the bus, I think it's closer to 8-9 hours because the bus has to, do its stops along the way.
Yeah.
And fly down, it's about a 45-minute flight from
Yeah, hardly entirely satisfactory. All right. Well, look, my questions have finished. I want to thank you both again. It really has been helpful and, quite frankly, concerning. So, thank you for the evidence that you've given.
Well, that brings us to the conclusion of this session. So, can I once again thank you both for participating this afternoon. It's been a very significant contribution. Aunty Monica, our sincere condolences, of course, to you and your whole family and the mob there who've lost an important and valued member of the community. We're thinking of you, and we do hope that over time the pain will lessen. But no doubt, though, you've lost a son, and that's something that you can never replace. Michael, thank you very much for the leadership you show and continue to show in your community. The material you provide us today is very raw indeed, but on the other hand, very rich in detail, which we'll be able to use in the preparation of our report and recommendations, which we sincerely hope will contribute to the improvement of matters health services and delivery and outcomes for your part of New South Wales. Can I just say in conclusion, it was our intention, both of you, that we would come up and spend some time with you as part of our inquiry. But as COVID cut its way through the landscape, so to speak, we had to alter our plans some months ago about the wiseness or otherwise of coming up to see you directly in the community. And on balance, the decision was taken that it was best not to do that in the circumstances. And we think we've lost that opportunity. Obviously, this is a second best option, but nevertheless, we wanted to take it up and ensure we're able to collect the valuable evidence you've been able to give us this afternoon. So once again, on behalf of the committee to you both, thank you very much.
Thank you.
Okay, well, we'll just thank you. Good on you. Thank you. We'll now transition to the next group of witnesses.
All complete. All good.
That's unexpected.
No, that's all good.
Yep. Great.
Good afternoon, everyone. My name's Sharon. I'm from the Secretariat and I'll be doing the sound check. Can I check Mr. Davis? Can you hear us?
I can hear you.
Great, we can hear you too. Dr. Burke, are you able to hear me?
I can, thanks.
Thank you. Mr. Grant, can you hear us?
Yep.
Thank you. Ms. Corby, are you there? I'm not able to hear you, Ms. Corby. Just checking if you're on mute.
Good afternoon. Hi, Katrina, Christine.
Oh, fabulous. Thank you both. We'll commence in a second. Thank you.
Thank you very much. Gentlemen, Yama. Long time no see.
Hi, Christine.
Good afternoon, everybody. How are you?
Yeah, keeping dry, eh?
Good on you. Well, thank you all very much for joining us this afternoon. Really appreciate you making your time available. I know you've got various things on your plate that keep you busy, so you've had to carve out some time to spend with us this afternoon. So thank you all very much. My name's Greg Donnelly, and I'm the chair of this committee and the inquiry we're undertaking. Before we hear from you in terms of evidence, we need to go through some standard formalities of having you prepared to give your evidence before the inquiry. So What we'll need is each one of you, and we've got a total of, I think, 5. We should have 5 individuals that we need you to identify yourself by your name, your position title, if you're actually representing an organisation this afternoon. If you're here representing yourself, you ought to say that, but who you represent. And then swear either the oath or an affirmation, whichever you prefer, the words of which should have been provided to you that you can use, but if for some reason you don't have them, let us know and we can provide them to you. So do people understand that procedure we'll now go through? So thank you for that. So I'll just go down the list of the names in front of me. So it's in no particular order, but rather the list of the names. So, excuse me, if we could start with Mr. Davis, if we could get things underway.
Thank you very much. My name is Bob Davis. I'm the Chief Executive Officer of Marama Health Aboriginal Corporation, but more widely known as Marama Health. And I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you, Mr. Davis. Could I now move on to Dr. Burke?
Yep, my name's Hugh Burke. I'm a public health physician, work for Marama Health. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thanks, Dr. Burke. Could we now move on to Mr. Grant?
G'day there, my name's Carl Grant. I'm the Chief Executive Officer for Billamugi Health Services Aboriginal Corporation. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth, so help me God.
Thanks, Mr. Grant. Moving on to Ms. Corby. You're up next.
Good afternoon, everybody. My name is Christine Corby. I hold the position of Chief Executive Officer of Walgett Aboriginal Medical Service and Rewarren Aboriginal Medical Service. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth.
Thank you very much, Ms. Corby. And Ms. Ward.
Hi everybody, I'm Katrina Ward and I'm the Chief Operations Manager of Walgett and Rewarren's Aboriginal Medical Services. I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you, Ms. Ward. Well, that's got through the formalities, so thank you all very much for that. Now, what I'll do is provide an opportunity for each of the organisations represented. So we've effectively got 3 organisations. 2 of them have got multiple witnesses to each, but each organisation to make an opening statement. And if you're agreeable, once that's been complete, we'll move into the questioning of yourselves by the committee members around the table. So are people happy with that format? Well, if we start with...
Yes, thank you.
Good, thank you very much. So we'll start with Marama Health. I'm not quite sure who will be giving the opening statement. Would that be you, Mr. Davis?
I'll do that, Mr. Donnelly.
Thank you.
Thank you very much. Look, I'll limit it to 3 key points, given that you guys have only given me 3 minutes to talk, but Marama's submission...
We'll give you 5.
Well, I've timed myself, so it'll be 3 minutes and 25 seconds.
You're right.
Marama's submission provides a much more comprehensive overview of our advice to the inquiry, but Marama's region actually covers all of far western New South Wales, and it's also part of what we call the Murray-Parky region, which occupies the northwest and far west parts of the state. It also covers some of the most arid and remote parts of New South Wales. The geography of the region is seen by those who live there as a great strength because it reflects the traditional and contemporary movement paths and linkages of families and communities along the Barwon Darling River system. The river system in turn provides a strong collective identity. The name Murray-Parky is actually derived from the traditional language of the region, Murray meaning black man and Parky meaning river. People living in the Murray-Parky region have lower socio-economic circumstances, worse adverse lifestyle risk factors, limited availability of local health professionals and infrastructure, and poorer access to health services due to distance and cost. The combined impact of these circumstances is that Aboriginal and non-Aboriginal people in the region have poorer overall health and health literacy compared with people who live in the metropolitan areas. There are also a range of issues relating to both social and cultural determinants of health that hamper Aboriginal people accessing care, including experiences of discrimination, racism and poor communication with healthcare professionals, a lack of affordable transport and healthcare services, a perceived lack of confidentiality, a lack of culturally appropriate services and information on available services, and different perceptions and understanding of health, illness and treatment. Together, these difficulties make the navigation of a fractured and complex health system that is poorly suited to remote communities and smaller populations a very big ask indeed. So it brings me to the first point I wanted to focus on, that's a greater focus in remote New South Wales. Over the last 10 to 15 years, governments and their departments have slowly fragmented. An example is New South Wales health responsibility for remote New South Wales is split between two LHDs or local health districts, and transferred responsibility for the executive management of service planning, design and decision-making for the Murray-Parky region to centres outside the region. So, for example, the Western Primary Health Network or the Western PHN headquarters is ostensibly in Orange and viewed by some our way as, you know, a central west-centric PHN. This consolidation of Canberra, Sydney and the central west has only increased the distance and gaps in understanding of local needs, autonomy and solutions, and is unsatisfactory on many levels. The one-size-fits-all approaches, coupled with complex and competitive tendering and grant arrangements, do not provide the flexibility to respond to the unique geographical and cultural challenges of the region and lead to fragmented, duplicative, siloed services that are not suitable or sustainable for providers or communities. Centralisation of bureaucracy is also mirrored by the devolution of two major NGOs with governance and senior management functions based in metropolitan regional areas, which have increasingly resulted in services being delivered from outside the Murray-Parky region on a fly-in, fly-out basis and telehealth basis as well. Since the establishment of the LHDs and PHNs, remote communities in New South Wales have experienced disinvestment on a scale that has never been seen previously. Without a joint remote primary health care strategy, including mental health, there is ambiguity of responsibility, a preference to force a fragile market to compete to deliver options, poor population health intelligence and plan. Commissioning practices are poorly prepared and place little confidence in local provider organisations and networks. The second point I wanted to refer to was ACCHO engagement and leadership. Aboriginal health institutions are amongst the most stable and consistent providers of primary health care in remote New South Wales. However, this clinical and cultural knowledge and authority is not reciprocated in authentic partnership, investment, nor advocacy from LHDs or PHNs. Given a growing Aboriginal population in the region with continuing health disadvantage, a declining non-Aboriginal population and market failures in both the public and private health systems in the Murray-Parky region, the ACCHO sector needs to be engaged and supported to take a greater role in planning, design and delivery of the region's health services to ensure their sustainability, accessibility and quality, because the ACCHO sector is the sector of the future. A remote health strategy must recognise clinical and cultural leadership of ACCHOs to secure health improvement. The ACCHO's unique comprehensive primary health care model of care and the more recent Commonwealth Government's Healthcare Homes program has the potential to address the failing primary health care landscape in the Murray-Parky region. However, ACCHO leadership and push will be required on a regional level to achieve the necessary integrated system-wide practice and primary healthcare reforms. To rely on the mainstream, and in particular the Western PHN, for such innovation and drive at this stage would be a mistake. There is an obvious need for greater investment into primary care organisations that have cultural authority, industrial agility, and live and work in the communities and are regionally governed. And my last point is a case for change. General practice in primary health care in small towns in Western New South Wales has reached a critical point. Projections show that 41 towns and approximately a quarter of the population in the Western New South Wales PHN region are at risk of not having a general practitioner practicing in those communities over the next 10 years unless remedial action is taken now. The challenges facing rural and remote health services with respect to workforce are widely recognised. The provision of quality primary care services requires availability of a skilled workforce of doctors, nurses, Aboriginal health practitioners, allied health professionals and ancillary staff. Remote New South Wales, like most other rural and remote settings, has experienced increasing difficulties in recruiting and retaining such primary care workforce. The impact upon the provision of primary care services in the Murray-Parky region of the continuing difficulties in recruitment and retentions has been substantial. It has led to discontinuities in services and in some cases service closures. It has led to impoverished business and clinical systems and services for chronic disease management and worsening health outcomes. Practices have incurred substantial costs in the employment of locums. Frequently, practices have had to rely more on overseas trained doctors and less on locally trained doctors, many of whom have been prepared to stay on until they meet registration requirements and who have required substantial additional support to adjust to cultural context. The high turnover of GPs is also having a negative impact on the continuity of primary care, especially for patients with chronic and complex conditions. This is particularly an issue in remote health care, where there are increasingly fragmented services and without a regular GP who has good knowledge of both the patient's medical issues and the referral pathways available, many patients experience undue difficulties in accessing services. Poor continuity of care also particularly affects the Aboriginal patient, many of whom are anxious in unfamiliar clinical situations and with unfamiliar practitioners who respond best to trusted longer-term relationships. While the ACHO sector has grown in its capacity and capability to deliver general practice services, it is also constantly challenged by the poor supply of general practitioners and GP registrars. And finally, instead of the siloed competitive approaches of the past, what is needed now is a wider collaborative general practice workforce and training strategy for Western New South Wales, also known as the Murray-Parky region. What is really disappointing to all of us out there is that following the Western New South Wales PHN's dire assessment of the vulnerability of general practice in Western New South Wales in 2009, i.e. 41 towns and 25% of the population won't have a GP in 10 years, nothing substantial has been done to address this critical issue in the subsequent 3 years after. Thank you very much.
Thanks. Thank you, Mr. Davis, and it was remiss of me not to acknowledge and thank Marama Health for their submission to the inquiry, which is submission 716. That's the number it's been given when it was processed. It was a very helpful submission. That's been processed, as I said, and been uploaded to the inquiry's webpage and sits as evidence to this inquiry. So thank you. That additional evidence in your opening statement is helpful, and we'll have some more information from you, no doubt, soon from the questioning. Can we move on now to Mr. Grant? Would you like to make an opening statement?
Yeah, good afternoon, panel, chair, committee. Probably just like to really back up what Bob's saying. I haven't gone to the lengths that he has been able to share with us today, but I pretty much would agree with everything he has said. Bill and Muji's a little bit different in that I suppose we we were established around 1995, and it was a group of CEOs from Aboriginal Medical Services that came together, and what they were looking at doing, I suppose, was having a bit of a regional voice. So we represent the Western New South Wales region out to Burke. I think one of our members is at Coomiella, so it's a bit further south, Bulgard and all those areas as well. And Christine and that used to be members of our organisation. And the aim of the organisation, I suppose, is to be an advocate for the RCHO sector. And everything that Bob has said, I totally agree with. Like we're finding amongst our members challenges in getting GPs to work for us. And some of that's around the criteria used to assess whether or not we can get subsidies and all that type of stuff, as member services will probably attest to. As you would probably know, the health statistics for our mob, I think if you go just about anywhere in the country, they're always a challenge in terms of chronic diseases that we're suffering from and access to services. And Bob made the point, and I would imagine all my members would say exactly the same thing. Our mob will go and visit services that they're comfortable with, and if they're comfortable with those services, then they will go and get the care. If they have to go up to an ED department because they're not comfortable visiting a GP practice in their local town or whatever, then they've got to deal with the systems that we all know you can run into issues when you're running into the acute sector. What I will probably add is, as you know, Dubbo was one of the first communities in terms of the Indigenous population that was hit with COVID-19. We've had, I think, 13 deaths in our community, not all Indigenous, but a fair whack. And one of the things I found refreshing was the fact that when it really came down to the chips, both the NGO sector and the government sector, both state and Commonwealth, we all worked together. We formed a committee and we got out there and we helped all our members of the community that were in need. And where I seen that was probably a challenge was in some of our smaller towns like Barorona. You might have one person that sort of takes that lead because they're passionate about community, but they just got burnt out during that process because they had a lot of agencies wanting to help, but there was no sort of coordination. So I think the point that Bob made around the PHN, the local health services and the RCHO sector working together, I think if you look at the AHMRC documents around that, there's documents saying that we should all sort of partner up. And I suppose what I'm saying in terms of the COVID response, even though it was a crisis, that brought everyone together, and we're hoping to maintain some of that work here in Dubbo around continuing that work on the ground. I think what you'll find locally is people on the ground, they do come together and they work together. They don't worry about where the funding's come from, whether it's Commonwealth or state, whatever. They'll get in there and do the work. It's, I suppose, when you get to our level, when we're, I suppose, having debates with state health or Commonwealth health or Commonwealth government around funding, that where you see some of these issues that Bob's mentioned. Even within our service, we've got 2 positions, clinical positions, counsellor positions at the moment that we've been funded for, and we cannot fill the vacancies. I'm about to re-advertise those jobs in January, but we essentially went out to recruit. We were able to recruit both roles, but they have since moved on now. So in terms of the skill set, it's difficult to get some of those skills in your smaller areas now. I'm new to town, so I don't know how Broken Hill and Dubbo compare population-wise, but I'm sure that Bob and Christine and Katrina probably face the same issues in terms of getting clinicians and staff out to these smaller regions. And it is a challenge, but as I said, our argument will always be community is comfortable visiting our services when it's our mob they meet at the door, and they build up that trust and rapport with the GPs. That's probably all I'd like to add at this stage, thanks.
That's good, Mr Grant. That adds very nicely to what's already been provided this afternoon. Now, moving on to our next panel, or next members of the panel, I understand both Ms Corby and Ms Ward, you both have an opening address or opening statement. So if that's the case, you both want to separately make one, is that correct?
Yes, please. Thank you.
No, that's just fine. So listen, perhaps can we start with you, Ms Corby? Invite you to make an opening statement.
Thank you very much. And as I said earlier, good afternoon, everybody. We're on Gummeroy country here in soggy Western New South Wales. Dare I say, we're on Two Rivers, Walgett, and knee deep in water at the moment. So my family is Gummeroy from here, my mum, and my dad is English. So I pay respects to traditional owners, past, present and emerging. It's lovely to hear my colleagues in Broken Hill, Bob's succinct statements about the overview of the health system, but it was like listening to our plight as well. So I really thank you, Bob, and you for that wonderful opening statement. It's quite clear that things haven't changed for me, who's been working in the business for 35 years. And with Carl, whilst you recognise my association with Billamugi, certainly I was one of the 3 CEOs at the time that instigated that regional consortia, and unfortunately both Brewarrina and Walgett are no longer members for businesses of change, I suppose. I listened earlier to the Walgett Shire Council and they spoke about the demographics and also particularly about telehealth, and of course Nurse Betty Kennedy is our chairperson of the board here, even though she didn't mention it. So there's a bit of connection, Walgett connection again, in her presentation about her knowledge of the hospital system. And with Betty, of course, I think she said she was 41 years in the game. So we're a bit of old chooks around the table at the present time, with the exception of young Carl. So it is with privilege that I'm the founding CEO of WANS, but over time I've seen the changes. We've endured and grown to provide a deep, place-based, culturally safe, family-centred primary healthcare service, not only to the Walgett community, but the surrounds, Brewarrina, Coronabrae, Gudurga, Pilliga, and some of the other further afield communities, according to the funding arrangements. For Walgett AMS and Brewarrina, we treat everybody, both Aboriginal and non-Aboriginal. We currently have 75 personnel, are the biggest employer of Aboriginal people in our community, and certainly with COVID's impact, our workforce has suffered with 15 vacancies. Now those vacancies broken up with 5 RNs, 2 doctors, 1 dentist, 4 Aboriginal health workers and 3 admin personnel. So that in itself, as was mentioned earlier by the other speakers, workforce per se and the ability to attract in our regional areas is slowly diminishing, if not non-existent. Successful services in our community require consistent long-term relationships with health workers and GPs face-to-face. We know our community needs its Aboriginal medical services and we certainly know how to respond to them. We believe we have the relationships and deep community knowledge that enables a primary healthcare service to succeed. We believe we are the experts and need the health system to be motivated by their leadership to work in partnership with us. I'd like to just summarise a few of the services that have been concerning us for many years, and one, of course, is workforce. Certainly for the past 2 years, COVID has affected our way of life. Several issues we encountered, particularly with people who returned to their border states and did not return at all. So the pool to recruit was for New South Wales, and all of us, whether we lived at Broken Hill, Walgett, Bree, anywhere, we had one pool of workforce in New South Wales, and we completely understand that the health system needed that workforce at the prices that they encountered. But for 2 years, as a business, we've been really restricted and hampered in the way which we can provide a productive, responsive level of care to our community. just on workforce and what Betty Kennedy spoke about in her presentation was the RN on country. And I'll just give a bit of clarity around that. The RN on country proposal is an initiative of the Walgett Aboriginal Medical Service in partnership with the University in Newcastle. We're looking at training people, be it Aboriginal and non-Aboriginal people, to become registered nurses, and not necessarily RNs, but also ENs, AINs, and other forms of allied health professions. We had the opportunity to go to Canberra last year and present to several ministers about our great idea. Whilst it was warmly received, the dollars haven't been forthcoming. So with the members of the committee and the questions they asked to Betty, we'd be certainly willing to answer any questions in regards to the queries they have about this initiative that we think can really work out here. We believe not only TAFE would help, as Betty indicated in her presentation, but we're also looking as an Aboriginal medical service to be registered training accreditation as a RTO. So there are ways around, I believe, in attracting the workforce and securing local personnel. Another issue in summary I'd like to speak about is oral health, which through the RFDS and RAMS and a few other presenters today, I share the same sentiments. It's certainly difficult to recruit dentists. It's more difficult to have patients come for preventative care. I think the fear of the dentist drill, the old scenario as we tend to know, sitting in the chair, having a tooth removed or filled, prevention just doesn't really work in our client base. So how we attract and encourage people to present, I really don't have the solution. We do offer in our community oral health programs in the schools. We've actually been fortunate with philanthropic money to secure some chilled water kiosks down at the local public primary school to encourage children to drink water as opposed to those wonderful soda drinks that we know that are so popular. But on a reporting point of view, again with COVID, I believe New South Wales Health has this crazy system called dental weighted, wait a minute, UA, what's the U? Activity units. In consultation with our dental consultant, it seems to have no bearing on the actual services that are provided. And I'm glad Dr. Burke is shaking his head, which I think I believe is in consensus with what I'm saying. So with that, it'd be wonderful if the KPIs overall, maybe part of our recommendation as health services here, that the KPIs actually reflect the service. Because right now, we're looking at 2 years where we have to return some of the money to the various governments because we didn't spend it due to COVID. Despite our argument to carry over, to keep that money as a kitty, I suppose, when times are, flourish, lean times, flourishing times, until we can actually retain and recruit staff, we'd hate to see some of the money taken from us and then our ability to offer the opportunity to recruit people that would be ideal for us is then missed. So I hope some...
Ms Corby, I don't want to cut you off, but it's now 10 to 3. We've still got one more opening statement to go. Could I invite you...
pass to Katrina.
Just to give us an opportunity, because I don't want to miss our opportunity for questions, because that elucidates a lot of the points that have been raised. So I apologise, I don't mean to cut you off, but you are. But I am, yeah. There's no nice way of saying it. I've just cut you off, so I apologise. But we'll circle back, don't you worry. Ms Ward, could you please, or invite you to make your opening statement?
Yes, certainly. Thank you again for the opportunity. As I said, my name is Katrina Ward and I'm a strong Niampa woman from the Undiver Nation, just on the western side of the Bogan River and that. And I was originally brought up around Ningo, but I've been working in the health industry most of my life in the far west and northwest regions of New South Wales. So I'm very familiar with a lot of the issues and seen a lot of change over the years in the... probably the really
38 years I've been involved in health, so it's unfortunate for our communities out here, and it's something that we need to strive to get back to be able to provide our primary healthcare focus. For those who may not be aware, Brewarrina Aboriginal Medical Service is located in the small town on the Barwon River, which is the location of a great cultural significance of the Aboriginal fish traps and that, which is, has very strong cultural connection and historical identity for our region and for our people, and it was a place where all of our tribes came together and done the bartering system, and also sought those medicines and that as well in the old days, and looked out for each other. So there was, you know, the commencement of the overall holistic health and wellbeing occurring on those riverbanks, and that's something we're trying to rejuvenate within Brewarrina. And I've been working originally as the manager of the Brewarrina Aboriginal Medical Service for just on 4 years, and I've just in the last couple of years with the COVID moved over to the working alongside Christine, operating both out of Walgett and Brewarrina AMS. But during my time in Bree, as it's affectionately called, we only had 2 doctors coming as an outreach service 2 days a week. That has been increased to 5 day a week, 1 local GP, due to the demand, what was occurring out there, and trying to increase the services and the allied health services has been ongoing just from the local needs. Brewarrina's town holds head per capita the highest number of Aboriginal people in the whole of New South Wales, nearly up to about 68% of people identify as Aboriginal in our township, and the vast majority of them unfortunately suffer from many chronic illnesses, and in the local hospital there's at least 8 renal dialysis chairs, and it's a constant 1 in, 1 out rotation for members of our community. So that can give you an oversight of, you know, the seriousness of the disease of what we've had, and even both across Brewarrina and Walgett, the high number of sorry business we've had to attend to and family members have from our people who have, you know, succumbed to these illnesses that have been impacting their life for many years. Our goal is to continue these services in Brewarrina, and there is the real scope there and the demand to keep services coming. But unfortunately, we're in a rental building there, and we've come across the situation a couple of years ago where we could have been, what do you call it when you turfed out, we could have been evicted from those premises. So we sourced funding streams to try and obtain funds to build a new AMS, which would also help us in the bid to be able to have enough space to have those services increased and have additional services come for the people. Unfortunately, they haven't been successful as yet, and there's always a cloud over our head as to whether we're able to continue operating out of our existing building. And at the moment, it's starting to come down into disrepair as well. Because it's not our building, we can't source any funding to do any repairs to it, and that was just evident a couple of weeks ago when I had a simple funding application in for repair to, you know, a 2-door roller door, which was a WHS issue as well. But because we couldn't get any members of the government, both federal and state, to identify who were the owners, I had to change my scope of practice of where I wanted that money to go. So that problem still exists there, but we've been talking about sourcing some of our Medicare income to try and overcome that for the safety of our staff. But it's very disappointing that governments are unable to at least give us a clear answer as to where we stand, you know, as to whether we're going to be evicted or whether they're able to gift us the building and then we take on that ownership through Walgett Aboriginal Medical Service, and then we're able to either do renovations to it and, of course, put the required money in to fix up the cracks in the floor and in the walls, etc., and just do that basic maintenance, what it needs. We need to be, you know, we're strong people as it is, but we've got to have the facility behind us as well as being strong and fixed to give that overall appearance that you come here, you're going to walk out feeling a lot better.
I've also...
Just noting that you've been speaking for 5 minutes. Sorry, it's hard to be subtle about this.
And not.
So perhaps another couple of minutes. Just if you could bring your comments, and then we can open up for the question, because I know there's lots of questions.
Yeah. Look, I think one recommendation across the board we've had chosen, I know I've often discussed it, is the way the funding streams are decided from, the government organisations. For example, we have funding for mental health, for drug and alcohol, for social and emotional wellbeing, suicide prevention. They're all comorbidities. They all overlap with each other, and we're all doing similar services to community. If it was just in one pool of money, it would be one lot of reporting. We'd still have the same amount of staff delivering the services, but at least they can complement each other, and it will also help us to be more concise with our reporting and not trying to do duplication. We've also, as I say, we've had great recruitment support. What came up out of the COVID with the rural ACCHO, or the remote ACCHO workforce response program. I believe once the COVID dies down, I certainly hope that that kind of support doesn't just disintegrate as well, because recruitment, as we've all identified, is going to be an ongoing problem, and we need to have, additional workforce support there that takes some of the both financial pressures and also the pressures of trying to find people on the ground in needs of due crisis. Transport's always a major problem for us as well. A lot of our people have to travel great distances. There's the need for regular and more frequent, like the palliative care teams, to be coming out to our communities. We shouldn't be expecting these people to have to do, from Brewarrina perspective, an 8-hour round trip to Dubbo. And, it can be a 4-day trip if they've got to go to Sydney. So we need to have these specialist care people to come out to our areas more regularly. And that's the same with the aged care assessment teams as well. We're becoming an ageing community, and there's certainly not enough people on the ground to be able to keep us as well as we can in our homes and take that economic burden off the hospital systems and the overall health system.
Thank you very much. Well, there's a great deal of information that's been provided to us in all of those opening statements, and I sincerely thank you for all of those. There's so much there to work our way through. We'll move to now the questioning. So we've got representatives here from the opposition, crossbench and government. So we'll work our way through the three groupings. So we'll start with the opposition, Honourable Walt Secord.
Thank you, Mr. Chair. Thank you, everyone, for your evidence today. Ms. Corby, you mentioned, or your proposal about training AINs, nurses. Would you, in fact, be able to get enough students if you actually were given RTO training status? And how would such a program work? And would it be a program similar to, I think a number of years ago, there was the Aboriginal health practitioners, a special category of someone like that. So how would your proposal work?
May I answer that on behalf of Ms. Corby, Ms. Ward here? Sure. Yes, the training program would line up with APRA and the New South Wales Registration Board. So all the syllabus components would be matched accordingly, so there's no shortcuts in this training program. It's been intensively researched and that through with the University of Newcastle, and the nursing team there have been liaising with both APRA and the Nurses Registration Board to ensure that everybody becomes, competent as need be, as for anybody who would go to university and move away. The concept is that we would have people from our region, particularly trying to upskill existing staff, our Aboriginal health practitioners, plus other staff coming through, and reaching
out to our neighbouring communities as well. We would like to start it off as a pilot program, but we really can see this working well, because the main times when people would still have to go off country to attend some placements, but the majority of them, particularly in the early stages, could be achieved through our local health organisations and our AMSs. And then we'd also have educational support for people who may have some literacy issues, and there's programs within the university which would provide that support and be able to get the individuals up to the required level from, you know, doing essays and that and what's required to pass. But there'd also be a lot of the hands-on and the teaching out of the school environment. So, and the main idea is to keep people at home, reduce that risk of people having to travel, having the strain on family, particularly a lot of our people out here, they have children a lot younger than that as well, and that's often a barrier for them to go source adequate skills and that to look for the future for them to get a career basis. And predominantly it's open for Aboriginal people, but if need be, we're quite, you know, happy to take on non-Aboriginal people as well. And yeah, we've done a lot of research into it. We do have a proposal, and we're happy to forward that to anyone of interest.
Could you
quite impressive, and we really see it as really doable. And there's going to be different excerpt outages for individuals as well. If something comes up, you know, a person might start and then they get to the ANI status, and then they might fall pregnant and have a child, so then they need to take time off, so then they can re-enter later down the line. So we've got all those useful people and strategies in place as well.
Okay, could you forward the documentation that you have involving this proposal to the Secretariat, or we'll have the Secretariat reach out to you?
We'll send it.
Yep.
Yes, we will do that.
Thank you very much. Now, a question to Mr. Davis. Mr. Davis, you know, you referred to 41 towns, a quarter of the population at risk of having no GP within a 10-year period. Now, what's this? I've heard this figure before. Is that an old study, or is that a recent study?
It's recent, and the best person to actually speak about that would be our public health physician, Dr. Schubert, who's
okay.
involved in collecting some of that information. He won't like it, but I'll defer it to him. Otherwise, I'll take it on notice. And
No. I'll take Dr. Burke. Dr. Burke, the show is yours.
Over to you, Dr. Burke.
Dr. Burke, over to you.
Come on down.
You'll have to unmute.
Yeah, that's right.
Just unmute.
Right now?
Yeah, great. Thanks, Doctor.
It's come from the Western New South Wales Primary Health Network. I think the original quote, it's been referenced in a number of PHN documents. They contracted the AHHA to do the work, and was looking at the vulnerability of general practice in Western New South Wales. And I think the original quote came from a 2019 report. I suspect the reason you actually hear it a lot is because the figure is so stark and so concerning. I assume that that's the reason that probably other people that have actually presented it probably raised the figure as well. As Bob said, though, the concern that we actually have is that it's one thing to identify a problem. The more important thing is to fix the problem. Now, we don't actually underestimate how difficult it is to fix this issue, but we as a group, and that's the Aboriginal Community Controlled Sector, would be of the view that there hasn't been a lot of traction since that assessment was made. Now, I'd be the first to admit that COVID could be an issue for that for the last couple of years, but really we can't hide behind COVID forever and a day. And the longer this goes on, the worse it gets.
Now, Mr. Davis also mentioned that there's a declining non-Aboriginal population in your region. So do we have where is the non-Aboriginal population going? Are they going to Broken Hill, Orange, Dubbo? Tamworth?
Major regional centres.
Yeah. So do we have a situation where the smaller communities now will be virtually solely Indigenous communities, and the major centres will? You're not. Yeah, Mr. Davis.
Slightly over time, that's seen. Yeah. So obviously there's a migration effect from the northwest into Dubbo. Similar migration effect of the surrounding communities outside Broken Hill into Broken Hill. And obviously the southern communities into Mildura. So there's obviously that regional impact. But having said that, even Broken Hill, if you actually, and I'm sure your secretary can look at the population data, but look, I was just looking at the census the other day and just looking at children under 5. So if I compare 1996 to 2016, there's been a drop in 450 non-Aboriginal children under 5 in Broken Hill in that 20-year period. That's 450, nearly a third. Interestingly, though, there's actually been an increase of 70 Aboriginal children under the age of 5, and it's gone from sort of 90 to 170. So, close to doubling. So even somewhere like a regional centre like Broken Hill, the population movements are really important to consider, with regards to health service provision.
So Bob Davis, so that's actually going to magnify or multiply the problems that or the challenges that we have now. In fact, attracting GPs, medical nurses, and that to work in smaller communities, it's actually going to become even tougher.
Well, it's tough now.
Yeah, but so what I'm saying is that it's actually going to become even tougher.
Yeah, that's right. Yeah. Look, can I just make another comment, just by following on from Hugh and your question to Mr. Scott about the general practices, dying or disappearing in the next 10 years. We shouldn't underestimate the role of the ACCHO sector in those regions, because, as I said earlier, they've been a stable institution. They are a general practice in their own sense. We just use the word Aboriginal health or what we've incorporated. But they actually still survive. And as in the case of Christine, who's been a CEO as long as me, which is 35 years, we went straight from school actually to being a CEO. Is that they're still standing there. They're stable institutions, despite general practices slowly disappearing. The point I'm saying here, though, the thing I want to get through is here, that's why they should be supported, because they'll still survive for many more years to come.
Well, that's where I was going to go with my next question. So you actually jumped to it. So in fact, there will actually be.
Well, I apologise.
No. No, but you're actually emphasising that there will be a need to support and strengthen Aboriginal health organisations coming into the future.
Exactly, yeah. Because look, in the end, they may be the only general practices in those remote sectors surviving and standing still. They still are. And like I said, look, Walgett's been around for 30 or 40 years. It's still there, a stable institution, despite other, as Hugh just explained, some of them will slowly die, those smaller general practices.
Now,
May I just...
Oh, sorry.
May I say the committee, and Bob's just prompted my recall with some of the comments that Betty mentioned regarding services at the hospital. And you are quite right, Bob. As an Aboriginal medical service, I suppose the question needs to be asked, what is it you actually do? And with that, we've inherited quite a lot of the allied health specialist services over the years. And, we've been quite fortunate to be the RDN or contracted businesses, but we provide, the cardiology where you don't have to travel away to Orange 4 hours one way. The podiatry come to us. So it's the whole mix of respiratory. It's wonderful how us as a business has grown, and also compliments to Murray-Mar too, with the footprint that they have. And, again, into the future, if it is an Aboriginal medical services, well, there's going to be something in our image. And I did hear Rams mention that that is what they believe they are. Well, to a degree, but not really. You know, they're not autonomous, they're not a primary health care practice. They do not practice the social determinants of health under the WHO, let alone us with the National Aboriginal Health Strategy. Acute care is not our business. Whilst we've touched on oral health, that used to be a body part by the government. Now I think slowly the heads are turning to recognise anything that goes through the mouth affects the rest of the insides, which of course is a chronic disease. So, you know, the logistics of us as Aboriginal medical services and our definition of health and keeping that body healthy is quite different to GPs and private practice, with respect, and also the hospital system.
Thank you. Deputy Chair Emma Hurst.
Thank you. Thanks, Chair. I just wanted to throw to either Mr Davis or Dr Burke in regards to your submission. You note in that submission that Aboriginal health institutions are among the most stable and consistent providers of primary care in remote New South Wales. You say this also isn't recognised or supported by LHDs. Can you talk a little bit more about this and what support you'd ideally like to see from the LHDs?
Yeah, you want to ask the tough ones. Look, I mean, this is probably a difficult one for me to answer, because I think, you know, in the case of our LHD, it's sort of based on relationships more than an organisation to organisation. So, you know, the partnership isn't exactly great, but I mean, what we have though is individuals that work within the organisation who have relationships with people that who may be connected to some of the programs that we run. I think the thing that I'd like to say is that we like to be respected for the work we actually do, and I'll give a good example is around COVID, where in a town of like Wilcannia, for example, where, as every one of you guys around the table know, you know, 3/4 of our town is Indigenous, and despite us being a major player, a big player in the delivery of primary health care in that town, we weren't the ones that took the lead role in the rollout of COVID there. It was other agencies that did it. And in fact, we came along, not necessarily mobbing up, but actually coming along in the background, supporting those agencies because they didn't have access to the people. So I suppose that in our sense, you know, if you could go back in time, I mean, the rollout of that, for example, we should have been the lead role in delivering, you know, the rollout of COVID in Wilcannia with the biggest primary healthcare provider in the town. It's a majority Aboriginal population, and I might also add is the Aboriginal community actually expected us to do that. So I suppose the respect isn't there for, I mean, this is my personal view, it's not the view of Marama. So you ask me a question, I'll answer probably, I suppose, on a personal basis. So for me, you know, the respect from the other agencies isn't there.
Yeah, can I also comment on that, if you don't mind, Bob, in the sense that from a Walgett perspective, when we had positive cases as such, and, you know, being an ACHO, we were able to respond and react immediately. Yes, I spent a lot of time on the phone and got additional vaccines brought in and additional staff. But for our outreach communities, we were able to jump in vehicles and go straight out and commence that vaccination, plus have people lined up here and get it done. And then it was 2-3 days later, between the LHD and the ADF just turned up in town and put up their pop-up clinics. There was no consultation with where have you been or how could, you know, we help you. It was like, well, here we are, come to us now. And it did cause a lot of confusion within the community. And I personally believe there was no respect, you know, from the other organisations back to us as
Aboriginal health organisations in that respect of them as acknowledging that we are very competent healthcare providers. And you use the word mop up, Bob, and that's exactly what we had to do out here, because, you know, they would put, you know, advertisements on Facebook saying they're going to be at this community or this community to do vaccinations, but it would be a day or two before we were going out to do second vaccinations. So then community members were confused as to, do I go to this fella or that fella? So there was a lot of behind the scenes work from us to doing that reassurance and that advocacy for our community members, which just put additional strain on us. But that's what we do, because we do have a passion for our communities and we do try and fulfil the needs they need. You know, like we even had Minister Hazzard come out here, you know, and it was all about the Western LHD. And even when he was on TV every day, it was all about the Western LHD, about, you know, the Wilders and Brewarrans and the Aboriginal people. Not one mention about what AMSs were doing on the ground. And we were the ones that were carrying the burden of it all. And, you know, taken some slack from our own mob too along the way, but we took that with a, you know, our grace, as we usually do. So it was very disappointing, and from that point of view, it would have been nice just to say, hey, look, we want to come to town, we're thinking of doing this, do you need that? Or would you prefer us to go somewhere else? And that comes up where we even took on doing a lot of vaccinations from outside our LGAs, which I received criticism from different community, or not community organisation, government organisations, that I should be just doing my own LGA. But I had the vaccinations there. They're our mob anyway. We're still travelling through these communities, so the faster we got everybody vaccinated, the better off we were for it. And at the time I'm getting criticised, but now I'm being commended for doing it, so because it got the ball rolling a lot quicker. But as I said before, all I did was stacked up somebody else's data, but in the long term, I kept our communities safe because they were still going to be travelling down the road to either Burke or Dubbo or somewhere like that, so they had to pass through these towns.
Thank you.
Thank you. Kate Fairman.
I could just quickly add, I suppose in terms of the LHDs, essentially what Bob said's true. If you don't develop a good relationship with the people, in particular as AMS, then you don't get the benefits of that stuff. So it's around formalising some of those partnerships so that there's a commitment on both sides, and that assists you with your workforce, and that assists you with patient flow as well, so that clients aren't falling through the gap. That's all I'd add. Thanks.
Thanks, Mr Grant. Kate Fairman.
Thank you, Chair, and thank you all for appearing today and for the wonderful work you do for your community. I just wanted to maybe a question for Walgett AMS. Firstly, around what you've said so far around the urgent need to train, recruit and retain workers. What about incentives from government? I'm sure, for example, things like housing. I assume housing is an issue for healthcare workers. I assume needing a car for the job. What could be done to incentivise? 15 vacancies is frightening. That's obviously not working, just throwing kind of positions and money. So what needs to be done? What more needs to be done there?
Well, money is the issue, may I say, because whilst Katrina touched on the workforce, the recruitment agency fees are exorbitant. 20% of the salary of a GP or a locum nurse. Absolutely terrible. So that's budgeted items, which the Commonwealth and the State Health, particularly the Commonwealth, I suppose, aren't really ready to release money so willingly. So we aren't competitive with the salaries for the doctors. We aren't competitive with the salaries for the nurses. From New South Wales Health, and Betty indicated earlier in the piece, there was the opportunity out our way, and it might have been Wilcannia as well, Bob, where there was an incentive for $5,000, I think, after they tenured for a few years out here. So people would go and work for the hospital system as opposed to working for the Aboriginal Medical Service, because they knew at the end of the day they'd receive a bonus per se. For us as Aboriginal Medical Services, we're restricted by government requirements. It'd be lovely if there were packages for accommodation, a vehicle, we have to do that ourselves. We have to submit for additional money for a house. It doesn't come as a package. So if that's your question, no, we don't have the luxury of having such incentives. We have to be creative and be patient until such time the government's ready to actually fund us for such programs and such opportunities to attract the staff. And additionally is the notoriety of the West. Too often we're in the media for all the wrong reasons. Katrina touched on COVID, Bob touched on COVID, the responses, the positivity as us as Aboriginal organisations and Aboriginal people and the achievements we reached in those trying times with bouquets to the Western, with the LHDs and other government departments. I say forget about that, because we need to put ourselves on a positive light. And while you have the media and people who fly in and out on all these goodwill whistle-stop tours and say, I've been there, how good are they? It's only a short-term, I don't know, it's not a solution. It's just a spot check, I suppose. Public relations, may I say. So the notoriety of our organisations, we need to remove that from the airwaves.
Thank you. I've got quite a few questions which we're not going to get time for, unfortunately. So I did just want to say, just in terms of your
I'm happy to concede our time if that helps. I know we're working to a schedule. I'm happy.
Just keep going, Kate. No, thank you, Trevor. No, keep going.
Thank you, Trevor. I'll keep going. So I've just got a question around, firstly, drug and alcohol and mental health services, and whether Walgett Aboriginal Medical Service is able to, whether you are receiving funding for that?
Yes, we do receive funding for it, and we've also got funding for social emotional wellbeing. They're all out of separate funding streams, so there's, you know, lots of reporting there, what they all want on the same day, and a lot of the activities that evolve around it, you know, they complement each other. So often we'll be putting one activity on and trying to bring it all into the same reporting, but the government likes to keep it, well, this was specifically for drug and alcohol, specifically for social emotional well-being, or hence mental health. So it makes us, we've got to be more creative to divide that up. Well, this one can be, you know, allocated against this funding and vice versa for the other regions. But if it was all in us together, then it would be, well, I believe it would be far more beneficial for the client, because you're addressing all their needs from the one team. You're not having to go see this person for drug and alcohol, then this one else for your mental health. So it would help, particularly with our people, where you don't have to retell your story all the time to several different people, and then they want to, you know, go through where you're self-medicating because of your anxiety or depression or vice versa. So it's about bringing those comorbidities together and just have them as one funding and over a 3 to 5 year time period, because, you know, to make any difference in those fields, it doesn't happen, you know, through 6 visits. It takes that long to build up a trusting relationship, or longer. And, you know, our people are very suspicious, and, you know, we don't want to share a lot of the negative impacts that happen within our life. So there's a lot of trust building that needs to occur.
Can I also check in with that then, because you did mention, you mentioned the kind of trust needing to be built up, and I know there's been some comments today, but there's criticisms as well of like how many organisations are being contracted in some ways to provide services, potentially sometimes at the expense of the local workers, if you like, who know the community well. I've got an example in front of me, which is and not saying that they're not a wonderful organisation, we've heard from them today, but the Royal Flying Doctors Service, I understand, contracted to supply drug and alcohol and mental health services in potentially a fly-in, fly-out model. WAMS, this is to you as well. Is there are issues with that type of model? Not wanting to criticise the RFDS though.
Yeah, look, personally, I believe in from an Aboriginal woman and that too. I don't like telling my story to someone else, and we often then, as you know, if anything's going to happen, it'll happen as soon as the plane's flown out of town, you know, so, and then they come back and they rely on the people who's here on the ground, and that often becomes our Aboriginal health workers or their own family and their mob, which then take on that carers or that other burden of care for them, and they become distressed from, you know, looking out for their loved ones, particularly if they're in a mental health crisis. You know, so, and, you know, I've got extensive experience in with mental health and social emotional wellbeing, and I've done, you know, masters in mental health as such, and about to endeavour on a PhD evolving into Aboriginal mental health. So that's going to be an interesting pathway as well, and I'll be touching on these kind of issues that occur. But within that, it's about having those support periods for when those people who fly in and fly out aren't here. And I know the RFDS model happens in Cobar at the moment, and it's got a couple of staff on the ground there, but they're not clinical staff as such. They're good for health care and promotion per se, but when it comes down to the nitty-gritty of someone's in crisis, they're up at the hospital and they're having a mental health assessment over the telephone, and that happens here in our local hospitals. And often, and particularly in Brewarrina per se, connectivity with IT isn't the best. So as much as Telstra will tell you that it's everywhere, it's not, and it's down more times than what it's working. So that causes other barriers to a person who's having, you know, a crisis, and particularly when they feel they're not being listened to in the first instance, and they go to get on for a telehealth conference and it blanks out or they can't hear properly. It's why they get more agitated. And then
thank you, Katrina. Yeah. That absolutely heard you. I've got one more question. If I can.
Sure.
Yeah.
One more question.
It's a completely left field question actually, but it is around dental health, and it hasn't come up. It doesn't come up in this inquiry yet, but I understand that this is an issue, and it's around fluoridation of water in terms of dental health of town water. So I understand that for Walgett that there have been funds allocated under the Fluoridation Capital Works program, under the New South Wales Oral Health Capital Strategy, and that Walgett drinking water isn't fluoridated. I understand there's issues with council kind of prioritising it and training staff to do that. I assume that's a big issue actually in terms of dental health. Would you actually like to comment on that? Because it would be good to include something, a recommendation around this, to be honest.
You've done your research and you're quite right. It's disgusting that the Walgett Shire Council haven't employed 2 people, so I've been told the situation with Michael Urquhart, several conversations over time and before he started as well. The issue I understand is they just can't find staff to rotate managing the water unit to install the fluoride. Absolutely ridiculous. You know, we're a population of 2,500 people, one supermarket in town, so all you city people who can go to Coles and IGA and Woolies, we had our one supermarket burned down twice in 4 years. So can you imagine the increase in takeaway, the increase in soda drinks? I won't mention that gentleman's name from across the ocean, but, you know, soda drinks rule here, poor oral health surgery on 2-year-old children. That in itself is an indication for us as an organisation to source philanthropic money through Rotary and another generous donor for a water unit at the primary school. Now, the Catholic school said, can we have one too? And I said, well, the education system should be supplying that. You know, we were just generous and recognised the need, because at the time the education system said, well, we don't have the money for that. Water isn't a problem. Clean drinking water isn't a problem. I can't understand that. You know, so you've researched well. I just wish something would happen. I really don't know, because bottled water is not the solution. That in itself has been an issue when the rivers dried up for many months. we had to rely on packaged bottled water. Then everyone was saying that because the water isn't fluoridated, don't drink it. So you drink the water that's no good. You know, crazy. It's cyclical.
Well,
so if the committee can find a solution, it'd be wonderful.
Well, thank you for that answer, and indeed thank you all. First of all, for participating this afternoon. It's been an extensive session. I think we've covered a great deal of ground, much of course in your opening statements, and followed up by the elucidation of a number of points in very comprehensively answering a whole range of questions from members. So on behalf of the committee, thank you all for participating. But perhaps more importantly, thank you for the wonderful work that you've been doing over what in some instances are decades of contribution to matters to do with health outcomes and services for our Indigenous but also isolated populations around New South Wales. So thank you very, very much. We'll break now for, thank you. We'll break now for afternoon tea, and we're back at
10 minutes ago.
5 minminutes.
10 minutes ago.
5 minutes. No, thank you very much. No. 5 minutes. We've got 5 minutes, so we're back at 3:35. Well, good afternoon and welcome to you all for what is the last panel session today of our hearing. And first of all, could I thank you for making the time available. We know that you're all very busy with respect to your important obligations and tasks that you've got before you. So we do appreciate genuinely carving out the time you have over the next approximate hour to provide some evidence this afternoon. My name's Greg Donnelly and I'm the chair of this committee and this inquiry. So what we'll do, if we could first, is just go through the formality. I'm sure you're probably well aware of the drill. So we'll go through and get each of you to, in the first instance, your full name, followed by your job title and your position fully, and then swear either an oath or an affirmation, whichever you prefer. The words of which you should have there before you. If for some reason they're not there, just put your hand up and we'll make sure you get those before we come to yourself. So perhaps it might be easier just to do it this way from perhaps my left, moving across to right. So this is on my side. So perhaps if we just start with Miss Sutton. Can we commence with you? Thank you.
Hello, welcome. My name is Dale Sutton. I'm the Executive Director of Nursing and Midwifery and Clinical Governance for Far West. I solemnly and sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you very much. So we'll then move across. Yes, thank you.
Good afternoon. My name is Umit Agus. I'm the Chief Executive of Far West LHD.
Thanks, Mr. Agus.
I solemnly, sincerely and truly declare and affirm that the evidence now about to be given by me shall be the truth, the whole truth and nothing but the truth.
Thank you, Mr. Agus. And moving to Dr. Smart.
Good afternoon. I'm Tim Smart. I'm the Director of Medical Services for the Far West Local Health District. I'll take the oath. I swear that the evidence now about to be given by me shall be the truth, the whole truth, and nothing but the truth. So help me God.
Thank you, Dr. Smart. Well, we'll before moving into questioning, just invite, if you're wishing to do so, make an opening statement, if that's what you've got prepared. So perhaps over to you, Mr. Agus. Will you make the opening statement?
Yes, I will. Thank you, Chairman. I would like to begin my statement by acknowledging the traditional owners of the lands within Far West, the Barkindji, the Mutjamuti, the Wilyakali, Nyampa, Wadigali, Mayangaba and the Wankamara peoples. We acknowledge and pay respect to the elders past and present and their ancient wisdoms. We acknowledge the communities of today and the Aboriginal community members who are part of our communities. I would like to thank the inquiry for the opportunity to contribute to the improvement of health services across the rural and remote regions of New South Wales. I would like to start by giving the inquiry a geographical context of our district. Far West Local Health District covers an area of just under 195,000 square kilometres. This is more than the total landmass of Denmark, the Netherlands, and Cuba combined. The same three countries have a combined population of more than 34 million people. Far West has a total population of about 31,000. This, I hope, gives you a sense of the enormity of the landmass relative to the size of our population in the region. It is against this vast geographical backdrop that the health services are provided across our region. The remoteness of our region represents one of the biggest challenges to providing accessible and timely health services. To this end, our services are delivered across 9 sites, comprising 2 hospitals, including the Broken Hill Base Hospital and Wentworth Hospital, and 2 multi-purpose services being in Referrals and also in Wilcannia. The delivery of public health services relies heavily on the commitment of its workforce. In Far West, we have one of the most dedicated, community-minded workforce. Part of the reason for that is the person they are treating is likely to be their own family, friends, neighbours, or someone they know. So this is as much personal as it is professional commitment for them. This was particularly evident during the recent COVID outbreak. Our staff worked tirelessly for days on end. And because they knew it was their community who needed them during the most challenging time in the history of our health service, they were equal to the task by demonstrating their willingness and resilience in the face of significant adversity. And they did it with the customary Far West smile. Our commitment to engaging with our community is also exemplified by the fact that our executive team live within Far West, which contributes to enhancing their connection to their communities. The result of such connection, I believe, was evidenced in the recently released 2020 Broken Hill Patient Survey, which showed that 98% of patients stated that their care was either very good or good. Our doctors and nurses received the same 98% satisfaction rate from our patients. Innovation and strong partnerships are critical to overcoming the challenge of remoteness and recruitment to key roles. Additionally, we have used telehealth and virtual care as an adjunct to face-to-face clinical service delivery to either improve or create access to services. This was particularly evident during the COVID outbreak and constant border closures, as we are flanked by 3 states, being Queensland, Victoria and South Australia, and the fact that we rely very heavily on visiting specialists from other regions and interstate, in particular, of course, South Australia. We have continually improved our clinical governance and invested in our workforce and in virtual and vital infrastructure, including the new $30 million Brentford Hospital and the $9 million Baronga One Health Service in Dayton. This in addition to capital improvement in recent years to our palliative care services, breast screen, community health service of Broken Hill. Ivanhoe and Toowoomba have also undergone a rebuild and refurbishment of their own health facilities. We have also prioritised the redevelopment of our mental health inpatient units at Broken Hill Base Hospital to improve our patient care. In the last 7 years, we have seen an increase of almost 23% in our budget, an increase of about 8 staff, or just over 16% of our total workforce. As an LHD that is committed to providing the best possible care to its communities, we acknowledge the issues our communities have raised and continue to raise, which often are embedded in broader multi-system level issues, and embrace the opportunity this represents for improving our services across the Far West through ongoing engagement with our communities and health partners. Thank you.
Thank you very much for that opening statement. That's very helpful. And of course, as you know, New South Wales Health has provided a whole of government submission to this inquiry, which underpins the whole position with respect to New South Wales Health and the government's position on health with respect to this inquiry. And that opening statement carves out some specific comments for the great work that you do out in Far West New South Wales. So what we'll do now, if you're agreeable, is that we'll now share the questions amongst the committee members. Represented on the committee are members of the opposition, the crossbench and government members as well. So we'll be sharing the time between ourselves and we'll get underway with the Honourable Walt Secord.
Thank you, Mr. Aegis, for your opening statement. I've been on this committee since the very beginning, and I have to say that is the most efficient opening statement I have heard. Your local health district has been under enormous pressure. I would have expected an apology in your opening statement. There has been an ombudsman's investigation investing systematic failures in your health district, and not an apology. You've had patient suicides. You've had preventable deaths. You've had 30 nurses leave in a 2-year period. You've had 10 out of 18 doctors, 10 out of 18 senior doctors leave the town. Can you please give and explain to the committee what is happening at Broken Hill Hospital?
Thank you for the question. In terms of the challenges of providing health service in a remote setting.
Sir.
Well, let him answer.
I want to hear practical steps and measures.
Well,
sir, lay them out.
I'll take the point of order. The member has asked a very lengthy question, indeed a diatribe. Having put that lengthy proposition, then it's really over to the witness to respond to the multiple assertions that were made without interruption.
Thank you, Mr.
Okay.
I take your point of order, Mr. Conn. I accept that, and I will sit here quietly, and I will listen to the Chief Executive Officer respond to. Those were statements of documented fact. Those were not made up.
Thank you. Just proceed with your answer. Thank you.
Thank you, Chairman. Again, there were a number of questions that were posed, so I'm going to try to remember. If I neglect any, I'm sure I'll be reminded. In terms of talked about suicide, it's one of the challenges certainly of our time, not only in remote communities, right across rural communities, indeed nationally and internationally. The numbers do suggest that we need to do more, and as with any other health service, that's our commitment. And I do absolutely, sincerely, condolences to all the families who have had to endure suicide. Having worked in the field as a clinician for over 20 years in mental health, I can tell you firsthand the experiences of both clinicians and families in response to suicide and mental illness. So I speak with some authority in that regard. In terms of the nurses leaving,
yes,
look, there's nothing unusual in that. We have a churn of staff every year. What made it more challenging, absolutely, is COVID in the last 2 years. But if you look at the numbers over the last 2 to 3 years, the number of people who, the churn has been very similar, and I'm more than happy to provide that figure on notice.
If you could do that, that would be good.
We have had additional resignations, absolutely. I mean, one of the challenges has been the border closures. We do get some of our, obviously, workforce from interstate, and as soon as the borders were opened, because of the uncertainty of the environment, a number of people actually have left. Not because they had grievances, because actually they made a decision for themselves and for their families to leave the state. In terms of doctors, in fact, what I would argue is that, and I will certainly get Dr. Samar to comment on this, we in fact have actually strengthened, not weakened, our, if you like, recruitment of our doctors. We've invested heavily. We've in fact, for the first time in a long time, now have heads of departments, which we didn't have, and other elections to take for granted. That was a significant gap for us. We've addressed that. And on top of that, we've actually been successful in recruiting local GPs. And I had in earlier statements about the importance of actually engaging and employing local GPs. We actually have done that. And the result of that has been a greater continuity of care and really, I guess, also providing longevity of employment, if you like, for our LHD. So, absolutely, I'll apologise for the fact that we can do better. And that's our commitment to the community that we work with.
Have you?
I'm happy to pass to Dr. Smart, particularly around the medical workforce.
Yeah, I would like to know, 10 out of 18 doctors have left and 30 nurses have left in the last 2 years. I would like to give that in perspective of the overall workforce there, and has there been an investigation into why they've left?
Certainly, part of our process is that we actually do an exit survey of every employee who leaves. We give them an opportunity, and then we certainly record that, and it gets reported in our executive as part of our really planning and understanding as to the reason why people leave. Because obviously it is in our interest to know, to actually prevent. One of the challenges for us is, I think it was raised earlier, it's not just about recruitment, it's about retention. And for us to retain, we have to understand what the issues are for our staff who are leaving. As I indicated earlier, a large number left because they made a decision to really, a personal decision to leave. There may have been others who may have left because they were not happy. Absolutely, this is a very challenging environment, and that therein lies one of our challenge. We have invested really heavily in terms of, particularly in our nursing workforce, and I'm happy to get something to comment on this in terms of providing extra support, particularly to our nurses. It is a tough gig out here, and we're doing everything certainly we can, with the help of ministry, to create support systems so that actually people don't leave.
Could I hear from Dr. Smart to respond to the question?
Thank you for that. Firstly, I'd like to make a couple of statements of fact, and then I'd also like to give some context. Firstly, the statements of fact: we have more doctors on the floor on any one day than we've ever had. And on any one day, we have 37 doctors rostered. It's a hybrid model, which is both specialists, that's both subspecialties and some of the core subspecialties such as general surgery, medicine, pediatrics, etc., etc. And we also have the intermediate levels, and we have younger doctors, the trainees, who are rotated out from Concord and from Canterbury Hospital in South Sydney. In addition to that, we have developed a rural generalist training pathway. At the present moment, we have 4 local general practitioners on that. Our component of that is to do the advanced skills training, which we do. We had our first graduate a month ago from that, and we continue to encourage local doctors to join us. So in terms of actual numbers, we have a significantly larger number than we had even 2 years ago. The second thing is that the contextual component is that the preferred engagement that doctors have in New South Wales is what we call a visiting medical officer, and this is where they are either paid on a sessional rate, hourly rate, and or what we call a procedural rate based on the number of procedures they do. And the common contract that is given, and this is the New South Wales award, is what we call a 0 hours contract. So they have flexibility, they can use as little or as much as they wish. This, if you look across the whole of New South Wales, results in quite a reasonable churn as people find other opportunities and work in other places. Inevitably, in any medical staffing situation, there is sometimes dissatisfaction, and particularly if people have been called to account in terms of their professional levels of service delivery. And when we do require that, some people prefer not to stay.
Well, I want to stop you right there. Can you roll back up a little bit? I'd like to explore that. So doctors have left because?
There may be simple things in terms of commitment, attitude, in other words, the clinical variation from what we expect, which is one of our significant KPIs that we monitor. And a lot of the people who come out here are visiting, they're flexible because they're visiting medical officers and they can move. They're not contracted in terms of staff positions.
No.
We have 4 staff positions.
No, what do you mean?
Let him answer.
No. He's rolling past. Getting upset about being questioned about clinical variation. What does that mean?
Right. So,
are we talking about adverse outcomes? Are we talking about?
Or shall I answer this new one?
Well, I want you to answer the question.
Well, I'll take the point of order. The witness has started to answer a question, and then partway through the answer, I accept that Mr. Secord has areas of inquiry he wants to go down, but the witness should be entitled to finish answering the question before he's taken up on part of it. Otherwise, none of us will understand what's going on.
Okay, so it's really important that because we're doing this remotely, that we direct our questions specifically to an individual. That individual acknowledge you've received the question and then provide the answer back. That's probably the way to.
Okay, so why don't we start from the premise that, okay, I'm concerned, you said there are 37 doctors rostered at any given time. 10 out of 18 doctors have left. That you say that there is, quote, a churn of doctors, and some of those doctors have left because they were questioned about clinical variation. What does that mean?
Right, so in fact there are other things as well, including clinical variation. So I'll start with the clinical variation, and if I may cover the other reasons why people leave, and it's largely out of the locum workforce. So there are a couple of reasons we've had people move. So clinical variation to start. When we are looking at any delivery of clinical service for any particular conditions, there is basically what we call either best practice or practice based on research. if you have 3 or 4 doctors and of those group of doctors, so let's say 4 doctors, 3 of them use the best practice, and 1 doctor is off on a tangent using treatment that may well be acceptable to some extent, but is not considered best practice, we will question that. That is clinical variation.
How many doctors have left because of clinical variation, meaning not following best practice, but going off and doing what they thought was best?
I don't have that number for you, and I'm not sure I've even been able to find it at this stage, but we could certainly try and find that information.
Well, can I just make this point very clear? I'll jump in here. That's quite a significant acknowledgement, if I could sort of use that word, Dr. Smart, that you've made from the probing question. I understand that. Surely that information is available. It surely cannot be the position that the number can't be identified over a particular period of time, surely.
Absolutely, and as I said, I'm happy to take it on notice. I should have used that phrase, sorry. Yeah, and provide that information.
Thank you.
Now, Dr. You'd it's been a number of years since I've been Shadow Minister for Health.
Sorry, just before that, the witness had indicated that there are a number of areas apart from those matters. I'm not quite sure whether he's finished answering the reasons for separation apart from that particular one, because he said he was going to come back and answer it more fully.
Okay, well, put it to
I could be wrong, but I thought that's where he was.
I was given the impression that he had finished his answer and he had taken it on notice, and I was moving on to my next question.
We could ask, move along.
Thank you. Shall I continue, Chair?
Yes.
Yes, please continue. Yes, if you need to, yeah.
Thank you, Chair. In fact, we were talking about some of the reasons why people leave, and we've talked about the number of people who've left in the last few years, preceding my time here. But what I was talking about are the reasons that we see for people leaving, and certainly within my experience here. And amongst those are individuals who have contracts where they can increase or reduce their work at will in terms of their commitment to us, and the majority of them leave for their own reasons or other opportunities or other other areas where they might be able to do visiting medical officer work. But that is usually their choice, and that's the answer to that component of it.
Dr. Smart, back to my question earlier. A number of years ago, when I was Shadow Minister for Health, there was major adverse outcomes in hospitals. And I think they were called. Maybe the terminology has changed since.
Sentinel events.
Sentinel events. Thank you, Mr. Chair. Sentinel events. Are they still called sentinel events?
We have a new classification, clinical instance, on which there are sentinel events in some instances, yes.
Oh, so what are they called?
It's not commonly used, but they do use it at times, yes.
What are they called now?
Perhaps I might get Ms. Sutton to answer that, because in fact she's our Director of Clinical Governance, so she's right across this area.
Thank you.
Just for clarification.
So, Ms. Sutton, if you could answer that question, and then so give me the terminology of what they're called, and how many are there at Broken Hill Hospital at the moment, and how many have been last year?
Okay, thank you. They're actually called harm scores. So they rate between harm score 1, which is a death, unexpected, is one example, to harm score 4, which could be a near miss, or you gave a patient the wrong medication and there was no adverse outcome, or they could have had a slip or a trip, is a harm score 4. I would have to take that on notice around how many harm scores that we have. We do collect that information, but I don't have that information in front of me.
Would you give me an indication that are there many for a hospital of your size?
I can't answer that. I don't have that information in front of me.
Can you take that take that information on notice? Back to Mr. Aegis. Now, you mentioned in your opening statement that 98% of patients reported very good and good. What do you base that on?
That's the BHI report. That was a media release. So I'm more than happy to provide that information, if you please.
98% of people who visit Broken Hill Hospital are very pleased, I think they received very good or good treatment at the hospital. You stand by that?
Correct.
Thank you.
Move now to the crossbench. Deputy Chair, Honourable Emma Hurst.
Wonderful. Thank you, Chair. And thank you all for coming here this afternoon. I'm not sure if you either read the submission or saw any of the evidence today from the Aboriginal Health Services that have come in today. But one of the things that one of the themes that they brought up was that they often felt that there was a lack of communication or cooperation with some of the community groups and the LHDs, and I just wanted to get your response to that and whether that was something that had come to you previously, and whether there was any actions being taken forward to prevent that.
Again, thank you for the question. Certainly, we did. I certainly listened to the evidence that was given. Obviously, I can speak to the relationship that we have within our Far West, while that does not fall within my jurisdiction. In terms of our relationship, look, perhaps I can give an example of the COVID outbreak, just to reflect the level of partnership that we do have. It was really the response, particularly in Wilcannia, was really the success of Wilcannia was the result of the partnership. Particularly our efforts in the community. That's where we need to focus a lot of our attention. And that was really a partnership between RFDS, Marama, and the health service. And I do believe that results speak for themselves. We, in fact, developed teams that was a combination of our partner organisations, including a mental health clinician, I might add, who visited the community on a daily basis. You can't do something like that without a strong base of a partnership. And that partnership really continues right across our region. For example, in recognition of the significant role our AMS play in our region, in conjunction with Ministry of Health, we fund positions to the value of 2.2 million in Marama, because we believe that they are the best agency to be able to enrich into Aboriginal communities, and we work very closely, certainly, with the staff on the ground. We have regular meetings, and these are, a matter of record, really, and we have involved them in our planning, certainly around COVID, and in fact, Ms. Sutton was the chair of our emergency response team, and can certainly attest to that. We held meetings daily on a lot of occasions where we invited our partners, including Marama and other services. We've also, an example of the strength of our relationship, Community Health, which borders the other side of our region, which borders Victoria. One of the challenges for us was there really creating access for patients who sought mental health services. There were challenges there. We really sat down with the leadership and looked at how best we can actually address that. And what we ended up doing was, in fact, we funded a mental health worker within what we call a CHAC, Community Health, and that person became the bridge, if you like, between our two services. And what that has seen is improved services, mental health services to the Aboriginal communities in that area. Is it adequate? I don't think it will ever be adequate. I think we need to continue to work.
Thank you. Marama were particularly concerned, as you would have seen in their submission, about the erosion of the community health spending, with a greater focus of the LHD budget going on hospital rather than on preventative and community care. I'm wondering if the LHD are doing anything to improve or to change that.
Look, certainly in terms of the actual figures, I don't have it in front of me. As I said, overall, we had an increase in our budget over the last 5 to 7 years of about, just under 25%. And we really, I guess, distribute that funding on the basis of need and activity. we are absolutely mindful of the important role our community teams play in preventative work. As I said, we also fund other services like Marama as 2.2 million, which echoes about over 10 FTE in the community for that purpose, and we'll continue to certainly focus in the coming certainly months and years to invest more and more in the community, because we know that if we can actually stop chronicity emerging in the community, that will have a positive impact both in the patient's lives, but also the impact on the hospital system as well.
I might just dig down on one of the examples that Marama Health Aboriginal Corporation stated in their submission in regards to some of the concerns they have. And I'll actually quote directly from their submission. I don't have the page number in front of me, sorry, but they said that LHDs are putting substantial pressure on dental providers to achieve daily, weekly or monthly targets that do not seem to take into account the service delivery landscape or the clientele. So they're concerned that this is, leading dental providers to move outside the LHD. Is that something that you're looking into?
Just on that, as a bit of a background information, majority of our dental services are provided by RFDS through funding from the ministry. We provide a level of service for children in Broken Hill. We have obviously regular meetings with our service providers to make sure that our community get equitable distribution and service delivery in terms of oral health. And in fact, Far West probably performs the worst in terms of oral health access, and we are working with our partners to look at how we can improve that. We want to focus more on preventative work. A lot of it is on acute and disproportionately, and we certainly are working, as I said, on shifting that from acute to more preventative work, so we can actually get in early and actually provide a better health outcomes. When it gets to acute extraction, you missed the boat basically.
Yeah, absolutely. Look, a number of submissions also, and something we talked about this afternoon as well, was about short-term planning with funding, whereas they would like to see much more longer-term planning with funding to assist particularly around recruitment and planning. And I just wanted to get your response to that and whether or not there is anyone looking into undertaking more longer-term funding.
Look, that certainly is a contract arrangement between the certainly ministry and our partner organisations, particularly RFDS. We are certainly absolutely supportive of longer-term funding because it is very challenging to recruit to remote sites on a short-term basis. And certainly our contract, for example, RFDS is usually around 5+ years. We get that done through the ministry. Certainly we would be supportive of any really attempt to increasing the life cycle of the contracts, given the challenges of recruitment in our region.
Thank you.
Would you have a further question? Or, Kate Fairman then, please. Kate.
Thank you, Chair. I just wanted to go to, firstly, the situation in Wilcannia and just ask what KPIs has the LHD set for increasing the life expectancy there for males that we heard today from 37 and for females from 42?
I think setting out a KPI or an expectation that is less than, that's freely enjoyed by the general community will be doing disservice to our Aboriginal communities. Our expectation, as indeed the expectation of the ministry, is that every citizen should be able to live to the full extent of their lives. So really I guess from that point of view, our aim is to make sure that that our Aboriginal community enjoy the same length of life as everyone else does. So I hope that answers the question.
No, it doesn't actually. So I'm sorry, but it doesn't. So it hasn't. It's not a new revelation that the life expectancy of Aboriginal men in Wilcannia has been. I thought it was 36. I've always thought 36. Today we heard 37 from the witness Michael Kennedy. Firstly, is that correct? Is that the average life expectancy for Aboriginal men in Wilcannia?
Look, I have taken that on notice. It certainly is. Yeah, look, I'll take that on notice.
Dr. Smart might know.
Recently.
Thank you. Yeah.
Sorry, I'm new to the area. I don't have that record, but certainly we can provide that information on notice. Yeah.
No, that information usually really held by our public health unit. Certainly, I'm more than happy to also give a more detailed, I guess, understanding on notice around the life expectancy and what contributes to life expectancy. Obviously, it doesn't necessarily indicate that every person, reaches that age and passes away. There are a number of factors that are taken into consideration in determining life expectancy, such as, stillbirth, suicide, and all those factors impact.
Yes, that's true. They all do impact. That's right. Mr. Aegis, how long have you been in the position for? If I could just ask.
Sure. I will be coming up to my second, completing my second year in the middle of January next year.
Okay, so maybe the question then is, let's say that and take it as a fact that Michael Kennedy was correct today, the Wilcannia witness, along with Auntie Monica Kerwin, who tragically lost her son to suicide just recently, and we in fact had a 1 minute silence for her son Mark. So let's take that 37 average life expectancy for Aboriginal men in Wilcannia as 37. What is the LHD doing to address that and to ensure that that life expectancy starts to increase?
Sure. Life, again, if I can just perhaps preamble that, life expectancy is not obviously necessarily the outcome of, if you like, health per se. Health has a number of factors that are impacted. So I'm talking about social determinants of health. You're talking about housing, you're talking about education. So I guess I can't speak to the whole raft of factors that impact. In terms of what we do, we certainly are looking at, as I said, we're working closely with our primary healthcare partners such as RFDS and Marama around primary health, so preventative work with our PHN partners. We're investing in mental health, really, to I guess, have an impact on, particularly on suicide. As recently as this year, we've in fact opened up our Safe Haven Cafe in Broken Hill, and also have invested heavily in community education right across the district around suicide prevention and education. So there's some of the actions I guess we are doing to contribute to improving the health outcome for our Aboriginal communities.
So mental health support then, you said you're investing in mental health support. What we also heard from the Wilcannia witnesses today was in fact the lack of mental health support, how they were very much needing local, or at least people, Aboriginal people who live locally, who could be that provide that mental health support. So trained mental health counsellors who ideally are from the local community. What's being done there?
Certainly, our aim always is to create local opportunities and employ locally. That is not always possible, and that's why we have the likes of RFDS and others who really do a visiting service. We're working with, again, Morima. Morima provides primary mental health services alongside RFDS, and LHD provides the more, if you like, serious and acute level service, mental health services in the area. In terms of local employment, again, as I said, where there's an opportunity, we certainly do so, but that is not always possible.
I would suggest to you, if I can, actually, that it's not working, that there's not enough mental health support, that we had 2 witnesses today saying they don't have the Aboriginal mental health workers that are there 24/7 in Wilcannia. So you've just talked about fly in, fly out from the Royal, from the RFDS, and you've talked about Murray Ma, but we didn't hear that today from the Wilcannia residents, from the local Aboriginal community there who were saying that there have been recent suicides of young people, and that is not unusual.
Look, certainly I have heard that, and certainly will be, looking to both communicate. I think there's a fair bit of communication there as well in terms of what is available, and also looking to investing in the gaps that the obviously the communities have spoken about.
Do you see it as a priority for you, the terrible health situation in Wilcannia, the absolutely terrible health situation in Wilcannia? Is it a priority? I've just asked about KPIs, and I suppose what I'm trying to get is some idea of the level of priority to address the suicide rate in Wilcannia, for starters.
It is an absolute priority. I mean, our Aboriginal communities still have the worst outcomes, and that hasn't shifted. There has been slight improvement, but not to the level that we would expect. It is an absolute priority, both of the government and, of course, of the LHD. So to say anything else would be really understating or denying reality.
So what further support will they get, recognising that suicides are still happening? We've had witnesses today saying that they don't have mental health support workers that are needed in Wilcannia. That's just one example, I'm assuming, Wilcannia. But what additional support are you advocating for in this area? Because it's working what's there at the moment.
Sure. We'd be keen to engage the community and really explore where the gaps are. We have a number of services already on the ground, provided by a number of services, and I did hear that that is not clearly meeting the need. I think we need to obviously engage the community and understand more in terms of where we can target more services. As I said, we have received a number of, if you like, funding from the ministry during COVID, and it continues to be the case. We have embedded in our community support teams during COVID mental health clinicians, both adult and also children's. So we are aware of the need, and as I said, it's an ongoing challenge, and we'll continue to look at ways of investing and meeting the gap.
Do I still have time, Chair?
If you want another one,
yeah, go.
One more. Give it a go, and then I'll have a go.
Then I'll.
I'll just move on. I could. Broken Hill Drug Rehab Centre. We have heard from a number of witnesses that there isn't one. Dubbo is 700 or 800 kilometres away or something in terms of people accessing that. What, again, to the CEO, what are you advocating for a drug rehab centre in Broken Hill, either to New South Wales Health internally or to the Minister?
Well, the short answer is yes, but the long answer is a bit more involved. So I guess in my previous life, I was head of drug and alcohol service in Tasmania, so I've got some understanding of the, complexities of the service. There's obviously two parts to it. there's one is the withdrawal, which we do because that's a clinical intervention, and we use our hospitals for that purpose because it has to be supervised by a clinician. And then there's the other element, and that's residential rehab. And often those services really are managed by NGOs rather than clinical services. Clinical services tend to provide clinical input and guidance, but not necessarily run them. A recent application was made, certainly joint, in fact, proposal was put both to the Commonwealth and the state through our local PHN to actually look at developing a hybrid model, though the details of which are not clear yet because we want to get the funding first. But so there's an absolute commitment. We know that it is a challenge for our community. People are going to Dubbo, also they go to Orange, I think Narromine, and also South Australia. It is not a satisfactory answer, absolutely not, because you do people, engagement of people in this journey is so critical. You can have the withdrawal, but you need to be able to marry it with the rehab, particularly for certain clients. And if they have to travel, to get someone to, undertake the journey to Dubbo or Orange, they have to be highly motivated. And we do have those, absolutely. But there are those that travel may be a disincentive, and we need to really minimise that and capture that moment. And absolutely, we are committed to creating that facility, within Far West.
Well, just to follow up on that, Mr. Aegis, if there has been a funding proposal that's been put forward to the state and the Commonwealth, are you able to share with the committee that funding proposal?
Actually, we are not the lead agency for that. It's actually the PHN. They've taken the lead, so I didn't have access to the actual funding proposal details.
Well, look, I accepted from your previous answer that you were not the lead agency, but if you can, it would be very interesting to see it. So if you can get it, we'd love to see it, if I can put it that way. But it requires your cooperation, the PHN, but it's the sort of thing that I suspect this committee would like to support if we can. All right, look, could I just go on to some specifics? And again, I'm going to talk about Wilcannia. It's many years. I'm getting old, but it's many years since I've been there. It would have been 10 plus years since I've been there. It was concerning when I was there then. Plainly, nothing's got any better than when I was there. So let me ask you this. You've got an MPS there, is that correct?
That's right.
So what facilities are available at that MPS?
Yes, we have a number of aged care beds, an ED service, for more level, if you like, category 3, 4 and 5. So the acute care obviously gets transferred to Broken Hill or to tertiary hospital.
Yeah, that's understandable, yeah.
Yeah. So, and then we have a number of what we call the subacute beds as well in Wilcannia.
All right. Well, what is the level of population that's required to, for instance, support a renal dialysis chair or bed, depending upon how you describe it? Because there's not one in Wilcannia, is there?
No, there isn't. And I don't. Well, I guess it is a function of demand, certainly, to make it work. But also, you need to have the right clinical environment to deliver that service safely. At the moment, we have, I think, 2 residents from Wilcannia, and we also have 2 residents from Menindee who come to Broken Hill for their dialysis service.
Sure, but Menindee is an hour away, as I understand. Wilcannia is 2+, am I not right?
Yeah, that's right. In fact, I think probably more like the 2.5 hours if you drive safely.
Indeed.
If you drive fast, it's not be shorter.
Yeah.
It's a significant import. We certainly acknowledge that. What I will do, though, is that in terms of the clinical safety element, is to keep this here around what we can and can't deliver in some of our, if you like, remote sites. And I will get Dr. Samar to really speak to the clinical aspect
Please do.
of it and the operational elements within that.
Yeah.
Thank you for that. There are some constraints in terms of being able to deliver the renal services, the haemodialysis in particular, in those remote areas. We are contracted to the Royal Adelaide Hospital for our renal services, and they've looked at and taken consideration in terms of being able to provide their specialist care or outreach to these smaller areas, and found that they can't do it. They just don't have, so we don't have the nephrology support out there. That's the first thing. The second thing is the other trained staff, like nursing staff, renal staff, etc., and once again the recruitment retention component. And we do have the capacity in some of those smaller areas for people to do their own home dialysis, home care. So the two cases in Wilcannia, for example, one for medical conditions, in terms of medical conditions and complications, is unable to do that and is required to come to a proper satellite unit like Broken Hill for their service. And the other one has been offered the opportunity to be trained. It does require training, to be trained in home care and has declined to do that and has chosen to come down here. Now, the complications in terms of the other areas of offering that is that the majority of the individuals that we are dealing with have multi-organ failure, and in particular the cardiac complications, which precludes them from the home dialysis care themselves, and they have to be very carefully chosen and trained. So it's a combination of the lack of nephrology unit support, trained staff on site, and then the ability to be able to get them to do the home dialysis care, provided they don't have, they meet the criteria and accept the training. But the vast majority of our cases, of the 4 in Menindee and, two in Menindee, 2 in Wilcannia, only 1 was eligible and declined because they felt they couldn't cope with the training, for example. So it has been a significant challenge.
Right. All right. Well, look, I'm going to run out of time, so I'm just going to move on. What percentage, and I think I'm principally talking about in Broken Hill on the basis of what we've heard already, but what percentage of your frontline medical workforce is Aboriginal? And yes, it's directed at you, Mr. Aegis, is the best one to ask.
So I was thinking about medical, but did you ask medical or just in general?
Look, I'm interested in essentially your medical and allied health professions.
I can't give you the breakdown of the actual specific disciplines, but what I can tell you is that 6.5% of our total workforce is made up of someone of Aboriginal descent.
Mr. Aegis, I'm not being dismissive of the intent to provide employment to Aboriginal people. In fact, that's great. But am I right that in terms of the whole of your health district, is it 12% are Aboriginal?
About 13, actually.
13. But it's one thing to have people employed as catering or cleaning staff. It's another actually to have them in health and allied professions where they might actually work in country and stay. So that's sort of what I'm interested in seeing is what you're trying to do to actually build a stable workforce with people who actually the Aboriginal community might relate to and aspire to become themselves, if that sounds in any way coherent.
No, it does, certainly. Look, my apologies, I don't want to be all writing, but we have, again, I can take that on notice of detail, but in just general terms, we have a number of Aboriginal health practitioners within our service. I know for a fact that Menindee has a number of them. We have a number of nurse unit, at least one nurse unit manager. In fact, Wilcannia nurse unit manager is an Aboriginal person.
Well, that's good to hear.
We have really, and we also have a number of Aboriginal liaison officers, if you like, and we also have a number of training positions. At the moment, for example, we have school-based training, which, if I can give you an example, if you like, the kind of a pipeline, if you like, of training. We have had Aboriginal young kids who actually, as part of the program, started working for us whilst they were doing year 11 and 12. They come and work, you know, the admin, and they go to acute sites, do some admin work. They get a sense of it, and then they actually become AINs, assistants in nursing. And in fact, we also then have a number of them, in fact, then become trainee nurses. We currently have a number of those, in fact, studying to become nurses. And I might actually throw to, at this stage, to Ms. Sutton, because a number of trainee programs, in fact, do come under Ms. Sutton's leadership. So if I can perhaps get Ms. Sutton to comment.
Would be very interested. Thank you.
Okay, so we run an SBAT program, which Booman has just described, and currently we have 20. But the majority are doing either Cert 2, which is Aboriginal Health Studies, to then move on into become an Aboriginal health worker or an Aboriginal health practitioner. Now, 8 out of the 20 are Aboriginal, and we support them in that role over the 2 years. We offer assistance in nursing, and we've got quite a few Aboriginal nurses that are assistants in nursing, and they're currently undertaking studies externally with South Australia and campuses like Charles Sturt University that offer a fantastic external program, and we employ them as AINs, or we support them to undertake enrolled nursing because we have a TAFE here, and support them through that pathway and then undergraduate. We provide 2 Aboriginal cadetships that are supplied by Premier and Cabinet, and we actually have 2 students that are actually work with us in the school break and go to university in Adelaide through the school year. But they're paid a wage, an average wage, while they're at university, book studies and assistance with education. So there's quite a few different pathways into nursing, and we do have Aboriginal nurses.
So, Ms. Sutton, is there a target in terms of, and it's sort of the adjunct to the question I was asking Mr. Ages, is there an adjunct to the number of allied and health professionals that the health district is seeking to employ who are Aboriginal?
I'll take that on notice. I'll hand over to Umit.
If I can just add to that, certainly our board's view, which obviously we support, is that we want to match the actual overall number of Aboriginal employed in our service, 13%. In terms of how that breaks down, to be honest, we haven't really set targets within that, but I think it's a really good point. Although we have a view that we need to have Aboriginal health workers right across all disciplines, we haven't set targets as such, but I think something that I think for us to really consider.
Yeah, well, I think, Wes, did you want to ask in terms of?
I did, thank you. I just wanted to ask briefly, if you wouldn't mind, it's become a bit of a common theme during this inquiry, the issue of telehealth, and I just wanted to see if you had, in the short time we have available, some positive examples of how telehealth has actually provided support to the patients in the far west of the state, and how it may have made a difference in, for example, telestroke patients or the like.
I might actually ask Dr. Smart to take this question.
Thank you very much.
Thank you. We have a comprehensive program being developed. Some of it has also been ad hoc during the COVID time, purely because we didn't have all the subspecialists coming out, particularly the 17 specialists who couldn't visit us from Adelaide. and so they've been providing services here to our outpatients on a VC basis to try and keep up with their patients. So that was a less formal one. We have a number of formal projects going at the moment. One is the chronic respiratory diseases one, which is one where there's service provided by VC and monitoring provided by VC to the peripheral sites. There's the mental health service as well, which is provided, particularly around the drug and alcohol. So that's another service. We're in the process of developing, once again, or transferring literally from rural Adelaide to Sydney, the telestroke project. So we're still running that with Adelaide, but early next year, we'll be converting to the Sydney-based service, which will be providing us. We have the EICU project. We had an interim project during the COVID time, which we managed to get in place to support us. And that's 24/7 cover with our ICU, availability of a COVID physician 24/7, and MDT meetings and multidisciplinary team meetings and ward rounds, so to speak, on a daily basis. We're now formalising that in the project, which has been funded by the New South Wales Government, and we will have a formal comprehensive EICU program in place with the RPA. The official commencement date, in fact, our live date is the 14th of February next year. We actually anticipate we'll probably have that in at the beginning of February. And the model of care has been finished, the technology behind it's been sorted. We've now got to go to the sponsors' approvals, the CEO sponsors, and so on. So these are a number of the shall we say, fairly significant projects that we have. We're also working on, obviously, the formal delivery of outpatient services or ambulatory services, and that's not only people sitting here, specialists sitting here providing services out into the community, but it's also where there's some services where they can't visit or unable to visit or can only visit intermittently. Then we obviously provide. We look after the patients at this end, and they provide the service from wherever they come from. So there are a number of those projects going on as we speak at the present moment. We're also looking at other technology enablers as well to see if we can develop those, and we're looking at, for example, like Queensland has with their cardiac patients, real-time monitoring of cardiac patients, real-time monitoring of respiratory patients, etc., where, for example, if they get into trouble, we can contact them immediately and, if necessary, retrieve them. And bring them into Broken Hill and or take them to one of the peripheral sites where either RFDS, Miramar, and potentially in the future people like CHAC, the Camellia Aboriginal Health Service down south, will be able to obviously provide services on site as well.
Can I just add, in terms of perhaps, if I can just add the comments, obviously telehealth is not a new concept. It's been around for many, many years. And it's one of the key, I guess, platforms that rural communities have been using, remotely have been used for a long, long time. I think that's it is an adjunct and not a substitute. If I could just make that point clearly. Secondly, without it, we would be significantly curtailed in terms of meeting our goal of local access. If I can give you an example, you asked for an example. Imagine somebody who's actually, becoming acutely unwell in a very small community, and that happens quite regularly. I'm talking about from a mental health point of view. We don't have psychiatrists in small communities. Well, what we do have, we can provide the assessments through telehealth, through the screen. We can actually engage a psychiatrist straight away, do an assessment, and then retrieve that person. If that person requires inpatient treatment, we can then retrieve them quickly out of there through RFDS to one of our facilities. That really is just one example where we actually do use telehealth to, if you like, increase access. Without that, that person would be, have to be driven somewhere and not necessarily get the service that they require.
Look, thank you so much for that input, and thank you for providing some positive experience to the telehealth input into this inquiry, because we've seen quite a bit of negative commentary around it. But do believe that there are many positive aspects, and I thank you very much for providing that evidence to us today. Thank you, Chair.
Mr. Chair. Thank you. Just before we go, the Honourable Walt Secord just needs to clarify a matter that he raised in the question, so I'll defer to him to sort of raise what he wants to.
In my opening statement, Mr. Aegis, I referred to a number of cases. So what is the status of 18-year-old Alex Bray's case where he died of an infected toenail? The newborn baby Alani Clark who died.
Yeah, that's not a clarification of a point. This is a new line of inquiry. Each group has been given a designated period of time, and what we're going on to here is something really entirely new. And apart from anything else, it may well be something that can be put on notice, but I think otherwise the length of time that may be required to answer this will take us well and truly beyond what was proposed in terms of this.
Mr. Chair, may I respond?
Sure.
That when I was asking these questions in my block, the Honourable Trevor Khan took several points of order and did lengthy explanations which cut into my time. I was going to provide these examples and then ask a question which brings it together. I think I should be, and if they decide to take it on notice, that's fine, but I would still like to...
Just to try a little bit of latitude to draw this to a conclusion. I'm not quite sure how much further you're going to extend beyond those couple of examples that you've given. So I'll provide a little bit of latitude, but the fact is that if there's quite a long list, it will take a long time to answer.
Okay, I won't do that.
Let's see.
Okay, let's go back to what were called formerly sentinel cases, and I'll end at that. I would like to know, in the last financial year, and in 2017 to 2018, 2018 to 2019, 2019 to 2020, 20 to 21, and the current financial year, how many, now you gave them 4 classifications, but I think we can all agree what were formerly known as sentinel events, how many occurred at Broken Hill Hospital? And I'll leave it at that. Thank you for your time.
Thank you very much.
Thank you, Mr. Chair.
Thank you. Well, once again, thank you very much for making yourself available this afternoon. Obviously, you're all very busy in your important roles with respect to the Far West Local Health District. Appreciate the frankness of your comments and your responses this afternoon. There'll probably be some follow-up questions, which are questions on notice or supplementary questions, perhaps even those as well. But the committee secretariat, if it's agreeable, will liaise with you in regards to those, and there's a 21-day turnaround period for them. So once again, on behalf of the committee, thank you very much for coming along and participating remotely in our hearing this afternoon. Thank you very much.
Thank you.